Can you hear me? Good morning. Can you hear me? Hello, good morning. Can you hear me? Hello, good morning. No, I'm not. I'm just
Yeah, I know.
I'm just checking Zoom.
It's covered your face, so maybe another speaker.
Okay.
So today are we going to hold the comments till after the lecture?
Yes.
So we can make this go more quickly today?
Okay. Yes. Yes.
Do you want to do it at the end of the morning session and do it for those people? Or do you want to do it at the end of each lecture?
We can do anything.
I think we ought to hold it till we get to like the coffee break time
Yes.
and then do a quick Q&A.
Mm-hmm.
Because then you can get the presentations and move them faster.
Mm-hmm.
But the thing is, how do people get online?
You want me to use this instead of, I thought the speakers were using this too.
Because this will look nice with podium. Yes.
Oh my God.
Yes, I will be there today.
Thank you.
Yes, I am sharing.
And then I just press
Yes.
this. Okay. How do I go back to the title?
Okay. So
The-
I missed
oh,
it.
that way?
Did I?
There. That's it.
Okay, when I'm doing this, it's not coming. It will come like this.
Oh,
I
okay.
think.
And then,
So if you do like this first, then you can press it like
okay.
your title will come like this.
Should I start?
I'll do the intro.
Oh, okay.
Then you're more than welcome.
Okay.
Hand it over to you. Is the camera on here for the?
Yes, it's
All right, good morning to everyone. I hope you enjoyed your evening last night in Dubai. We're going to start with day 2 today of the conference. I'd like to extend a warm welcome to the participants, the speakers, and the delegates that are here with us in person and with us online. We're going to start the second day of the 10th World Nursing, Healthcare Management, and Patient Safety Conference. And our first speaker for the day is going to be Dr. Pasqua Spinelli from the US, and she'll be speaking with us today on non-suicidal self-injury. All right, thank you.
Isn't my name so beautiful? No one ever gets it right. Hi, my name is, everyone hear me? Yes?
yesterday it was making too much sound. Is it working?
I think so. No? Can you hear?
Okay, then you can.
Yeah, I mean, I blew on it. Hello? Can you hear me? Yeah. Hi, my name is Pasqua. I'm a psychiatric nurse practitioner in the United States. And today I'm going to speak about non-suicidal self-injury in adolescents, which is a global concern. As we all know, during the pandemic and after the pandemic, mental health is a big issue, and it's a pandemic in itself now. And it's affecting adolescents and adults and elderly in all countries. It's attacking everyone. So what is non-suicidal self-injury? It's a behavior characterized by deliberate destruction of body tissue in the absence of any intent to die. So this is deliberate self-harm without the intent. This is deliberate self-harm without the intent to want to end one's life. I think they could hear me.
Can you hear?
Can you hear me? Okay.
Hello. Please do that. Why did you?
So it's self-destruction of the body tissue in the absence of any intent to want to die. So it's an adolescent about self-harming themselves, again, without the intent to want to die or end their life. It's in the literature and in psychiatry, we call it many different things like non-suicidal intentional self-harm, non-fatal deliberate self-harm, or self-injurious behavior. Some of these pictures may be disturbing, so I'm okay if you cover your eyes or walk out briefly. The most common types of self-harm in every country is self-cutting, head banging, biting, scratching, burning, self-poisoning, self-strangulation, also doing injury to someone's wounds and preventing wounds to heal. If you see the female, she's participating in self-harm and strangling herself. You have a child there, headbanging. Also, the pill is overdosing. That's a form of self-harm too. So self-harm is an emotion regulating behavior. In adolescents, they have difficulty with coping, dealing with depression and anxiety. Adolescents report that after they cut or self-harm, that it helps them calm down. And I know it doesn't make sense to us, but I asked one of my adolescents, if the blood on your arms could speak, what would the words say? And she said, pain. Adolescents also do it to self-punish, to gain self-control. Some do it for attention, and some also do it because the peer group is doing it, so they want to fit in with the peers. Oops. So self-injury, as I'm going to talk about some studies in other countries, you see it everywhere. It doesn't matter your race or how wealthy you are, what religion you are, what culture you are. It's seen everywhere. Internet, movies, songs, social media, that's such a big thing with adolescents. And adolescents utilize self-harm after they saw a friend self-harm or they were exposed to it on social media. On Instagram, there are actually adolescents that self-harm and teach other adolescents how to do it and where to cut so parents can't see it. So it's out there in the internet. This is data from 119 countries, United States, Canada, New Zealand, Europe, Asia, and the Middle East, including them. The prevalence of self-harm is very high in adolescents, 17%. Self-harm is an increasing trend globally. So the studies that I reviewed from different countries, some are very similar, but then some are very different and shocking. From the United States, the largest study of the US population, 12 to 23% started cutting in adolescence. Children in the United States as young as 11 years old engaged in self-harm. Initial acts of self-harm start between ages 11 to 15, with a 75% engaged in recurrent episodes. So that's like very significant. A study in Pakistan saw that there's an increasing trend of self-harm with married women. In Taiwan, the study was with adolescents, and this study showed that adolescents had a history of mental illness, depression, that engaged in self-harm. A study in Australia, significant, 57% of adolescents reported self-harm or overdosing, and that study, those adolescents had a history of depression. Jordan, a huge study, 11 to 19 years old. This study was different compared to the United States. In the United States, we see more females engaging in self-harm. In Jordan, more males than females engaged in self-harm compared to North America. Serbia, again, the most common form of self-harm was cutting in the age range of 13 to 18 years old. China, large study. They studied students from as young as 12 years old to 24, and they reported engaging in self-harm. Turkey, higher lifetime prevalence of self-harm in Turkey compared to China. And it was equally distributed among males and females. England, again, 1% of self-harm cases resulted in death. And this is what we see, accidental deaths, because the intention is not to end their life, it's to self-harm, to deal with the negative thoughts and pain. Mexico, the study in self-harm was higher in females. India, 30 children, 11 to 13 years old. Most common form, this is sad, most common form of self-harm is rat poison, ingesting rat poison. And 52% had a history of depression. Saudi Arabia, another sad study. There were 5 cases of males ages 10 to 13 years old. 2 of the children passed away. They were self-strangling themselves as a form of self-harm. So 2 of the children passed away. And this study is significant too. It's different from other studies that none of these children had a history of mental illness. It was never reported. Australia, 10% of adolescents reporting harming themselves to their medical doctor, and Australia higher in females. So what are the risk factors? We're all from different professions, medicine, psychiatry here. The background, what you want to look for is background in child abuse, maltreatment, family hostility, and criticism. There's individual risk factors, someone who has difficulty coping or can't deal with anger or anxiety. Some studies that we talked about before, it's higher in females. Again, it doesn't matter race or ethnicity. We see it throughout. Sexual orientation, those adolescents who are confused or they discuss that, you know, if they're not biological, if they're biologically a female, but they feel like a male and they're struggling with that, we see high rates of self-harm in that population. But the connection with parents decreases the risk. If you have an open, supportive relationship with your parents, it decreases the risk significantly. Another risk factor is underlying mental illness, depression, anxiety, borderline. bipolar, eating disorders. Personal characteristics, what you'll see in the adolescent: low distress tolerance, depression, anxiety, being very impulsive, very critical of oneself. If your adolescent is isolating themselves, that's a concern also. If the adolescent is experiencing stressful life events. Bullying from peers, there was a study in China that children who have been bullied since a young age, the risk for self-harm is very significant, high. Media representation of glamorizing self-harm, like through the media or through movies, and internet addiction. Again, there was another study in China where adolescents who were addicted to video games had a higher risk of self-harm. Factors associated with decreased risk: strong social support, appropriate peer networks, a sense of connection with your family or parents, and religion, being spiritual. Making the diagnosis, there's several tools that you can see on the slide. Most of these scales are self-reports, and some of these are generated by the clinician. How this patient is going to present to you: they're going to report self-injury, and they always do it in specific areas that they can hide, like the arms, legs, wrists, and stomach. Like we said before, girls usually resort to cutting. Boys resort to hitting, burning, or headbanging. Negative, strong emotions, low tolerance for distress, a history of mental illness, and a history of emotional, physical abuse, or witnessing domestic violence or parental neglect. And here are some questions to establish a dialogue with your patient. Where on your body do you tend to injure yourself? You want to ask these questions when you're with your patient. What is your usual mood when you injure yourself? What types of situations make you want to injure yourself? This behavior seems to serve a purpose in your life. Can you tell me more about that? What do you see as the advantages and disadvantages of continuing this behavior? What would you need to help you change this behavior? How would your life be different without this behavior? Have you ever told anyone about your self-harming behaviors? Do you know anyone who could help you cope with this stress? Do you want to stop injuring yourself? Because some adolescents don't. The management is psychotherapy, where they learn how to manage their emotions, learn skills, learn coping skills, and problem-solving skills. The first line of therapy, which is very specific and it's in the literature that it works, is DBT therapy, and it teaches skills to help the patient tolerate distress, regulate emotions, and improve relationships with others. Another form of therapy is CBT, and it helps the adolescents learn and identify unhealthy negative beliefs and behaviors and replace them with adaptive ones. So the management strategy is, if this patient comes to you, you want to see if they need any medical assistance, like stitches, because sometimes they cut pretty deep. You want to engage them in therapy, possibly medications if needed to treat the underlying illness. And also, as a clinician, you want to see if they need to be hospitalized or they need to go to the ER. So for medications, there's not that much in the literature for medications used for self-harm for adolescents, but I'll tell you what we use in the United States and in other countries. The adult population is studied a lot with self-harm, and there's numerous medications used in the adult population, like the SSRIs, like Prozac, antidepressants, second generation antipsychotics, such as Abilify, also other antidepressants like Effexor. And naltrexone is, people, when they hear naltrexone, they hear about it being used in substance abuse, but we use it actually in the United States for adolescents who self-harm. So like I said, there's no randomized trials evaluating any psychopharmacology treatment in children. We use off-label medication, and it's been effective for us. And that's the end. Any questions? Thank you.
What we'd like to do, and I forgot to mention when I began, is please, we will do questions. If you will write those down, then what we will do is take all the questions. We'll review the questions when we break for the coffee break. Okay? That way we can keep our speakers on schedule and we can move a little faster today. All right, here's your, let me take this off.
Getting it from
Oh.
you.
Yeah, just write it down. There, you've got the notepads. No, she's giving us. Thank you.
Thanks so much.
Thank you so much. That was great. Yeah, rather than this. This is great for lecture. Fix myself? I'd like, it's not on. I'd like to thank Dr. Spinelli for an excellent lecture. And it's a well-needed topic to be discussed. So thank you very much for that. The next speaker we're going to have this morning is going to be Dr. Amir Hamad, who will be speaking. She's from Egypt, and she will be speaking on patient safety in healthcare.
This one? Yeah. Okay. Sorry. No. Actually, yes, please. You can paste this one. So, put the paste. Yes, so it's like this. Okay, thank you. I hope it's on.
Okay, hello everyone. I'm Dr. Amir Hamid, Senior Quality Specialist at Cleopatra Group Hospital. I am from Egypt. Today we will talk about patient safety in healthcare, that definition, evolution, and impact. I want to choose the slide. I want the whole screen to be the slide.
Zoom is not, it will not record it, so you need to present like this.
Okay. Yes. Okay. The outlines of our talk today is what is patient safety, the history of patient safety, the burden of harm for not applying patient safety in healthcare, financial and harm on the patient. Also, investing in patient safety will offer a good return. We will talk about international patient safety goals, how to implement patient safety in healthcare, the steps for patient safety culture, and the tips for improvement of patient safety.
Press F5.
No, actually, recording is not going in. Zoom is having some problems, so you can always do this. Yes, I will be there. If you want, I can play your slides.
So we need to know what is patient safety. Patient safety is the healthcare discipline that is emerged with the evolving complexity in healthcare system and the resulting rise of patient harm in healthcare facilities. It aims to prevent and reduce risk, errors, and harm that occur to patients during provision of healthcare. Also, it is fundamental for delivering quality essential health service. Indeed, there is a clear consensus that quality health service across the world should be effective, safe, and people-centered. Also, in addition to realize the benefits of quality in healthcare, the health service must be timely, equitable, integrated, and efficient. So, to talk about the patient safety and the history of the patient safety, we must know a brief on the father of patient safety. It is here, as we show, the father of patient safety is Dr. Lucien Leap. He is the physician father of the patient safety movement in the United States, following a successful career as a pediatric surgeon and professor and chairman of pediatric surgery at Tufts Medical School. Dr. Leap has been a major leader for more than 3 decades in health policy, specialty, system theory applied to healthcare, medical alerts, and patient safety. He was the co-author of Harvard Medical Practice Study in 1991 that led to the Institute of Medicine report, "To Err is Human," in 1999, which was a shocking report, and was a member of an Institute of Medicine committee that wrote the report and also its next report, Crossing the Quality Chasm, in 2001. In 1994, he published a significant paper in the Journal of the American Medical Association entitled Error in Medicine, in which they use the word used error to describe the numerous treatment injuries to patients. So, to talk about the history of patient safety, the concept that patients could be harmed while receiving the medical care has been known for the thousands of years, since Hippocrates coined the phrase first, "do no harm." The terms iatrogenesis still used today to indicate harm experienced by physicians. Although the idea of medical mistakes has been long known, the modern literature began a famous 1956 New England Journal of Medicine paper discussing the disease of medical progress. In 1994, publication of the seminal commentary, Error in Medicine by Dr. Lucien Leap, highlighted the issue and presented a framework for error and analysis and prevention that is still used today. In 1999, it was a shocking report that was by Institute of Medicine, "To Err is Human," famously estimated that 44,000 to 98,000 Americans die each year due to preventable harm. Most consider its publication to present the beginning of the modern patient safety movement. This report was shocking, as no one can imagine that it will be harm from the treatment, not the disease. In 2003, Joint Commission on Accreditation of Healthcare Organizations, JCAHO, developed the National Patient Safety Goals And the international patient safety goals were developed in 2006 by the Joint Commission International. And these goals were adopted from the GCHO National Patient Safety Goals. So we have to talk now about the unsafe care burden. The unsafe care continues to anchor a substantial burden on individuals' health system and societies. This was according to WHO reports published on 2019. Although, as we saw in a patient safety in a serious global public health concern, there is 1 million chance for a person being harmed while traveling by a plane. In comparison, there is 1 in 300 chance of patients being harmed during healthcare. Otherwise, industries where perceived high risk, such as aviation and nuclear industries, have a much better safety record than in healthcare. And what is shocking, the occurrence of adverse event due to unsafe care is likely one of the 10 leading causes of death and disability in the world. It is estimated that for 421 million hospitalizations in the world annually, approximately 42.7 million adverse events occur in patients during this hospitalization. Estimates show that in high-income countries, 1 in 10 patients is harmed while receiving hospital care. The harm can be caused by a range of incidents or adverse events, with nearly 50% of them being preventable. In a study on frequency and preventability of adverse events across 26 low and middle income countries, the rate of adverse event was around 8%, of which 83% could have been prevented, and 30% led to death. Approximately 2/3 of all adverse events occurs in the low and middle income countries. Also, unsafe medication. Unsafe medication practice and medication error are a leading cause of avoidable harm in healthcare system across the world globally. The cost associated by the medication errors has been estimated as 42 billion annually, not counting lost wages, productivity, or healthcare cost. Of every 100 hospitalized patients at any given time, 7 in high-income countries and 10 in low medical income countries will acquire a healthcare-associated infection, affecting hundreds of millions of patients worldwide each year. Each year, around 3.2 million patients are infected with healthcare-associated infection across the European Union, and a total of 37% of them die as a direct consequence. Although in a simple and low-cost infection prevention and control measures, such as appropriate hand hygiene, could reduce the frequency of healthcare-associated infection by about 50%. Just hand hygiene, appropriate hand hygiene. Unsafe surgical care procedure cause complication to 25% of the patient. Almost 7 million surgical patients suffer significant complication annually, 1 million of whom die during or immediately following the surgery. Globally, also the outpatient harm from the patient safety lack, as globally 4 in 10 patients are harmed in primary and outpatient healthcare. Up to 80% of the harm is preventable. The most detrimental errors are related to diagnosis, prescription, and the use of medicine. Medical exposure also to the radiation can cause hazard for both the patient and healthcare professional. Recent evidence shows that 15% of total hospital activity and expenditure in OECD, which is Organization of Economic Cooperation and Developing Countries, is a direct result of adverse event. It's estimated that the aggregate cost of harm in this country alone amounts of $1 trillion every year. This is a summary of listed studies on the burden and cost of patient harm. These studies talk about the harm and the financial loss. This is a collection of studies happen in different countries, and this show the harm result from it. As an example, Anand Out, it is a region in 12 states of the United States. Type of harm, 9 types of harm. The direct cost was 2.8 billion across the 12 states, county and VTE most costly in aggregate. So, investment in reducing patient safety incidents can lead to significant financial savings. not to mention patients' outcome. In the United States alone, focused safety improvement led to an estimate 28 billion in saving Medicare hospital between 2010 and 2015. Investing in patient safety offers good return, and reducing patient harm can lead to significant financial savings, and more importantly, patient outcome. In the following slide, we will show the table represent the current and forecast GWB and what GWB would be if harm were be eliminated. Can retard as an unsafe care retard the global economic growth by 0.73 per year. This would amount to over 29 trillion between 2015 and 2024. This is based on IMF data and projection. As we see the table, the estimated GWB will be totally 101 on 2024, and after eliminating the GWB, after eliminating the harm, it will be 108.42 billion. These graphs show the potential cumulative effect on GWB growth of eliminating harm between 2015 and 2024. As we show, we will start 2015 from 75, and it will raise to 101. But by eliminating the patient harm, it could be rise to 108, and this will save 29 trillion. This will increase the GWB by 29 trillion dollars. So, according to all that, both the WHO and Joint Commission have recently released information to bring awareness to the latest patient safety issues. Healthcare facilities are encouraged to implement new protocols that will address these concerns and ultimately improve patient care by reducing the preventable harm incidents. So the International Patient Safety Goals were developed, as we mentioned before, in 2006 by the Joint Commission International. Compliance with IPHGs has been monitored in JCI accredited hospitals since January 2006. The JCR recommend targeting solution tools to help hospitals to meet the IPHG standard. So let's talk about the International Patient Safety Goals. First of all, goal 1, to identify the patient correctly. We must be ensured that this is the patient that we are dealing with. We use 2 patient identifier, not including the patient room or location. Before administering medication, blood or blood products, before blood or other specimen for clinical testing, before providing treatment and procedure. And this all must be supported by policies and procedures. Goal number 2, to improve the effective communication between the healthcare staff. One example is the verbal order. Verbal order, we deal with it if the physician doesn't present for any urgent. The complete verbal and telephone order or test result is written down by the receiver of the order and must be read back by the receiver of the order and be converted by the individual who gave the order. Goal number 3, to improve the safety of high alert medication. Medication involved in high percentage of error, as we mentioned. Look-alike and sound-alike medication policies and procedures are developed to address identification, location, labeling, and storage of high alert medication. The policies and procedures are implemented. Concentrated or electrolytes should not be present in the inpatient care unless critically necessary, and they must be stored in patient care units clearly labeled and stored in manner that it is restricted areas. Goal number 4, as we mentioned before, the big harm from the unsafe surgery. We must use an instantly recognized mark for surgical site identification, and the patient must be involved in this surgical mark. And also we must use a checklist or other process to verify preoperatively and the correct site, correct procedure, correct patient, and that all the document and equipment needed are on hand, correct, and functioning. The full surgical team conduct and document a time-out procedure just before starting the surgical procedure. All these are supported for sure by policies and procedure. Goal number 5, to reduce the risk of healthcare-associated infection. The organization had to adopt currently published and generally accepted hand hygiene guidelines and should implement an effective hand hygiene program, and policies and procedures are developed to support continuous reduction of healthcare-associated infection. Goal number 6, to reduce the patient harm resulting from fall. Implement a process for initial assessment for fall risk and reassessment of patient when indicated by changed condition or medication, among others. So also measure must be implemented to reduce the fall risk for those assessed by risk, to be at risk for fall. And measures are monitored for results post successful fall injury reduction and any unintended related consequences. So here about how to implement approaching the patient safety within an organization requires a review in six key areas. Number 1, safe structure involve reviewing whether the facility are designed to promote safety, such as the right supplies. Have we a safe environment, including assessment of lighting, temperature, noise level? Have we safe equipment and technologies, including examination of labels, instruction, and safety features when use various devices? Safe process, including assessment whether redesign would improve safety by looking at same factors such as the complexity. The effect of people, example is the staff, include the attitude, motivation, health education, and training. The leadership culture, which is the most important from my point of view, can drive safety issue when there is a willingness to allocate appropriate resources. Okay, let's talk about 7 steps for patient safety culture. Number 1, build a safety culture. Create a culture that is open and fair. Lead and support your staff. Establish a clear and to be focused on patient safety throughout the organization. Number 3, integrate your risk management activity. Develop system and process to manage your risk and identify and assess things that could go wrong. Number 4, promote reporting. Ensure your staff can easily report incidents locally and nationally. Number 5, involve and communicate with patient and public. Develop ways to communicate openly with and listen to patient. Number 6, learn and share safety lessons. Encourage staff to use root cause analysis to learn how and why incidents happen. Number 7, implement solutions to prevent harm. Embed lessons through change to practice, process, or systems. Finally, there is a tips for improvement of patient safety. Constituent of patient safety committee. Develop clear policies and protocols for patient safety. Discuss regularly patient safety initiative within the hospital staff. Orientation hospital staff on patient safety. Encourage transparency in the regular desk review. Non-punitive reporting by staff. Review, monitor, and evaluate safety procedure regularly. So thank you so much. Thank you. Thank you.
Thank you.
so
Very
much.
nice.
Thank you. Good luck.
Yeah, great.
Thank you. Thank you.
Thank you so
Am I
much.
to have my class? I take mine.
Yes, please, you can.
Okay, thank you. Thank you so much.
Thank you. Great job. Great. Thank you, Dr. Amira, for a great job on this discussion this morning. Appreciate your time and efforts for this. Our next speaker for the morning is going to be Nuha Filfilan. And yes, she's from Saudi and she'll be speaking on infection prevention and control. I know we're going a little bit out of order, but we have had to move Dr. Kieran Greenberg She's from Israel. We will move her till after 10 o'clock for the next speaker. All right. So if Dr. Nuha can come and join us at the podium, please.
So your presentation. Send it to Ms. Amar this morning. Yes, we have. Anyone from there?
No, I wrote my name on it. No, for this presentation.
It's not there.
No.
Did you send it on mail as well?
No.
Okay, meanwhile, you can introduce yourself. Let me check there.
Yeah, sure. Okay. Hello, everyone. Okay. This is better so I can speak clearly. My name is Naha Filfilan. I'm a physician that graduated from Qura University, did my residency training program at the University of Calgary in Canada. Currently, I'm a lecturer at Taif University, and I work as an infection prevention control officer at the Medical Services Center. I'm very glad to be here with the elite because I feel like you guys have persevered the COVID-19 restrictions and came. So thank you for that. And thank you for inviting me as well to this interesting conference. Today's topic, I'm going to talk about our experience with infection prevention control program establishment at the medical center at Taif University. I'm not sure about the presentation, but I have a lot of pictures, so you guys won't be bored. Please, the presentation is essential for people to wake up.
Should be there. I download it from WhatsApp. I'm so sorry for this.
Meanwhile, like I tried to have this presentation as light as possible. I didn't speak, I didn't put a lot of scientific research because I wanted this to be as an example for you guys to consider application later on, because I noticed this is happening globally. It's not only in Saudi Arabia. I noticed that happening also in Canada where I practiced. I also practiced I was lucky to be able to practice in the US for a little bit. So I noticed the same. Yeah, so.
Here we have. Do you have it in pen drive?
What?
Your presentation?
I have it in my laptop if you want.
Okay, so bring it.
If you want to transfer it to the
Yes, yes. Dr. Noha, it's done. Yeah, it's done here as well.
Okay, that's perfect.
Yes, you need to present it like this only because Zoom is not working in full screen.
Oh, really?
Yes, so it's a recording.
Okay.
So you
No
can
worries.
just press this one.
Okay.
Yes.
Okay. So this is my picture, and I'm wearing the same jacket as you can see. I noticed this morning. I was like, I really love this one. Okay. Now because I have no other options, but I love it. Anyways, so I already spoke about my background, and this is just a code saying that safety doesn't happen by accident. So we need to work for it. We need to plan, we need to implement. The outline of today's lecture is I'm going to tell you a little bit of a story of why did I choose this topic, and then an overview on the culture of safety in infection prevention and control. I'm going to say IPC a lot because it's a little bit wordy to say infection prevention and control. Current IPC culture, importance of changing the IPC culture, and lastly, how to achieve this sustainable change. And this is where I'm going to mention our example. So what's the story? This is a picture of the Medical Services Center at our university. It's not a big center, but it has about 200 to 300 employees. Our client base is mostly university students and university employees. So we don't see a lot of people. Having said that, due to COVID-19, this year we have established a vaccination center around, I think, June, July of this year. And that has increased the number of clients we're seeing. And accordingly, because we're seeing a lot of people, the risk of transmitting infections that are associated with healthcare centers will be higher. Luckily, we didn't get any yet, but we would like to be proactive and start implementing this program before we get any cases. This is just background on how healthcare-associated infections are concerned in all countries. Yes, it is mostly about inpatients, but the same could be applied to outpatient care, which is our center. So when the number of patients has increased at our center, higher management, or like the general supervisor of the medical center, has recruited me to become an infection prevention control officer and establish this IPC program. Of course, it's an organized, it's not just like, oh, I need to prevent this, but it's mostly an organized effort. As you can see, there are a lot of things that are included in this program. And it takes time to implement all of that. And the first thing that I have faced, which is a normal thing, it's not just Taif universities everywhere. It's about resistance, how like, okay, we are as an IPC team, we wanted to change the practices, but people are like, why are you here? You're just putting so much work on us. So I felt like I'm the only person going upstream and everyone is like just doing what they want to do. Okay, so it's a little bit frustrating for me, but it's a very normal reaction. Everyone, even for me, if I was one of them, I would do the same. Like, why do I need to change? So here comes this like change management plan. It's a new concept in the medical field because it's mostly applied in business corporations, but in Saudi Arabia, I feel like the whole health system is going to through a transformation from like, governmental just service application type of organization into like a corporation kind of culture. So I felt it was helpful to apply the concepts of this change management to our practice. What I did, I was appointed as an IPC officer in August this year. So that was the kickoff. I collected the requirements. I met with a lot of people, stakeholders, upper management, employees, everyone who's interested, involved, and impacted, everyone. So I tried to get a baseline and do like a health need assessment of what is already there, what do we need, how do we move forward. October, November was more of developing and planning the program. And then currently in December, I'm testing the progress that has occurred during the past years and see what I can change further and kind of fit it and apply. For the future, I'm currently developing a training, educational and training curriculum for employees, for new recruitments, new people, students, and anyone that is involved with the healthcare services. And then hopefully, inshallah, I'm hoping that we could achieve like a permanent change in the future. Okay, so a little bit of a background on culture of safety and infection prevention and control. A small overview, systematic review was done in 2020. They have illustrated a positive relationship between safety culture, improvement of IPC processes, and concurrently or consequently decreasing hospital-acquired infections. So how can we define what safety culture is? In the past, it used to be like the avoidance and prevention of adverse outcomes. They were focused mostly on how to prevent this disease, how to prevent I think they have like certain diseases that we do surveillance on, and we try to follow up that. Did they decrease, increase? But nowadays, we are changing this into addressing not only the adverse outcomes, but also the beliefs, values, attitudes, and perceptions of behavior. So it's mostly a behavioral change, which is not an easy change. And also, this change will determine the organization's commitment to quality and patient safety. Okay, so the key principles of safety, there are 4 keys. The first one is acknowledgement. We know that providing healthcare is high risk in nature. We know we need to encourage the employees, encourage people, as well as the patients and customers as well, encourage them to collaborate to prevent the infection transmission. For myself, I feel the blame-free environment, I think, I didn't read any evidence or any research about it, but I think that having a blame-free environment is very essential. Because if you feel like you're watched, you're going to be punished, you will be like, I won't say it. I might not wash my hands, and I will be like, I don't want to tell anyone that I don't do it. But if we did, we were open about it, we talked about it, no blaming, I think the culture will improve. Organizational commitment is also key, is very important, because without the management and the whole organization buy-in, change will be harder. Okay, so currently, how does the IPC culture look like? This is a study, and this is also what I've noticed in my practice. They noticed that most of the healthcare workers, they have good basic knowledge about what an IPC is and what IPC practices are. Like in theory, they know how to wash their hands, they know for how long, etc. But is that leading to compliance? No. So in this systematic review, they found that despite having good knowledge in healthcare workers, the compliance with IPC practices was subpar. People did not practice IPC diligently, I can say. Like they do, but not as we are supposed to be. And I'm actually one of them, to be honest. Anyways, so we're working on this. Change is on the long run. So what we want to increase the compliance. So compliance, as we have seen from the systematic review, that knowledge is not enough. There are other factors. Just to name a few: education and training, experience, there are many more. There are also challenges in implementing a top-down IPC initiative. What is a top-down? Top-down is like the big boss comes and they're like, oh, we need an IPC program. Let's do it. And then we start. And then we expect people to follow. Is that necessarily going to happen? No, no. People have their own opinions. People have their own, and they're free. They're free to choose. We cannot force them to do what we want of them just because we're like in the higher positions. The new approach is to have IPC as a responsibility of all healthcare workers. We want everyone that is involved in the healthcare to feel responsible for saving their lives and saving others' lives by preventing this infection transmission. And also frontline staff adopting ownership. They should be proud of their practice. They should be proud that they're adhering to the practices of IPC, like they own this. It's not because they're forced to do it. Okay, so this is the other part of the get pricked by needles, etc. But in reality, it's for their own safety as well. It's not just for the patients, also for their own. So how do we introduce this idea into the culture of the whole organization and make it their own instead of us telling them that it is? So, as I said, cultural change. It's a culture. When everyone is doing it, we feel like, oh, this is just everyone. Who shouldn't do it? Like, we have to do it. It's just the normal. How do we achieve this change? Before we go there, I just want to talk a little bit about the significance of changing the culture. How is it, why is it important? Why do we want to do it? Why don't we just go with the status quo and we will be like, oh, we do IPC a little bit, just a little bit. We know how to do it. We don't have to change. Why do we have to change? So one of the studies that have noticed this, I think it's a literature review, they have noticed that the success of IPC program is impacted by the change in organizational culture. So when the organization is like this, everyone is like this. Even new people, when they come in, they see everyone is doing it, they feel like the peer pressure. They feel like they want to, they have to. For example, some hospitals in this study, they have studied a few hospitals. I think one of the hospitals was successful in implementing this program, but others wasn't. And that depended largely on the culture of the organization itself. Also in this study, they have noticed that there were some attempts to introduce high hygiene improvement initiatives. I think it was in Vienna, I don't remember, or Switzerland. Switzerland is the same as Vienna, right? Sorry, I'm very bad in geography. It was successful, but then in other countries like Nepal, it wasn't, it failed. So mainly it was about behavioral change, organizational structure change, like it goes back and forth. It's not just behavioral, it's not organization, it's both. For this literature review, although the review wasn't strongly conclusive, but they have noticed something. They have noticed that evidence suggesting that there is an association between culture and the rates of healthcare acquired infections or associated infections. For example, higher scores in the of the organizational culture, such as staff engagement. When the staff was engaged, they have noticed lower carbamazepine-resistant intrabacteria acquisition rates. And the same goes for SSIs, surgical site infections. Okay, so why do we want to change the culture? Because hopefully by the end, our goal, final goal, is to decrease the occurrence of healthcare associated infections. Okay, so this is my experience. How I didn't achieve it, but I'm hoping to, because I'm in the final stages right now. I want to achieve a sustainable change by applying Cotter's change model. What is Cotter's change model? Cotter is a guy, he's a professor actually. He's a professor at Harvard Business something college. And he is one of the renowned leaders in change. So he's been doing this for businesses, like changing the culture of the whole organization from an old one to a new one. And he has developed this change model that has 8 steps. Before we go to the steps, I just want to talk a little bit about organizational resistance. Sorry, I'm going back and forth. I'm just like throwing hints because I want you to be looking forward to what's next. So, and if you don't like that, just let me know. Organizational resistance is the tendency of an organization as a whole to resist change and want to maintain the status quo. And we already mentioned that. So one of the things that people have started, they have started by changing the habits of the healthcare workers. And this is what I noticed is the most common, is like, following the healthcare workers, mostly nurses, sorry, like, oh, you didn't do this, you didn't do that. And also like the biggest resistors are doctors actually. They're like, oh, I'm a doctor, you cannot order me. I don't transfer infections. I'm a god. Anyways. So it's a little bit hard for IPC officers to pursue doctors to change their habits, especially the older ones. They'll be like, oh, I've been doing this my whole life. I haven't transmitted any infection. Did you really? You don't know. So yeah. Especially surgeons. Sorry if there are any surgeons over here. Sorry. Anyways, so yes, going back to changing habits. So changing habits is just the tip of the iceberg. It's only here. It could be it could happen, but is it sustainable? Because there are a lot of hidden factors underneath that affect this. There are the skills, even if they want to change their habits, they don't know how to, they're not used to it, they need to be properly trained, they need the motivation, like why are we doing this? Why are we doing the extra work? Why are we paying more attention? And then the mindset, it's more of a belief, like inner beliefs and all that. And also, it should be part of their identity. Like, oh, I'm a healthcare worker, or I work at a hospital. Sometimes even not just healthcare workers, even people who work at administration, they're also, sometimes they come in contact with patients. Especially with COVID-19, like the risk is high. So how do we go through all of this? Is it an easy road? No, it's not. It takes years, but it's going there. We go up and down, but in the end, hopefully, inshallah, we will achieve that. So the model is an 8-step. The first one is increase the urgency. What does that mean? It means that we need people to feel that it is very, very important to have this change. It's instead of like us coming to them saying that this is important, you should do it. No, it should be the opposite way around. We should have people coming to us saying,
I need to protect myself. I need to protect my family. I need to protect my patients. So I want to have this program implemented in our organization. It's a little bit tricky because I feel this is mainly psychological. How do you affect people? How do you, like, we need to know the background context, like what are they, what they're doing, what are their values, and people are different. People have many reasons to do what they're doing. So we need to, that's why at the beginning, I met with mostly all of the people that are working at the center, because I wanted to know what their values are, how to affect or how to encourage them to change. And then the second step is to build a guiding team. So, okay, we have established that this is important, then who's gonna do it? Sometimes even if you know that this is important, this should happen, you keep complaining about it, but nobody's doing it. So we need to have someone to do it. That is where we have the IPC team. And then develop a vision. So the importance of developing a vision is having an end goal. I don't do it for no reason. I have a reason, and then I'm just heading there. I know what I'm doing. If I'm not heading there, I might have to change my tactics. I have to change my strategy. And then communicate for buying. Sometimes people have the best intentions. They have many wonderful programs created, but on paper, nobody knows about them. They're hidden in the drawer somewhere. We have got like a certificate of excellence for it, but then it's just hidden, and my effort is done. Like, it's not even distributed somewhere else. So I need to get a buy-in, communicate what I'm seeing, communicate what I want to do, like get everyone involved. By everyone, I mean literally everyone, not just management, not just everyone who's involved, and anyone who could help us as well with this change. And then step 5, empower action. What does that mean? I cannot ask someone to do it if I didn't teach them and like enable them to do it. Like, for example, I wanted someone to drink water, but I didn't give them the water. Like, how would they drink the water? Like, they have to have that power so they can do it. So in IPC, a good example is like, if I wanted them to wash their hands, I cannot expect them to bring their own alcohol rub with them, or like it has to be there everywhere for them, so it could be easier for them to just wash. And I have to fill it regularly. Like, what's the point if the dispenser is there but there is no alcohol rub? And there are many other examples. And then the next step is create short-term wins. For me, this works as a motivation as well. Like, okay, I'm doing something. I want others to feel that, oh, I achieved something by the practices, the change that I have done with my habits. I am influencing a good change. I am winning. And it's not a win for only higher management. It's a win for all, everyone who's involved. And also, don't let up. Don't let up, that means like, if we achieve this success, like we cannot just wait. We should pursue this and keep it. And then in the end, make a permanent change. Like it's more of like, I cannot say deleting the old habits, but like replacing old habits with new, healthier ones. And this is what we did in our organization. First of all, we have applied for an accreditation. After that, we built our team, the IPC team. There was only one person. Now we have a team working together. And also we have formed a multidisciplinary committee. By multidisciplinary, I mean not only healthcare workers, because in IPC, we need a lot of people involved from different specialties like environmental health, waste management, dental, sometimes even patient representatives, because we want to get the patient's perspective as well on what we are doing. And then the third step is developing a vision. We have adapted the Association of Professional in Infection Control and Epidemiology, which is a safer world through the prevention of infection. We communicated this to everyone. I did daily rounds, guided people. Like, I didn't do it as a police officer. It was like more of, oh, it would be better if you did this, because I didn't want to initiate this resistance. It's like, we're together, we're working together, let's do it. Instead of like me ordering them, oh, you have to do this and that. And then sometimes they were very good. They knew the practices, they asked me a lot of questions, and they gave me comments. Sometimes like there was some deficiencies in supply and all that, and they have given me feedback. So that was actually very helpful for me. And also empowering. So this is the next, for me, the next step is like, I'm currently developing a curriculum for education and training because I want to make them empowered, have the knowledge and skills to do this. And hopefully in a few months, we will be accredited by SIBAHE. So we need your prayers for this. And then in the end, the permanent change that we want this safe culture in IPC to be a normal culture in our organization. So yeah, I already said this. So my strategy, or our strategy, is to, it's a continuous process. It's not like me implementing this and then I leave. No, I did the planning, we did the implementation, everyone. And then we're currently in the process of evaluating to see the feedback. I have an airplane to catch. Can I have the questions now?
Yeah, you can.
Thank you. These are my contacts.
Do you have the microphone? I will make it quick.
Yeah. Because it's a link, that's why it's.
This hyperlink.
I know it's like
Or else you can read out.
Yeah, so it's basically my name, noha_filfilan@hotmail.com, and then my university email is nn.abdullah@tu.edu.sa.
I know we were gonna do the questions right before the coffee break, but because she needs to catch a plane, we're gonna go ahead and take the questions specific for her lecture at this time. Does anyone have a question for her?
Go ahead.
Can you move back to slide number 2 or 3, where you showed a curve? Okay, that's the one, the change curve.
This one?
Yes, ma'am.
Yep.
So this is a very interesting slide.
Yeah.
What I see is that, at the kick-off level, your performance versus motivation level was okay.
Mhm.
And then increased when you were defining your requirements.
Yeah.
But then when you came down to development and testing, there is a nosedive.
Yeah.
So my,
What's
I'm
the reason?
curious to know, what was it?
Mhm.
What were the factors, and how did you overcome that?
It's a very interesting question. I haven't even thought of it, but now I know why. Because
Something
at
like
the
a root
beginning,
cause analysis.
yeah, it's more of a motivational motivation, internal motivation. So, because I was new and I introduced myself as an IPC officer, so they'll be like, oh, I got involved with them to collect my requirements. So they were like, oh, we need to show this new person how good we are. I'm not saying that there was no practices, there was, and they were good at it, but it was a little bit, it needed more improvement. In the development plan, I was a little bit busy with the development, and I kind of slacked off my daily rounds. So I feel like this was one of the reasons, because it wasn't internal motivation, it was more of an external, because I was there, I was following up. So
Did you meet resistance to change at that stage?
not straight away, like not in front of me. They didn't, they were very welcoming and everything, but you know how sometimes, and I do it sometimes, like the passive aggressive kind of thing. It's like, yes, I'm gonna do it, but then, are you going to? You didn't. I didn't
And
see.
you
that.
were new to the institution, right?
Yes, not new, but kind of new, because
In that
I did my training abroad and then came back. So yeah.
Yeah, because sometimes you know what might happen is senior pros.
Mhm.
When you come in and then you start, telling them what to do, how to do, the resistance to change kicks in. That attitude.
Actually, the upper management was very, they were the kickers. They were the ones that told me to have this program. So I didn't have resistance from the upper management. It was more of a application, frontline. Yes.
It's usually the frontline workers with whom you would be working. They are the ones responsible for bringing that change.
That was, in our case, it's the opposite. Yeah.
They are, because they have been doing, like you said.
Especially because before the practice was different. Like when you don't have a lot of turnout of patients, like the risk is very low, and you don't feel that it is important. It is important, but it's not.
That later on that you can say that there's a lot of increase.
Mhm. That's what
training
we're
and
hoping
worldwide
for.
events.
Yeah.
So I think the intention is that the future
Inshallah.
plan,
Inshallah.
but as long as you engage them,
Yes.
because this is what from the cultural change model,
Mhm.
I implement that as well.
Oh, okay,
Plus
good,
the year,
good.
Yeah.
That's great.
Everyone. So what the beginning goes very hard actually to cover it. So that's what I'm saying that once you implement that, but make sure that you really engage them, because there will be a tough person.
Can you give me an example? Because probably I missed something.
Yeah, so for example, like they will say, no, we used to do that. Okay, fine, let's have a new model of that.
Mhm.
No, actually, this is not work with us. They should not refuse that. It will not be actually more like familiar with the staff. Let's have it try.
That's what so what I'm working on right now, it's a little bit a sneaky way, but what I'm doing is like trying to build a rapport with all the employees so they could understand me as a friend, not as
no, actually, my advice to you.
no,
be like a
not to
fox.
do. Okay. I am a fox, actually, my
Yeah.
personality.
Yeah, so that's gonna work. Actually.
Okay.
Like give them what they want,
Yes.
but in your way.
Okay.
So you assure that you implement your own project, but at the end you will actually reflect on the organization. It's not your personal
Yes.
project. At
Yeah.
The end.
Yeah.
At the
And I'm
end-
not gonna last there forever.
Exactly. So
Yeah.
you're gonna achieve the vision and value and target of the organization. So they wouldn't understand now, but later on they see that the percentage actually of the improvement, they will definitely be disappointed.
Ah, thank you for your input. It's very valuable.
One last question.
No, go ahead. This is very enriching, actually, to the
Do you
conversation.
include biomedical waste management system as part of this patient safety protocol? Yeah.
So we have a safety team, and I am part of their committee. I haven't done a lot in that committee yet, but we are in the current, like we are developing. There was some policies for safety in the past, but we're kind of updating that and making them more up to date for now. Yeah.
Okay, thank you.
You're welcome. And thank you for having me.
Thank you so much. Anyone else with any other questions? Dr. Nuha, we have your certificate for you.
Thank you.
I don't know what you want to do, where you can have this or that. This is your certificate. He's such a managing matches with me. It's only trying to get to you have an agenda. Ask them. Okay, this is the agenda. How do you see we're going to achieve it? Ask them. Okay, what is preventing you from being able to achieve it? And if you ask them and turn it on them, we need to do this. This is the new goals. So you tell me, help me understand how we can make this work together.
Thank you very much. That's very helpful. Thanks.
All right, thank you so much, Dr. Nuha. And I have safe flight this afternoon. Thank you for joining us. Our next speaker is going to be Dr. Karen Greenberg, and she's from Israel, and she'll be speaking to us today about depression, anxiety, and stress among pregnant women during COVID. So Dr. Karen, please come to the podium. Hi, thank you.
I see kids here. Yes, thanks. So is it? Do we have presentation? It's a PDF.
Yeah, I have PDF. PPT.
So we can have some just
I give it. I have my disc okay.
Oh, yes, you can.
Can I?
Yes.
Moment.
Because so presentation. Yeah, right. Yes. You can. Okay. This one. Data doesn't get this.
Must. And can I?
Yes.
Thank you. And thank you. Hello, everybody. Good morning. I'm Karen. I'm the head of nursing department in Rupin Academic Center. We belong to the Faculty of Social and Community Health Sciences. I'm a registered nurse also. And today I will present one of my studies, the highlights of the results of one of my studies, topic depression, anxiety, and stress among pregnant women during the COVID-19 outbreak. Okay.
while we know all that the COVID-19 outbreak, which started in Wuhan, it spread very quickly in a global level, and has created a huge global health crisis along the economic crisis and all other social crises, but a big health one. So during the outbreak of the pandemic, different groups of the population and also pregnant women were exposed to high level of psychological distress, such depression and anxiety and stress. And I wanted to check this psychological distress among this population during the COVID-19, because it was a new actually in the world. So we know that pregnant women and their fetuses represent a high-risk population during infection disease and outbreaks also. It's unclear whether the pandemic has caused much depression or anxiety among pregnant women, which may affect their mental health and the children's physical and psychological health. So the aim of my study was to examine the effect of the COVID-19 crisis on stress and anxiety and depression levels among pregnant women in Israel compared with non-pregnant women, because we don't have pre and post group, because the COVID just was an outbreak pandemic. So I tried to get some control group. So I took a non-pregnant women. This was a cross-sectional study, included 238 women, while 106 were pregnant women and 132 were non-pregnant women. The distribution of the women of the two groups according to the background variables was similar. And I used such a demographic questionnaire and also an anxiety, stress, and depression questionnaire by Lovenbod and Lovenbod from 1995. So I'll get to the highlights. Actually, I found significant differences, and we will see them in the figure in the next slides. But significant differences were found between the groups, pregnant and non-pregnant, in the levels of depression and anxiety, but not in stress. Okay, so it was a significant differences compared with the control groups. No significant differences were found between pregnant women and non-pregnant women in the stress levels. As I said, if we can see in this figure, we can see that in the severe and very severe levels, the anxiety levels were significant differences between the pregnant women, which in blue, and the non-pregnant women, which in orange. So it was a differences, a significant differences. So there is a high level of anxiety among the pregnant women, and it is significant. If we can, if we will look on the depression level, so this is distribution of the sample according to the degree of depression, and also here in the severe and in the very severe levels of depressions, we have significant differences among pregnant and non-pregnant women, while pregnant is on red and non-pregnant is on green. So we can see here, it was significant. So here it's also, while in the normal and the light levels, there's no differences were found. If we can conclude from this small study, because the sample was small and we have limitations here and we know it, but it was testing for the outbreaks, which was very fast spreading in the world. So we want to look also on this population, pregnant women, what's going on with them, because we know that all the population in the world also got any psychological stress, and it's differences between subgroups, we know it, but if we look on this population, so we conclude that it seems that pregnant women experience more depression and anxiety during the pandemic. We don't have, as I said, pre and post group to check the levels, but we have the control group that's non-pregnant women. And this study findings also highlights the importance of taking steps and set policies maybe to identify and recognize distress symptoms like anxiety and depression among pregnant women. And we as a multidisciplinary team, of course, the nurses and healthcare should plan and intervention programs in order to promote their mental health of pregnant women. And it's for sure for the COVID-19 outbreaks and the pandemic that it's still here, unfortunately. So this is the highlights of the study results. And I can answer questions if you have. Thank you so much.
Questions from any of the speakers this morning? Okay.
So thank you very much for such a stimulating talk. So I have two questions. One is that when you say that you had a control group, so I want to ask you, like, whether this control group was a 1:1 match, taking care of various other conforming.
Yeah, we look after matching on the background of the socio-demographic variables, and it was matching.
Okay.
Yeah.
And the second question is, like, you found that there was a statistically significant difference, you know. So can you, like, did you try to find out what were the reasons?
Well, actually, this is a very good question. We didn't look for the reasons in this study, but it's a very great comment. And I think the future studies will test it. So we should know the reasons and the factors in order to make a great and excellent intervention, an appropriate intervention in order to understand the factors. So it is a great idea for another study.
Thank you, Doctor.
Thank you so much.
Beautiful, great study. I was just wondering, during the COVID epidemic, were the rates of suicide in pregnant women or women in general at a high level?
The suicide? Well, actually, I didn't get this information, and I don't want to make an incorrect information, but I know that in all the population, the level of the suicide increased, unfortunately.
In the elderly?
In the elderly,
Okay.
yes, in the elderly, but I didn't check it, so I don't know. It's another idea for a new study. Yeah.
I mean, you're like 100% correct, because I recall in your country, due to the social isolation with the elderly, that was a big factor, that their families couldn't visit them. They were home alone, and they had no human contact. And of course, the elderly, they can't use FaceTime or any technology, so that was like a big impact. But you hit it on the nose, that's correct.
Yes, but it's connected to the his name, I don't know, I'm sorry. You talk about the factors. You have talked about the factors, and one of the factors is the social distance, I guess, because if other studies checked it on the whole population, I guess that it's had an influence on pregnant women also. So social distance and isolation, it's may be, according to the literature, to the new literature from 2020, one of the factors, and we might check it. In Israel, in the elderly group, it's coming up and rising. Important.
Are there any other questions? Thank you so much.
Thank you so much.
I appreciate your talk. It was excellent. I will give you the certificate. After we do the certificate presentation, we will break for a coffee break and return at 10:45, please. Thank you. Oh, we'll have a group photo after this as well. So let me do her presentation and the morning speakers. We can do a group photo. Okay, excellent, excellent work. Thank you. Thank you so much. It's a pleasure to meet you. Okay, can we gather all of the morning speakers? Everyone? Oh. I'm sorry, because we have new attendees this morning. I misspoke. We would love everyone to be involved in the photo this morning. So if anyone could come down to the front, please. We'll do a group photo and then we'll enjoy the refreshments outside. Thanks. Y'all want to come on down, guys? Let's do a quick photo so we can eat and drink. Yalla, quickly.
Thank you.
I need food.
I'll keep it here. No problem.
Yeah. Bye. Oh, lemons are slowly don't bite. Maybe they're a little bit. I'm hungry. So. He said she's showing us here. No, I agree. I like that. But she said that's here.
You are so good at hi. Thank you. Oh, you are also so thank you.
Yes, of course. Of course. Yeah.
Thank you. Can we put some chairs on here? We can put some.
Come join. Yalla. Afternoon, quick, before you get on the plane.
What are you flying?
Oh, you need to, yeah, well, you gotta hurry.
I cannot write my ears.
No, you'll have to, with your day, your morning, you are cutting it close.
Everyone is coming, right?
All right, let's go eat. Thank you, everyone. I appreciate you guys coming down.
Because Dr. Lin, she said regarding one point, I need to describe it. Not repeat. After this coffee break or another? After. I think I already informed you.
Okay, can I start?
Yes. Please ask everyone to come. I will come.
Okay,
Yes.
you will call them?
Yes.
Okay. Okay. Hi, everyone. I would like to welcome Mr. Sufyan Russia. He will tell us about the effect of ROI adaptation model guided education program on knowledge and practice regarding self-care management among patients with heart failure admitted in Sheikh Shahood Medical Center, Abu Dhabi. Welcome, Mr. Sufyan.
Yes, we need to do like that. Actually, problem is Zoom is not able to record the full screen. There is a problem, technical problem in Zoom.
All right, no problem. Hi, good morning. Thank you for being here and thank you for giving me the opportunity to share the findings of our research. So let me start by introducing myself. My name is Sufyan. I'm cardiac ICU nurse. I've been working in cardiology since 2012. I completed my master's degree in adult and gerontology nursing from Iraq University, and now I'm studying another master's degree in cardiovascular nursing. So let's just get started. So our research title was Effects of ROI Adaptation Model, Guided Education Program on Knowledge and Practice Regarding Self-Care Management Among Patients with Heart Failure. So as you know, that heart failure is a condition when the heart is unable to meet the metabolic demands of the body. It's a kind of pandemic, international pandemic, with more than 64.3 cases around the world. So obviously we have so many patients are suffering from heart failure. And also it's associated with huge financial burden, and the latest studies showing that we are spending more than $160 billion per year. Other report from the American Heart Association also showing or estimating the financial burden by around $5,000 per each case. So you can just multiply whatever we said right now by the number of cases that we have, then you get a clear idea about this. But this is not really the problem when dealing with heart failure. The real problem is the high mortality rates. So we have like a mortality rate that can range from 15 to 30% within the first 2 years of the first admission. These rates may increase within the years, and it's increasing within the years, and can reach 65.1% in 10 years interval. This is not just numbers. This is fact that people in cardiology know already. So if I can just recall patient that I was working with 8 years back or 5 years back, so I can see that most of them died already. So this is a major health issue. Well, the question that we can ask ourselves right now, do we have any solution for this? Can we do something for our patients? The answer is yes. So with the medical management, with advancing the medical management and pharmacological therapy, we have so many options. We are not limited to one option right now. So we have some new drugs. I can name sacubitril valsartan right now that we can use it, and it seems that's very effective, like in helping our patients. We have myosin activators also, which like novel drugs. We have other devices that we can use that really help our patients. But we need to clearly understand that without our patients being able to monitor their condition by themselves when they are at home, without them being able to act accordingly when they have any kind of deterioration. So most of the management or the intervention that we are giving will be less likely to be more effective or effective as we would like to have it. So this is why the most leading organization in cardiology, like the American Heart Association or the European Society of Cardiology, recommend to use self-care strategy as an effective pharmacological measure to prevent frequent readmission and improve the quality of care. Despite of all of this, 50% of our patients seems that they don't have clear understanding of heart failure management, and they have poor level of self-care. Well, what about UAE? The prevalence of heart failure in UAE is estimated to 1%. So that's a kind of consistent findings from like to other research from US or from Canada. But, you know, the prevalence of heart failure vary between 1% to 4%, without even talking about those patients that they are not going to healthcare because they have some kind of financial restrictions, or those people who are underdiagnosed. So far, we don't have any study that measures self-care in our population here in UAE. And this is what we try to do. We clearly understand that we can generalize or transfer other findings from other countries to UAE, but we need to be careful in doing this because our population here is very different. We have more young patients coming with ischemic heart disease, like I can say patients in their 20s and 30s. And we know that ischemic heart disease is one of the leading cause of heart failure. If we compare it to Canada or to Europe, that's quite different. So ischemic heart disease is quite common, like in people more than 50s in other countries. And here we are receiving patients with 30s. We have different ethnicity, different culture here that can influence self-care. So we need to be careful in this. Like in the conceptual work here, there is no study, internationally we can say, there is no study that evaluates the effects of Freud adaptation model guided theory on self-care, and nurses know well here. Whenever we are talking about self-care, we use Orange self-care theory or other new theories that has emerged in the last 10 years about natural adaptation model. So the conceptual work that has been done here, like took 1 year almost to do this. Well, what were our objectives? So first of all, we tried to categorize our patients, or to know how many patients they have good, adequate self-care or adequate knowledge about heart failure. And we were wondering if we give them education and intervention based on the SAFE theory, would this be effective? So this is what we were trying to do. It's like two parts of the study, one descriptive and the other one is empirical. This is the conceptual framework. It looks like a little complicated, little busy. Acute phase, maybe blood pressure will drop. Even the patients, maybe the patient will not know that, but so many processes will start there, like release of epinephrine or epinephrine. This is a kind of adaptation. So the body is trying to compensate to raise the blood pressure. So we started from the same principle, and we try to build education and intervention. I will not go further in this because it may take the whole morning speaking about the conceptual framework of the study. I will just go straight to how we did that, and they will take you step by step. So that was a quasi-experimental study, one group pre-test and post-test design. It was done in Sheikh Shahabut Medical City in Abu Dhabi, which is a tertiary hospital with more than 713 beds. The sample size was relatively small, which is only 30 patients that were recruited via convenient sampling. And obviously we include only patients who were willing to participate. We didn't put any restriction regarding gender, so females and males were like recruited. We spoke with our cardiologists, consultants, and experts. Then we set a cut-off of pro-BNP of 400, just to make sure that those patients who got admitted have a kind of fluid overload. And definitely we needed like official, medical diagnosis of heart failure. That was clearly mentioned in the patient file. We included also only patients who can read and write Arabic and English. Regarding our exclusion criteria, we excluded patients who has any psychiatric or cognitive impairments because we believe that maybe those patients will not be able to answer our questionnaires and to go through the process of assessing self-care. We excluded patients who were in any circulatory support, like people who are in inotropes, people who have the aortic, the IABP, the aortic balloon pump, intra-aortic balloon pump. And we exclude people who cannot do the basic self-care, like in terms of heart failure, like weighing themselves or recording their weights. So in the process, we did a literature review, then multiple interviews were going on with not only experts in cardiology and PhD nurses and professors in nursing, but also with our patients. We end up with developing 2 questionnaires, one knowledge questionnaire and second one is to assess self-care. So we set a cutoff of 75% to say if their level of knowledge is adequate or no, or if the self-care is adequate or no. So in the process, once we got the ethical approval, we started a pilot study that included 10 patients. Then we assessed, we just explored how our study would be feasible. Then we went through the process of consent validity and we calculated Greenberg alpha. We just made some comparison between the international tool and the tool that we have here. And when we started the actual study, we screened 75 patients and we end up with 30 patients for our final analysis. Well, after the admission and exactly within the first 48 hours, we contacted those patients. Then we collected the pretest data. Then immediately we started our intervention, which is based on the Roy adaptation model. Basically, we started by collecting the nursing history. Then we did physical assessments for our patients and the assessments of other adaptive mode. Because at the end, we are not dealing with the heart, we are dealing with the patient. So there are other aspects other than the biological aspect that we are focusing more. We try to identify what are the factors that can influence the knowledge and the self-care of those patients. Then we sit with our patients, we set educational goals, and we started educational session, which was 1-to-1, face-to-face educational session that lasted between 45 and 60 minutes. Then we waited until 1 week after the discharge, and we did the same. I mean, we collected the post-test data and we compared the two, like pre and post-test. So those are the demographic characteristics of our patients. Obviously, we had more males, more Muslim, and more Arab patients. And interestingly, most of our patients, they have limited financial, monthly income, and most of them didn't have like complete access to healthcare. So either they are self-pay or they have partial coverage, medical insurance. Regarding the clinical characteristics, you know that heart failure doesn't come in its own. So most of the time it's associated with other factors, other comorbidities, and this is what we had also. So 66% of our patients had diabetes, others had hypertension, and CKD and atrial fibrillation also was common among those patients. The distribution of clinical characteristic in regards of the ejection fraction was almost equal. So we had almost the same percentage of people with heart failure with reduced ejection fraction compared to people with heart failure with preserved ejection fraction. And we had more patients in the New York Heart Association classification of 2 and 3 rather than being in 1 and 4. So those are our final data. And if you can see on the left of the screen, the pretest data. So we started by having 16.7% only having adequate knowledge. So those patients only scored more than 75% in the questionnaire that we gave. After the intervention, that was like dramatic increase in the number of patients who had adequate knowledge as per our questionnaire, and it reached 93%. That's really amazing, and this is what we aimed for. However, despite the increase of self-care from 13% to 43%, we had more than half of our patients having inadequate self-care. And this is, if you just remember the previous presentation that was here, talking about how you can change behavior and self-care is a behavior. So most of the time, by targeting the knowledge in its own will not be enough. So in the next slide, we can see that many patients, they know that they need to stop smoking, but they are not stopping smoking. Many patients, they need to be active, but they are not doing so. And most surprising findings, it was one question there, and we asked our patients, all right, if you gain 1 or 2 kg in 2 consecutive days, what you will do? Most of our patients responded, I will take less calorie, I will eat less. Knowing it's not about eating food. You cannot like gain 2 kg in 1 week, I mean, in 2 days or 3 days, and even in 1 week, by eating more food. That's impossible. It has only one meaning, which is your body is accumulating more fluids. Either you are not taking your medication as it should be, or your heart is just decompensating. Most of our patients also were underscored in regards of self-care. And regarding the statistical significance, we used the PERT test to just compare. And the confidence interval was 95%, and we set a margin of error of 5%. So any results less than 0.05 was considered to be statistically significant, and we have clear significance here in terms of knowledge and practice. We tried also to see, is there any association between the demographic and clinical factors with knowledge and self-care? Actually, the only determinant was knowledge, and we didn't find any, like, self-care behavior and knowledge is not really associated with age or gender or ethnicity. We'll see what has been said in the international literature. Here in this slide, we try to explain our findings in terms of the international studies. And obviously, as I said, we had 86% of our patients with suboptimal self-care, which is quite surprising if you compare to international literature here. We can see that some studies in Ethiopia, Kenya, Iran, Lebanon, some others I didn't mention here in US, in Canada, everywhere, but nobody reached this 86%. How we can explain this? It's quite interesting that we didn't have any patient less than 30 years in our study. And there is one study here was done by Gabriel and his colleagues in 2020. And it's just suggesting that people aged between 18 and 27, they are more likely to have better self-care. So they were not included in our study. And obviously that may influence the end results. When our participants also, they were not involved in any one-to-one heart failure education previously. So that was the first time when we did this. And as I said before, 70% had limited coverage. And we know that patients, if they don't have financial access to healthcare, they will not go there unless if they have acute exacerbation of self-care. So either if they have pulmonary edema or other signs or symptoms that really bother them, only that time they will go to the emergency. And once they go to the hospital, they tend to be sick for 2 or 3 days before they recover, you know, the idea. The most important point here is the absence of advanced practitioner registered nurse scope of practice. So I cannot say what is there in other hospitals, but in my hospital, we are still developing this. And the most literature, like people they are linking the presence of nurse practitioner with the good outcome, including better self-care. So definitely we need to have this. And I did one search, like quick search in Abu Dhabi, and it's only existing in one hospital for now, and not in the hospital where I'm working. So we need to emphasize this. This is only the same limitation we know. It's mostly regarding the design. We had small sample size, but that was quasi-experimental study. It's not, and you know, it's not easy to do experimental study in here. And that was the first year. So we are we started on building larger studies. We are on the process on building larger studies, and we are working on some other literature review to just review what are the factors that can influence the self-care. We had non-probability sampling also, and we didn't have any control group. So we cannot really assess the true effects of our intervention. Of course, self-care here was reported and was not recorded. And I can clearly say that there is no study until now that recorded the self-care by observing those patients. So we don't have all the international literature or all the instruments that we have are self-reported. We have also time limitation, and we believe that because we excluded some patients who cannot read and write and patients who cannot speak other languages like Urdu, so maybe we missed some important information. So we are building in that, like by recruiting other team members who can speak those other language. And you know, the process of validating the tool also will take time. So we need people who really understand this, then going through the whole process, content validity and calculating the content validity and index and all those things. Doing our research without giving implication, in my opinion, is meaningless. So we need to see how this research can help, even with the small site that we have, but we believe that's really emphasize the importance of nurse-led education program in improving self-care among those patients. Well, it's also informed future education effort to reduce heart failure burden. This is also a practical guide in how nursing intervention can be very effective if it is channeled in the specific nursing context or if it is delimited by the nursing theories as well. This is also may encourage nurses to provide evidence-based practice by, we can say, yeah, you can adopt the Roy adaptation model, but you can like adopt other theories like RM self-care or whatever you are comfortable with. Education-wise, so we had a very comprehensive the intervention tool that can be used to teach nurses either in the BSN level or master level on how to apply nursing theories. And I found this very interesting because, you know, most of our students, they don't really make this link between the theory and the practice. They don't know how to go like from being this, from having this abstract thinking to make it practical in nursing intervention. And this is what we did here. So the protocol from here can be used. This is the first study that evaluates heart failure self-care behavior in UAE population. And as I say, we are considering this as a pilot study for now because we are building further studies based on the limitations and the recommendation from this one. This can provide opportunity to evaluate the effectiveness of nursing theory and just go to our recommendation directly. So what we recommend? We recommend nurses to use the right adaptation model or to design educational program in cardiology setting. And of course, we are nurses are one player of the team. So we need other people to be involved. At the end, it's about the patient. So we need our cardiologists to be involved. We need our dietitian, our social workers, our psychologists. And definitely we need nurse practitioners in this country, which is still missing. So the study here emphasized also another important point. And when we were doing the literature review, we found a huge gap in the conceptual thinking or the conceptual definition of self-care and adaptation. Self-care is well defined by its theory, adaptation is well defined, but there is no clear boundary between the two. So this is a call for all nurses who can do the concepts analysis. We need to come up with one paper to see like how those two concepts can be merged. And because heart failure is really complex, most of the time one theory will not contain the whole phenomenon. So maybe this is a start of new theory or like situation-specific theory for heart failure that will be merging the raw adaptation model with other theories. So this is what we are suggesting. At the end, just to summarize, this was an experimental study with one group pre-test and post-test. We had 30 patients and we found statistical significance in improving knowledge and self-care Despite of all of this, half of our patients remains like with suboptimal level of care. And this is highlighting the need of further intervention, like behavioral change intervention. So this is where we need our psychologists. This is where we need our psychiatrist, nurse practitioner in there. So this is the end of this presentation, and thank you.
You have breakouts.
If you have any questions, ask me.
Online. Okay. Can you connect us online? I would like to welcome Dr. Tariq Ali. He's from Egypt. He's a professor of internal medicine and senior consultant physician. He will tell us about the clinical considerations in the philosophy of patient-centered care. Thank you. Thank you, Dr. Tariq.
Hello, everybody. Is my voice clear? My voice is clear?
Yes. Yes, it is.
Everything's okay?
Yes.
Everything's, Dr. Amal, everything's okay? Hi. Hi. First of all, Bismillah ar-Rahman ar-Rahim. I'm presenting from Istanbul, so that everybody is informed about from where I present. Present from Istanbul, Turkey. First of all, good morning and hello, everybody, my friends and my colleagues and all participants in this respectful UCG conference today. Let me first introduce myself. I think most of the those who attend the UCG meetings, gathering meetings and conferences know me. I'm Professor Tariq Ali, formerly Professor of Internal Medicine and Endocrinology at Cairo University, Egypt. And I'm a senior consultant physician, internist and endocrinologist, medical expert and medical lawyer, and a researcher in philosophy in general, and with special interest in the philosophy of science and philosophy of medicine. This is myself in short. Let me go directly. I think my screen is clear. I can go directly straight to. Is it clear?
Professor Tariq, can you please share your presentation?
Yes, my presentation, I already shared it.
No, we can't see it.
Google Drive, I don't, document, screen.
Yeah, you need to click on share screen.
Now, okay.
Perfect.
Now clear?
Yeah, you need to go to your.
I will enlarge. Is it okay like this? Now, okay.
So.
Fine.
Can you please minimize your Zoom?
I minimized it. I was minimizing it, but you said it was minimized. I don't know. Now, I don't want it to escape from me because I don't have. If it escapes, it will be a problem. Yani clinical considerations. It's not clear.
Yeah, there is a black screen there.
Yes, it's okay. It's okay.
There is a minimize button. No, you don't have to do anything there. So just go.
I don't know where is the minimization button. This is the problem of, I know. I don't know what is this. Minimization.
Oh, actually, Zoom. This is coming. So I'm asking to minimize.
Oh, this one.
Yes.
So the projection is very small, so you
It was small already, but you told me that it's not clear, so I.
Now it was perfect. So can you please do it again? Yes.
It's okay.
Yes, please go to slide share mode.
Ready slide shared. Already slide shared.
Okay.
Yes. Oh my God.
Yes, please, you can start.
That's fine.
Yes. Quite.
Okay. So first of all, this is my appreciation to the Utilitarian Conferences Gathering. This is the logo of Cairo University, time honored. My university. This is the logo of Cairo University. This is the logo of Faculty of Medicine, Cairo University. Its famous name is Qasr Al-Aini. It's a very old medical school. It's the oldest medical school in the Middle East, in fact. This is, of course, the beautiful old Tutankhamun of the youngest king of old Egypt, famous. This is Nefertiti, one of the famous Egyptian queens, the beautiful Nefertiti. This is part of the nature of Egypt. Okay, let me go. First of all, I like to mention that I have nothing to disclose. There is no any commercial considerations in my presentation, and my presentation is absolutely scientific, and it involves and it expresses my points of views regarding our topic today, which is the clinical considerations in patient-centered care as a new concept in healthcare. So there is no commercial considerations. It is absolutely scientific, and it's all the presentation expresses my points of views regarding this topic. This is the framework of my presentation, or the outline of my presentation. I will first of all talk about definition of the patient-centered care, and then I will talk about, I've mentioned some basics and concepts in this issue, elements of patient-centered care, benefits of patient-centered care, values of patient-centered practice, examples and scope of patient-centered care in the healthcare system, the impact of patient-centered care on outcomes, and then I will speak about the, of course, the role of what we call augmented intelligence, or they call it more commonly artificial intelligence in the patient-centered care and new healthcare era. And then I will summarize my talk. Is my presentation clear? Is my voice clear?
Yes, it is.
Okay, fine. So first of all, let us talk about what is the basis of this concept. What's meant by patient-centered care? Actually, patient-centered care is a rather new concept in healthcare in general. And it is considered to be a transformation in the healthcare process affecting the healthcare practice. And of course, it is also a transformation in the process of clinical decision making. So it is a new concept in healthcare system, and a new a concept or a breakthrough or a new attitude in clinical management process and in the clinical decision making. It's envisioning a society in which all people have access to quality and affordable healthcare. And this concept of patient-centered care is applicable especially for people with chronic diseases and with chronic disabilities. But it is also applicable in acute medical conditions, in acute medicine, emergency medicine. And patient-centered care actually is a quality of personal, professional, and organizational relationships. this is the basis of the concept of patient-centered care. As I mentioned, the patient-centered care is a transformation in the healthcare process. What does it mean? What we mean by patient-centered care? It means that the person or the individual patient or the person or our customer in the healthcare facilities, in the relation between the healthcarer as a provider of healthcare and a patient as a consumer of healthcare, it is rather an innovation. It is rather an innovation. It's not just a concept in healthcare practice. It is an innovation. It is a new mindset in the healthcare process. And we can summarize all our mini lecture or presentation today as it is an innovation in healthcare process. It is a range of clinical pathway offerings and operational solutions which is customized to patients' needs and personal values. And this is actually the most important, that it is tailoring our healthcare process and tailoring our clinical decision in the clinical management process to the patient's needs and the personal values. This is very key words in our presentation: the patient's needs, the patient's values, the patient's opinions, the patient's preferences, and the patient's culture, and change the management of the whole healthcare process, as I mentioned. And it is a transformation. It's transformation from what to what. In fact, it is a transformation from the physician being the one dominant in the healthcare process in taking the clinical decision and in guiding the healthcare process to, from one side to the side of the patient. That's why it's called patient-centered. It is not anymore physician-centered as it was in the past. The physician having the upper hand, the physician having the positive arm of the healthcare process or of the clinical management. No, it is now directed to or given to the play yard of the patient, as we say, so that it is called patient-centered. It is not anymore physician-centered, it is patient-centered. But of course, it is guided by the physician and by the health carer, whether it is a physician or nurse or any paramedical or medical element in the management process or in the clinical management process, to the patient as being the one taking the upper hand in guiding the clinical decision related to his condition or to his health status. So it is a range of clinical pathway, as I mentioned, offerings, and it will change. Using this concept in clinical practice and in healthcare will change the management of the healthcare process as a whole. And it is a digital expertise, and it needs a digital expertise requirements that enables the optimal execution of this concept as an innovation. It is an innovation by its mean. And by the way, innovation includes, in philosophy, includes or in the process of mental thinking, includes imagination. زي ما بنقول أن الإبداع نوع من الخيال والخيال ملك للجميع. So in الإبداع اللي هو innovation is a part of imagination, and imagination takes thinking as the most important mental process to everywhere. As Einstein said that imagination takes you everywhere, but knowledge takes you from A to Z only. But imagination can take you everywhere. And that's why imagination is the basis of what is called divergent thinking as a mental process. Divergent thinking كنوع من التفكير بنسميه divergent thinking أو lateral thinking, which depends on both knowledge and imagination. The thinking as a mental process doesn't only depend on knowledge and logic and the science which we have got, for example, in medical school, basic sciences and clinical sciences. This is knowledge. This is medical knowledge. No, the physician and the health carer should have also what we call the power of imagination. And without imagination, you cannot have innovation. Same like if you don't have facts, you don't have truth. And if you don't have truth, you don't have trust. So this is the role of what we call innovation, imagination in innovation. And innovation is the basis of thinking in patient-centered care as a new concept. This is very important to remember. And the motive here is that the healthcare requires a new way of thinking, imagination, and as I mentioned, this is linked to thinking, or what we call clinical thinking and the clinical reasoning as a part of the clinical decision making. And now, what is the role of the patient in this issue of patient-centered care? As I mentioned, it is a revolution, يعني ثورة in clinical practice. It is a revolution. It is a breakthrough. It is a new diversion in the healthcare process, which affects the whole healthcare system in general and affects the health provider as a provider of the care to our consumer, which is the patient and the patient family and the patient's friends. So the revolution, so the patient-centered care is a revolution actually in treatment and the choosing the best therapeutic options which the patient need in every stage of the natural history of his disease. In cases of chronic disease, which always have what we call natural history of the disease, passing from a phase to a phase or from a stage to a stage of the disease. At every phase or at every stage, how does the patient can share in taking the clinical decision and in guiding the healthcare process? This is the core of the patient-centered care. The physician or the healthcarer in general is no more the dominant and no more the single active, as I mentioned here. It's no more the only active authority in this regards. It shifted to the patient and to his family to be at the center of the triangle of the healthcare, which is the patient, clinician. The patient is the consumer, the clinician is the healthcarer, and the healthcare system as a whole, as an authority in any city, in any country, in any place. This is called the triangle of the healthcare provision. The patient, or what we call, we can say consumer, provider, the authority. Consumer, provider, authority is the patient, the clinician, and by clinician, I mean any healthcarer, whether it is a physician, whether it is a nurse, whether it is other paramedic, maybe pharmacist, clinical pharmacist, maybe radiologist, etc. These are all called providers, healthcare providers or healthcarers. And then the patient will be in the center. It's no more the clinician or the healthcare provider will be in the center. He is only a guide, as I will mention now. This development requires that all healthcare providers should develop their listening and communication skills and improve these more and address the patient needs effectively. And they should strive to provide care that is both effective and safe to each individual or to each patient. Then we come to what we call shifting from the physician dominant role to the patient-centeredness. And this is the a core address or a core issue in my presentation. How is the shifting from being a physician-dominant healthcare process or what we call clinical management? Because this patient-centered care is a concept which is applied in relation to what's called the problem-oriented approach to diagnosis and treatment. Problem-oriented approach to diagnosis and treatment, and also to what's called the diagnosis-oriented or symptom-oriented approach to diagnosis, to clinical management. Whether it is problem-oriented, diagnosis-oriented, symptom-oriented, the patient will have the positive role. And this is what we call the patient-centeredness in the healthcare process. Then we come to definition and the confusion about patient-centered. I mentioned is providing care that is respectful. This is very important, of and responsive to individual patient preferences, needs, and values. And this is very important, that we will tailor our decision according to these three, which I put it in capital letters, to the patient's preferences, to the patient's needs, to the patient's values, and to the patient's culture, ensuring that the patient's values and experiences guide all clinical decisions. And this approach in care requires a true partnership, which I mentioned before, between the consumer, that is the individual patient, and the healthcare providers, whether it is a doctor, a physician, surgeon, nurse, radiologist, clinical pharmacist. These are called, or it is putting, it is a partnership. It represents a partnership. This partnership actually has a framework of regulations, we can say law, قانون يحكمها, which govern it. That's why the patient-centered care has what we call legal implications. لها انعكاسات قانونية. It has a legal implications. Legal implications because it is a partnership, and anything which has a relationship or a partnership is guided by a legal framework. That's why there is legal implications of the concept of patient-centered care in the healthcare system. Advantages, and this is very important, and more important also to mention that it has its shortcomings, or it has its faults, or it has its disadvantages, which all the two sides of the relationship or the partner what's the reality of the concept of patient-centered care? It is a good idea, of course, as I mentioned, and it is a nice innovation. I mentioned this also just a few minutes before. And it is an attractive concept which deserves its consideration and implementation in clinical practice, and to be adopted by healthcare authorities anywhere and everywhere. And as a transformation in the healthcare process, but it has its limits. On the other hand, and here many conditions should be fulfilled to minimize its disadvantages and to decrease its problems and its problematic consequences and its legal implications, which might the of the clinical decision, number one, and number two, which is the we can say it also as a primary end outcome, not a secondary. It's same like reaching the that is the secret behind being looking fantastic and attractive move in the healthcare process. As I mentioned, it looks attractive, it looks fantastic, but we should not only look at the concept as a concept, we should know how to apply it. And in order to know how to apply it and how to reach its results and purposes, we should understand it and we should comprehend it. All parties, health carers and patients. Elements of the effective patient-centered care plans. Here we mentioned that the health system mission, vision, values, leadership, and the quality improvement drivers should be aligned to the patient-centered goals. I mentioned this. The mission of the healthcare system in this country, in this city, in this place should be aligned to the patient-centered goals. If the health system not tailored to be aligned to the patient-centered care or the patient-centered goals or patient-centeredness, it's no more patient-centered care. No more. Care is collaborative, it is coordinated and accessible, so the right care is provided at the right time, in the right place, and for the right patient. This is the purpose. Very important. And here the patient-centered care focuses on both not only the physical outcome of the patient, it focuses on three important things: on the physical outcome or the physical well-being. That's no more physical manifestations, physical problems, physical complaints, pain, headache, vomiting, fever, whatever the complaint of the patient, whatever the disease, whatever the cause, there is improvement of the physical status, there is improvement in the emotional or the mental status, being an important part of what's meant by health in general, physical, mental, social. So physical well-being improve, emotional well-being improve, and more importantly, what we call psychosocial well-being improve, and the psychosocial outcome improve, and the patient physically, emotionally, and psychosocially better. This is our purpose in improving the decision, improving the individual health outcome, and reaching the patient to a status of physical, emotional, psychosexual, psychosocial relief. And then we have what we call the importance of the patient and family preferences and values, which I mentioned, which should be respected, and we should focus on it in order to functions and the patient is unconscious or if the patient has a mental problem, dementia, or in coma, or mentally confused, they cannot take decision, so we share the family. We share, if there is no family, the friends or the bystanders in the streets. So it is very important to mention this, the patient and the family, what are their preferences, but it is more easily applied in chronic cases. That's why I mentioned it is applied, number one, in patients with chronic diseases, with long history, because also patients with chronic diseases are running through a natural long journey, not just an acute situation or acute medical condition, which might improve and the patient after that is okay, no problem at all. So it's different from chronic medical disorders to acute medical disorders, and then the mix between the two, what we call acute on chronic medical disorders or medical situations or clinical situations, like acute on chronic renal failure, acute on chronic liver cell failure, acute on chronic heart failure, diabetes mellitus in emergency with diabetic ketoacidosis or with hypoglycemic coma. This is acute problem in a patient with an underlying chronic disease. But this has many, many details. I will not enter into these details now. I'm just focusing on the concept of patient, what's meant by patient-centered care in clinical practice. The patients and their families are expected, I mentioned this, as a core part of the care team with the clinician and the health authority, and they play an active role in decision-making at the patient and at the system levels, at the patient level and at the healthcare system in general level. The presence of family members in the care setting is encouraged and facilitated. Information here is important, and this is the role of the physician. The physician or the health carer, physician, nurse, or clinical pharmacist should give information. So here, the role of the health carer is to guide the patient by giving him information and knowledge. This is very important, should be shared honestly and fully, and it's confirmed to be understood by the consumer or the individual patient, so that the individual patient and their family members can make timely, informed decisions. Based on informative, insightful thinking, as I mentioned, after giving him the adequate information and the adequate knowledge about his medical condition or disease, for example, diabetic, I should teach him about what's called diabetes education, hypertension education, epilepsy education, whatever the chronic medical condition, I should teach the patient and his family how to manage this, and when it happens, how you can behave like this, like that, in this situation, when you are in a holiday, when you are away from your physician. And by providing the information and knowledge, the patient can take, or his family can take, the proper decision based on this information at any time and in any place. This is in order to minimize incorrect or inefficient defective decisions done by the patient as much as we can. This is very important. If the patient is ignorant or has no information, he cannot decide, he or his family, about what to do. So here the condition which should be fulfilled is information given by the health carer to the patient. Right information, right knowledge, educate your patient, inform your patient. Thank you. The goal of the care approach is that to improve the individual health outcomes in addition to the population health outcome, as I mentioned. And here healthcare professionals also stand to benefit that through improved patient satisfaction scores, higher staff productivity and morale also. And lastly, there is a reduction in the overall care costs. And this is very important, what we call the goal of the patient-centered care approach. This is the goal of the patient-centered care approach. And the most important goal to improve the individual health outcome. And by improving the individual health outcome, there will be improvement consequently of the population health outcome as a whole. The basic principles of patient-centered care, I mentioned that collaborative working with patients, respecting their individuality and their rights to express their needs and to their values and to their preferences according to their cultural traditions and beliefs in the individual. We implement all of these in the individual patient decision. So respecting all of these ideas and all of these concepts in the patient-centered care, with the aim of developing strong, rational, fair therapeutic relationships and the best clinical decision, as I mentioned. So that at the same time, every patient will feel valued, will feel respectful, and will feel safe while being cared for. And his opinion is respected in the clinical decision and not ignored. And this is very important. After informing the patient, after teaching the patient, after educating, this I repeat it again, this is very important. So the patient should be informed, the patient should be smart, the patient should be educated in order to share well in the patient-centered care and to be playing the active role in the clinical decision.
Yeah, Dr. Tariq,
I mentioned
this is Dr. Tariq, this is Dr. Carlton here.
Yes.
I would like you to remind you of the time and
Yes,
I request you to kindly conclude your speech.
I will conclude, yes. Then I mentioned that the principles of person-centered care, that we have to treat people with dignity, compassion, and respect, and provide coordinated care, support, and treatment, and to offer personalized care and support and treatment, and to enable service users to develop their strengths and abilities so that they can live independently and fully. And so it focuses on the crucial aspect of care, fulfilling the patient's needs and beyond their disability. That's the needs of the patient, rather beyond their disability or their disease. The 8 core values of patient-centered care is individuality, rights, privacy, choice, independence, dignity, respect, and partnership. The 4 C's of the patient-centered care, as I mentioned here, in my opinion, increasing personal connection, and the healthcare consumer. And from the medical profession point of view, it might be sometimes difficult to apply in some communities, in some societies, in some places, in some countries. There is legal aspects and the implications of the patient-centered care process. I mentioned this. The legal aspects are so many. I have no time to explain it, but the application of the patient care has a business and legal aspects, which should be thoroughly understood for smooth, effective, fair practice, or there will be miscommunication between the two sides, and miscommunication will cause misunderstanding, and misunderstanding might raise the issue of medical errors or mistakes and complaints by patients against doctors and against health carers in general. Here I talk about the role of artificial intelligence, but I think I don't have too much time in talking about this issue in detail. But of course, the implementation of artificial intelligence, or more correctly, the augmented intelligence in the centeredness of patient-centered, very important. The factors healthcare leaders should consider to meet patient needs. There should be ease of access to the patient data, and this needs artificial intelligence and digital improvement. The patient digital experience is very important. The administrative efficiency of the healthcare authority and of the healthcare networking, the building the human connection, recognizing the importance of work culture, and of course the impact of COVID-19 in the era of COVID-19. There should be what we call bridging
Please
technology.
conclude, Dr. Tariq.
Yes, okay. This is the role of artificial intelligence is very complicated. The data, I explained it, and how to successfully improve the medical business with artificial intelligence in the concept of patient-centered care is very important. There are many challenges. This is summary and conclusion. It is a new attractive concept, as I mentioned at the beginning. The PCC, or the patient-centered care, need to be understood by both health carers and individual patients. PCC has its conditions, should be fulfilled, and has its limitations, and should not be considered generally and blindly without paying attention to the heart of the concept before its text. The PCC puts the patient and the healthcare providers at the front seat of learning and understanding its legal implications, very important, or they will be subject to legal problems. The PCC is a kind of investing in a patient education solution. The PCC is a transition in clinical practice from physician-dominant approach in clinical management and decision-making, I mentioned this, to patient-centeredness in this process. Thank you so much. And these take-home messages, always try to understand what is patient-centered care. Both sides, consumers and providers, and you should understand the philosophy of medicine. Medicine is a science of uncertainty and an art of probability. And the art of medicine is to put the patient under observation. And a good physician is a good observer. This is me, Tariq Ali. This is Amin Hatab, one of the famous.
Thank you very much, Dr. Tariq. If there are any questions, you can, ask them when we break for the lunch, or
I appreciate it.
write to Dr. Tariq.
Yes, thank you so much.
Okay, thank you very much, sir. Appreciate your discourse. So next we have Dr. Salwa Soliman. She's a lecturer at medicine faculty, and she'll be talking about digital healthcare. So let's give a big round of applause to Dr. Soliman.
Firstly, I'm Salwa Muhammad Ali Sulaiman. I'm a lecturer at Faculty of Medicine. I'm a manager. My topic is digital health. I think my topic is very interesting for everyone, not for doctors or nurses or any healthcare providers, but I think it's very vital today regarding pandemic coronavirus. So I will talk firstly, what is the objective, define meaning of digital healthcare, and mention what is digital healthcare include, and discuss how digital health contribute to solving the problem of the corona crisis. My outline, introduction, definitely, and define what is the meaning of digital healthcare, and then a digital health system, and we will know difference between modern and traditional healthcare, and what is the digital health include, and application of one example of them, especially telemedicine on coronavirus, and how digital health contribute to solving the problem of corona crisis, and what is the future of the digital healthcare. Definitely, I changed my all my presentation because yesterday my colleague Dr. Niveen discussed all of my point of view regarding this point, so I changed it. My introduction, the huge impact of the COVID-19 pandemic on global healthcare system has promoted search for novel tools to stem the tide. You know, everyone, you know this point, I think, yeah. Attention has turned to the digital health community to provide possible health solution in this time of unprecedented medical crisis to mitigate the impact of this pandemic. What is the definition of digital healthcare? According to World Health Organization, WHO, digital health, or the use of digital technologies for health, has become a salient field of practice for employing routine and innovative form of information and communication technology to address health needs. What is the digital health system? You should know what is the digital health system. Engage patient with their healthcare providers, making them co-designers of their care and treatment plan. That we should do today, and I think all governments do this already. The quick and direct and shared access to the current health status of the patient increase the sense of partnership for the patient and doctors, and trust and transparency between patient and doctors. The difference between traditional and modern health care following the digital health transformation. I will not know in detail in digital health transformation, but I need to ask anyone know what is the difference between all them? If anyone know? No one? Okay. Tradition medicine, I know, yesterday we have tradition medicine. It is very tradition, and now it's modern medicine. Point of care in clinic in tradition, regarding modern point of care in the patient. Patient who the one will search for caring, will search for the medication now, based on population, and modern based on individual. Tradition is hierarchy, and modern is partnership. This tradition, it's depend on a prescription and orders, especially from physicians. In modern collaborative, I think it's very nice, yani. Data owner by institution, data owned and shared by the patient, individual experience dominated, and modern limitless data analysis. You know this point yesterday in details, and physician and authority. On modern physician as guided. I will talk, I will explain this later on. And Ivory Tower on transition in modern social media. It's very important. Tradition, it's a very important point also. It's a very expensive, but modern calls the driving down by Moore's law. Digital health include what? Under this umbrella, digital health include what is the point? I will discuss every one of them. Number one, mobile health, mHealth apps, and then electronic health records, and then wearable device, and telehealth, especially telemedicine, and then personalized medicine. Number one, mobile health. It's a very famous now. Mobile health app or application program that offer health related service for any smartphone and tablet. Some apps are aimed at physicians themselves. Many apps combine mHealth with electronic medical records, allowing doctors to keep accurate records that are easily accessible. So regarding pandemic on coronavirus, this way facilitate for the physician everything. There are many varieties of health app available for purchase from app stores. Some are designed to help customers make health choices in their everyday life by offering advice about fitness or nutrition and so on. Number two, mHealth or electronic health record. It is the same as the photo. It's an electronic version of a patient medical history that is maintained by the provider over time and may include all of the key administrative clinical data relevant to the person care under the particular provider, including demographic, progress, note, problem, medication, and so on. An electronic record is information recorded by the computer that is produced or received in the initiation, conduct, or completion of an energy or individual activity. For example, of electronic record include email, all of us use this. Word process, document, and electronic spreadsheet, digital image, and database. EHR include information like your age, gender, ethnicity, health history, medicine, allergist, immunization status, lab test results, hospital discharge instruction, and pills information. If one doctor order a lab test, they all see the results. EMR or EHR. What is the difference between of them? It's a best EMR. It's a best understood as a digital version of a patient chart. It contains a patient medical and treatment history from one practice. EHR contains the patient records, okay, from multiple doctors and provide a more holistic and long-term view of the patient health. What is the benefits of electronic record? Number one, it will helping promote legible and complete documentation and accurate documentation also, and enhancing privacy and security of patient data, helping providers improving productivity and work-life balance. Number four, enabling providers to improve efficiency and meet their business goals. What is the three main types of health record? That is number one, electronic health record, e-prescribing, personal health record, and electronic dental record, and secure messaging. Wearable are electronic technology or device incorporated into items that can be comfortably worn on a body. These wearable devices are used for tracking information on a real time. They have motion sensors that takes a snapshot of your day-to-day activities. I will show you application on this, how to use the wearable with digital healthcare now, especially with artificial intelligence. What is the example for wearable devices? All these examples: smartwatch and Google glasses, and so on. What is the example for wearable device? Smart jewelry, that I mean before, such as rings, wristband, watches, and pens. Smaller device typically work in coordination with a smartphone app for display and interaction. Your Apple Watch and Fitbit are classic example of wearable technology, but developed today. Telehealth. What I mean of telehealth? Telehealth or telemedicine has a potential to bring healthcare within reach of more people. It enables care to be delivered quickly across distance and enable more healthcare professionals to deliver the right care to the right patient at the right time. It's very, very important today to make all of this with accurate process. Web technology can also help bring visitors into patient room using the ICU or iPads, those further reducing visitors regarding coronavirus. Now, it's very, very important. Telemedicine team in West are helping train physicians to rapidly screen COVID-19 cases using questionnaire and, if needed, triage them to designed area to avoid in-hospital clustering and minimize exposure. Developing of robotic telemedicine cards occupied with camera and interactive screen, and I will show you it's a role model for this, which can send into quarters patient area to assess patient those limit HCW exposure and risk. How do you do a telehealth visit? Number one, setting up your computer for telehealth appointment. Number two, view your video visit confirmation and download and install Zoom and audio video. View your video visit confirmation and join video visit like you do, Yani. Personalized medicine, it's amount tailoring treatment as individualized as the disease. The approach rails on identifying genetic, epigenomic, and clinical information that allows a breakthrough in our understanding of how person unique genomic portfolio makes them vulnerable to certain disease. What is the example for this? Include using target therapies to treat specific types of cancer cells, such as HER2 positive breast cancer cell, or using tumor markers testing that is used today to help diagnose cancer, also called precision medicine. What is the difference between personalized medicine and precision medicine? The difference here in the precision medicine seeks to create treatments that are applicable to a group of individuals who meet certain characteristics. This is different from personalized medicine, which implied individualized treatment available for every unique patient. Tele or electronic intensive care. I think some hospital will prepare some ICU like this. I hope to see this in the future in Egypt. This can allow HCWS to remotely monitoring up to 60 to 100 patients in ICU across multiple hospitals. In the USA, it's already more than 13 hospitals in 34 states are taking advantages of such e-ICU service using two-way cameras, videos monitoring, and microphone and smart alarms connected by high-speed data lines. Digital development help fight COVID-19 in Africa. This is my example for this. Some African government regarding coronavirus on the pandemic, how digital health helped them to control this pandemic. Use digital platform to launch COVID-19 information services and debunk misinformation. In South Africa, the National Health Development set up a WhatsApp service to provide information to local from symptom and prevention tips and testing information. Importantly, the service also dispel false claims about cures that is spread in the pandemic, at the time of the pandemic, from eating garlic and beetroot to taking hot water baths and sensitize to scammers looking to take advantage of people's fears. In Nigeria, health authors partners with Facebook to send batch notification to users with information on symptoms and how to avoid infection, and with Twitter to elevate medical information from authoritative sources. 1/5 of African adults use mobile cash service. It's very nice for him in this time. In Kenya, Safaricom, the country's largest telecom company, implemented the fee waiver of East African loading mobile money product in Giza to reduce the physician exchange of currency. The move of following the directive by President Uhuru to explore way of depending mobile money usages to reduce the risk of spreading the virus through the physician handling of cash. And also this, the world will increasingly really, finally, the world will increasingly really on digital technology to help us weather to the COVID-19 storm. Digital platform help build more resilient society to the pandemic, as people can now access official information, enroll in e-courses, take online jobs, send mobile money, and even receive telemedicine no matter where they live. And this is my application. In Egypt, especially at Skill Lab, we have the first patient communication mannequin and already apply this digital health or artificial intelligence for all students in Faculty of Medicine and Faculty of Nursing, all faculties science. Which one? And this robot, what is the importance for this robot? This robot can facilitate for the student to make good communication with the patient and take patient history and make good vital data interpretation. This robot has a tablet, can connect Alex from tablet, iPad, iPhone, smartphone and mobile, connected is very easily. So
it's your project.
No, it's already done.
Yes, which one?
It's already done, and this robot is already inside Egypt. First contact with Egypt at Galal University. We already train all students on this robot, and let the student take vital communication with robot as a real situation. Robot has a lot of scenarios, around 1,050 scenarios. Scenarios for cardiac, respiratory, even coronavirus scenarios. When I attach Alex, I will show you video. When I attach Alex just only with internet, with my mobile, I attach him with my mobile here in Dubai. I can attach him in Egypt. How? I will attach him with internet, and then I will open application for Alex. It's connected with cloud. Will give me data according to the scenarios I choose it, like chest pain scenarios, and then vital data for the patient will be on the screen of me. I will show you this, and then Alex will have respiration, chest rising, can take pulses, blood pressure, IV sampling, cannulation, all investigation we need. You can take it from Alex as a patient, as a real situation. And also, Alex has a camera on the right eye, can save this conversation or share conversation with manager, with student, and save all conversation with Alex as a patient and the student and teacher. No need for instructor in this time. I can connect Alex and I can take my mobile or my iPad tablet in another area, and I can change anything on Alex from my room, and my patient like Alex and student in the room, and this conversation is saved already for me for accuracy and for the patient, for the student also. This first one? Yeah. And Alex speaks 3 languages: French, Spanish, English, and artificial Arabic. I make it already on it. And another one or advanced one will speak all languages but with updates. What else for Alex? Number 1, high fidelity mannequin can do ECG interpretation easily, patient communication easily also. And then what else? Cloud connectivity, it's very easy. And what else? Iris scan and camera, like reality storage. Another one. This is Arabic, okay? I will show you English. And also, we can ask Alex any question. Alex can answer any question with 3 languages. Even when you told him, مثلا, for example, what is the date of today? He will do it. And what is your name? What is your nationalities? What is your heart rate? Do you have any history of diabetes? Anything, medical or not medical? Okay. Reason. Which one? This one? This is Arabic.
First, we appreciate your efforts to support the success of the Air Action Committee, which discusses artificial intelligence and digital transformation. Thank you.
On this video, you show chest rising and pulses, and I will show you what is the ECG interpretation for him, like monitors inside of him. This one? No, this one. This is will represent for me, when I attach Alex with internet and make it on. This is ECG interpretation for all data inside Alex. It's well modified according to the patient case, chest pain, regarding cardiac patient, regarding respiratory patient, COPD patient, coronavirus patient, according of them. Heart rate is 50 and saturation even 91. 91.
It's not working, but my
Saturation also 91, and respiration 28. Blood pressure 98, and diastolic 65, and even temperature for him 36.1. When I change for coronavirus, you will show the temperature is 37.8. It's 38.1, like the case.
So I really don't understand. These data for whom? For Alex?
For Alex.
What I have to do with Alex? Okay, how do you help me? I didn't get it.
When
this
I
is
attach,
Alex.
When I attach Alex,
Okay.
when I go for the patient, when I go with my student to learn my student how to take patient communication and patient history and assessment I need this patient, a real situation. Regarding coronavirus, we cannot go for the hospital regarding coronavirus. Yes. So instead of this, we have the first communication mannequin as a robot, Alex, in the skills lab. I will train my student inside skills lab as a real situation at the hospital. We didn't need a monitor because Alex, when I connect him, when I connect it on my mobile, iPhone, anyway, I connect it. So data for Alex will be represented on my mobile. This data, and Alex will show me respiration, okay, and chest rising, and with the smartoscope of Alex, I can hear lung sound, heart sound, bowel sound, very easy. I think this is very difficult on the real situation also, but on Alex, I can hear all of this. It's very easy, okay? I talk to talk to him with the situation. I make a small situation to okay.
My name is Alexa. What brings you here? It's a little hard to read, and I can't catch my breath.
This is a robot. This is Alex.
I have been diagnosed with COPD for almost 15 years.
Okay, this is a real situation. Like Alex also has male and female voice. We can change it, male and female voice. So this is the female one with all organs, change organs and hair. I have time or not?
Your time is very fast, but maybe you can conclude in the next 2 minutes or so, man. Can you do that?
I will hurry. Okay. How digital health contribute to solving the problem of the coronavirus? Already talked to everyone. I will discuss it, Harry. App health checkup. Number 1, offering diagnostic support. Number 3, using artificial intelligence that I showed you for diagnosis. And also, I need to make a hint on something, Sectra. It is later on I will. The future of digital health. Medical professionals and policymakers have a huge responsibility in involving the patient as a partner in designing care and decision making and guidance them in using the of digital health technologies. Otherwise, the patient may either turn to non-proven services of technology solutions they might not be able to interpret alone. By sharing responsibilities by physician and so on. Using digital health is a teamwork. The era of lonely doctor heroes will end, I think. So success of providing care depends on collaboration, empathy, and sharing decision making. And all of this, I think I catch it. Thank you.
Thank you very much.
Something else. I need to something else. There are another one for artificial intelligence is anatomage, like Sectra. Did you know Sectra? It's anatomage. This table. When I attach this table, I can show. I can see heart and make a cutting on any area of it and take it like it in front of me and train my student for every area of this heart or lung or kidney all over here.
So it's like a 3D animation.
Yeah, training. Or it's already inside my skills lab, and my student already trained on it. This is very amazing, or very fantastic, digital health. Okay, thank you.
So perfect. So thank you very much for giving us an interesting discourse on the digital technology that is being used in medical education as well as healthcare. So here is your certificate, ma'am. Can you come in front here?
Okay.
Yes. Thank you. So next we have Mr. Ayman Nasir Al-Nafia. He's the Director in Operations, Executive Administration at Mecca Healthcare Cluster. Welcome, sir. Thank you.
Assalamu alaikum and good afternoon. Thank you again to have me here for this conference and very thankful for the hospitality. My name is Ayman. I'm just American certified patient advocate and certified as patient experience, working right now in King Abdullah Medical City in the knowledge management department and operational excellence in the cluster. I hope you find my.
Is it two?
That's good. I hope to find my presentation is interest. Thank you, Dr. Prof. Tariq. Before Dr. Prof. Tariq, I think he talked about patient-centered care. And my presentation is about patient experience as well. I just want to share work we have done in King Abdullah Medical City around 5 years ago. I'm still proud to present it here because it is really have a nice effective till now, and the work we done still unique in Saudi Arabia. So I'll just start first so everybody goes for the lunch. I'm talking today about the patient experience and the patient whiteboard. I'm sure the nurses and healthcare provider, they're about patient bedside whiteboard. The first thing, 2015, the perception of patient experience itself, it was new. So it was very difficult to implement the tools to support the patient experience. So patient whiteboard, patient whiteboard is about increasing the communication between the healthcare provider and the patient, and also over the healthcare provider themselves. The background of the patient bedside whiteboard is about if you have more effective communication, it means you will have better outcome. If you have poor communication between patient and healthcare provider, you will have in the end poor outcome. Why we raise this issue and why we start to have this patient whiteboard in our hospitals. Some issue is here, even verbally, some of it, observed by patient relation department, who is the consultant in charge for the patient. We're not talking about the patient who is admitted by or through OPD. We're talking mainly about patient through ER or transfer the health between consultant and other consultant. Who is the nurse charge of the patient? With the nurse, they have to have working 2 shifts, and then the next day maybe it might a different nurse as well. What the room number? Our patient, almost all patients, they are 60 and 60 above. So when they admitted, with the call for the relative by phone, and then ask which number, they don't know even, they ask the neighbor or the keep. And please put line about this one, keep asking and repeating question for the nursing and healthcare provider. Patient and family always ask for the Wi-Fi password. We provide free password, family free Wi-Fi, family member surprise when visiting the patient. You know, it's very difficult when you go to visit your patient and you can't find him because he went through procedures. You know, this gives a little bit shock for the family. A repetitive inquiry about the patient land, either from the patient or the family. Patient keep on asking about her diet. Patient frequently forgot the objective for the day, or even not given through the healthcare team or healthcare providers. So they are not really well informed the patient about what is their goal of the day. So the patient will commitment on it. Many patients who were discharged without asking for a prescription, instruction, next appointment, or discharge equipment. It does happen over time, but all the hospital, I'm sure for you at healthcare provider, if this one, the patient will be discharged and he did not take his next appointment follow up with the consultant. So working on this project, we talk about 2 objectives. Primary objective with to improve patient satisfaction with the use of the unique bedside. And I will come to this later. Please just remember it's unique, your bedside whiteboard design. The second objective is to bridge the communication gap between the patient and patient family member and the healthcare staff in order to improve patient experience satisfaction. Our defender are very important to increase patient awareness of treatment plan and better patient experience, have better patient experience. And we did very about it, the content itself with which we put it and write it on the whiteboard in our design, patient goal of the day, name of care provider, nurse physician, pain score, and patient and family member engagement. We'll talk a little bit long about this because I find interested, and it was not our intended. That outcome we have when we give space to the patient family to engage them in the healthcare plan and schedule test procedure, include the lab test. The hypothesis for this project, it was the new design will lower the number of statement interest written by nurse. All of us, we know that the whiteboard in all hospital is mainly responsible for the nurse. And because we are, our patient is Arabic patient, most of them, around 70%, and 75% of our nurses are non-Arabic. So it's not would make sense if you write in English, that will not be understood from the patient. The patient and family will have better understanding of the patient treatment plan and name of the healthcare provider, enhance the communication between the patient, family, and healthcare provider. The importance of the study, it was to reduce the communication gap between patient, family, and healthcare provider themselves, and to increase patient family awareness of the treatment plan, which it will end in will come in the end with better outcome and healer environment, which is what we are looking for it, which lead to high patient satisfaction also, score, and better patient experience. We went as well for the lecture review, and we find some article support our idea that improve patient whiteboard will improve patient flow, but land approach to their use is required, and this is what we did in this project, and also the difference between the practice between the healthcare provider, though these are different, but still the all provider value their potential as a tool to improve teamwork, communication, and patient care. Here we go, the difficulties. As we mentioned before, the language barriers, and most of our patients, 70% of our patients Arabic, and our nurses, 75% of our nurses non-Arabic speaker. So the language is very common barriers, and we will go to it later. The second thing was the culture barriers. Our culture in Saudi Arabia here is same in GCC. It's a little bit sensitive when it comes to private. All countries have something in their culture is sensitive, and we concern that privacy when we are in the room, it's really very important for our patient. These other barriers. Our patient, our rooms is designed to accommodate 2 patients at the same time, and it was difficult. I visit my cousin a few years ago in Houston, and she's alone in the hospital. She's been in the hospital, and she's alone in the room, and that's make easy for the people to write in the whiteboard without reaching any privacy. And that's why we'll come along with our project, how we accommodate this kind of barriers. The methodology we use a design thinking method. We take the time from July to middle of September to implement the whole process of the whiteboard. Okay. This is the project milestone of our project. The first phase, we did the design phase. The second phase about the pilot phase. And then we go to the adoption and printing of the final design. The fourth was implementation and execution of whiteboard. And then at the end, we come to the follow-up. When talking about the first phase, we of course create a team, team from nursing, ward clerk, from physician and other department, and patient relation. And the second thing was working group meeting workshop. In this group, we sit together, we come to the final design, and the important there, we visit the patient and sometimes the provider and ask them about their perception and what they think is better to be written in the whiteboard, and we'll come with the questions we use later in this phase. Visit the patient room, so we have to visit the patient room and to know exactly where we can place the whiteboard, so to be easy for the patient to see. At the same time, it will not be easy to see, to be seen by the next patient or the other patient. Create whiteboard prototype. Here we go with many prototypes till we go to the final design. The first prototype, it was 10 bedside whiteboard. We take in every ward, cardiology, oncology, hematology, so it will be an all one implemented and have feedback from the healthcare provider and also from the patient as well. Here we can share with you the first design of the whiteboard. When you look at it, it looks like similar to others. But now we'll come to the implementation, how it's hard. I want to show you the next picture here. It was very small. I'm not sure you can read it. It's for a little bit, but it's used not by healthcare provider and that the patient. It's no. It was by family and question about the healthcare provider. I just want to mention here also. I really have seen something very interesting. It's not a question for healthcare provider. Some people they draw the kids or the right statement for a lovely one. In the beginning, because this experience was really new for us, and I thought they misuse it. And then we're thinking to, again and went really for money literature review, and this I find the patient, I asked the patient, I found these things, it helped the patient for them to cope with and more commitment with other with our treatment, and then it will create hidden value for the patient. When every morning he saw the draw by his kids or by their loved one or very lovely statement, it really I found it very positive things, and I keep it and encourage the people to do it also. So this is the question design we used before we come up with the first prototype. It was about two segments. The first group, what do you think is the purpose of the whiteboard? So ask them from the beginning what's the perception, because it is new and nobody knows about it. So the answer is contains 3 kinds of feedback: improve the communication between patient, inform the patient well she is for the patient what she needs to know about her daily health information, and engage patient in the treatment plan. The second group of questions, now we're asking the patient and healthcare provider what they think about the content should be embedded in the whiteboard. And two segmentation we have here is information about the procedures, nutrition, and activity needed for the patient. I want to show here that we did not just only sit together with our colleague and come up with this. We engage the end user and our client. The third and fourth questions with like comment, it was like comment, and the number 3 question, the answer, all additional comments were from the nursing. We suggest that all comments written in the whiteboard in Arabic by another member of the healthcare team to be written in English as well. Later on, this answer was not valid because what is written in the whiteboard is already written in the patient file. So nothing would be written in an extra in the whiteboard and the nurse not aware about it. So it's already the information there with the healthcare provider. The comment indicated in the big picture of the whiteboard was still not very clear to them, and that time we were in the awareness phase. So that's the comment is already eliminated later. The third phase is actually printing the whiteboard. We already adapt 253 whiteboard and distributed in all wards. The fourth phase, implementation execution of the whiteboard. The fifth phase, continuous follow-up, and we'll talk a little bit about it. The study sample was the patient and the healthcare provider who had the authority to read and write on the whiteboard. The method of data collection, photograph of the bedside whiteboard, interview, and questionnaires. The consent, we talk consent from all patients participate in this study, and the healthcare provider was not need to take any consent from them, but it is their regular duty. The survey result here, it is the final result, final survey result after the implementation, the final design of the whiteboard. We can see here the participant is about 40 from healthcare providers and patients and patient relatives. We found here 55.1 agreed to important benefit of the whiteboard. Maybe this number, when you look at it, looks not big, but 5-6 years ago, which nobody know anything about the perception of patient experience and patient satisfaction. So I think it's very, very high. Nowadays, you can find some survey and some articles have less than this percentage. This is how the segmentation and who the people participate in the study. And there was a design of question for the final survey after the final design implementation. We ask the patient and healthcare provider, do you think that the whiteboard is informed? Does it help improve communication between patient and physician? Does it improve the communication between patient and healthcare provider? Communication between healthcare, the team open their each other, and improving the communication and understanding of diet plan. Does it help providing a good view of procedure and activity of the day for me and my relative? Does it provide clear instruction of what I need to take or to know upon the discharge? The outcome, so it's very interesting. The first one, the whiteboard design, bridge the gap in communication between patient and family. The second one, it is also improved the patient awareness of their care team admission plan and their care team and the admission plan and the duration of the admission. And we can say later is about of the estimation of plan. The patient, you ask the patient every time when you're discharged, they don't know. So very important is a plan of the discharge from the beginning, and the patient will family will be aware it at least a day before. The third is improve patient overall satisfaction. And the healthcare team and patient family have found the whiteboard to be helpful, and also the healthcare provider, they are more willing to use their to use the healthcare to use the whiteboard during their daily work. Here I want to show you in the end now how the final design whiteboard show. I hope if you can later make it big so everybody will see clear. I think yes, it's not clear, but I hope I can send it later. So we can say we can see here the dimension is 90 cm high and 60 cm weight. It is divided into column. It is include the bit number, extension, MRN, date, consultant nurse name, extension, the goal of the day, BAME score, you can see it here, expected date of discharge in the end of, before the end of the whiteboard, important contact number in the right side, relative contact number, it will be in this side also, and patient and family questions. And in this side, you can see the procedures, and it is very from word to word. We design our board to be vary from word to word, depending on the common procedure in each word. Now we'll come to, so why, how we come with the best solution of the language barriers. Now that whiteboard, patient whiteboard, who contribute on in is 5 healthcare providers and 5 departments. The nurse have a very small part. Now they are only make tick on the procedure. This procedure written in Arabic and English, and they have only to make tick in which they have. It is MRI, or come to it later. There's MRI, CT scan, lab test, and CAF and other procedures. The ward clerk has also role to write some of information. The patient and family, of course, of engagement, nutritions for the diet plan for the patient, physician, goal of the day. And we come here the role of the ward clerk to write MRN, room number, room extension, responsible to write the consultant name. The nurse part is to write their name. Until now, the question will raise, they don't know how to write Arabic, so how they will write their name, I'll come to it later. Nursing, they will write the station extension, it was this number, the procedure, they will take only the pen score, also it just will take on the pen score, it is in Arabic and English. This is what the whiteboard also contains. The whiteboard contains information need when discharge, it will be in this part. This intended to be for the patient to be sure when discharge, he will take all the necessary equipment or the medication and be sure the information about the medication use was given to him. So there is the discharge summary, receive the discharge medication counseling, discharge instruction, and next appointment. It also can be used by the nurse to be sure she already give everything to the patient before they leave, and would increase patient safety and, of course, patient commitment with the treatment plan, which will reduce any misunderstanding from the patient about his plan. This part, we write the communication of the patient relation and the CO office number, and was very initiative from him, and he really supported this whiteboard at that time. That's why he wants the patient will know that the CO is aware about any comment from the patient. And here we can go very fast about the design of the whiteboard. The design is same in all ward, except, as I mentioned before, this procedure. In the internal medicine wards, as an example, we can see X-ray, colonoscopy, endoscopy. Like oncology, we add chemotherapy or blood transfusion. We can see in different wards, like surgery, there is MRI, ultrasound. Laboratory, of course, is common things. Neurology, we can see the bone marrow aspiration. we cannot see in the other whiteboard designed for different ward, for another ward. The cardiac surgery ward, we add the Holter monitor, and we add the CAS, PCI, and the medical cardiology, we add the echo, and we can see the cardiac surgery and cardiac cardiology ward. Internal medical cardiology is similar a little bit. So what the attribution of our whiteboard was magnetic, written in Arabic and English, and a lot of checkbox, especially we designed that for the nurses, so to eliminate the language barriers. The privacy, of course, issue even by issued even by healthcare provider, as it is just we have 2 beds and 2 patients in one room. That's why we went to literature review, and I found very interesting article even issued by Australian professors, and written there exactly which it should be written in the whiteboard, and which is not which were prohibited to be written in the whiteboard, and will breach the patient privacy. Also, we seek a consent from our legal affairs, so everything will be a legal issue, and we will have any. We're not going to repeat that issue to be raised again, especially if some healthcare provider they were not really agree for the whiteboard implementation. We go also further for the patient, and we put our patient knowledge about the whiteboard in the general consent. The general consent to be signed from the patient or his relative upon the admission. We went also further, so everything will be under, we will be organizing more. We create a policy and procedures. And we put it in the Dropbox of the hospital, so everybody will be aware about it and about the rule. Here we conduct a training of the nursing. You know, it's not really whole training. We only give a very small session teaching the patient, the nurse, how to write their first name in Arabic. The monitoring of the implementation, we have this sheet, and we cannot monitor all the implementation of the whiteboard in whole hospital. So this we decide that the best relation will do round, and then we'll go to every ward, but they will choose randomly 2 rooms. It means 4 bedside whiteboard. It is our goal not only to be sure it is completed with the patient relation or patient experience officer has to ask the patient, did anybody experience the use and the benefit of this whiteboard or not? In the end, and it was raised for infection issue, but in the end, it's part of the cleaning, so they can clean the whiteboard and the pen use as regular things in the room. Why I want to emphasize is about the multidisciplinary meeting, because we did really a great job and many meetings. Almost will meet every healthcare provider just to tell them that the whiteboard will help you to avoid the patient and family recurrent question, and it minimizes the workload to the healthcare provider and also our COO. And this is important why I put it here, because without the supporting of COO in his regular meeting with the executive and general staff meeting, this will not be happening. The final thing said about the issue, this is the final slide, about the issue of financial issue, this final slide. Talking about the pen, you know, it was missing from the whiteboard. So the question raised, are we going to buy every day for every patient? How many, for how long? And we decide that just to put it in the chain and put it in, stick it together with the whiteboard. Thank you very much, appreciate it. I hope this was very helpful.
So thank you very much, Mr. Ayman. I was wondering if there are any questions.
Hi, thank you very much. It was well done. I just have a question because I know in this part of the world and culture that the families do not want the patient to always know what their diagnosis is. And they don't want them to know the plan of care. So I saw your rejection rate was a little bit high. Is that it? And how did you address it? And were you able to have those people, did they understand? Or were you able to communicate to them why we're doing this and what, how this will improve the patient's care?
Yeah, exactly. Okay, to answer this question, it is two parts. The first part is about if the implementation of whiteboard or the use of whiteboard is mandatory for all patients, it is not choice. So in the end, if the patient and family doesn't want to use it, we will not going to use it. But so this is a choice. The second thing is about, yes, some whiteout in our survey, it was high from interruption. It's not because the patient and family don't want to use the perception itself. So, you know, sometimes we go further with some questionnaire interview with some patient and some care provider who wrote that rejection. And also, if you can see our sample, most of them they are healthcare provider who wrote they reject the implementation of whiteboard. So at that time, go further, it is not about this, some rejection because they don't understand about it. That's what you mentioned. So that's why I asked the same question to my cousin when I visited in Houston, and she said, after the what about if you came the next day and nothing written in the board? She said, I will complain. Yeah.
You have a loud voice.
Okay, with us, they start with a bang. And nobody explained to us that. No, it's not a policy, there's nothing. It's a very good tool because I'm working in pediatrics. So with my personality, I make sure that that mommy is the middle of all the attention. And they want to write. We are the ones that we must write on the report again. But especially if a patient is there for 3 months, what do you write more? But we see that the family really wants to write. But nobody talked to the healthcare worker. Why is that board? They just paste it on the wall, and we must look for a pen because my people lose for a pen. So how do you do it? And I can see it works because they know my name, they know who is the doctor, they know who's the consultant, and what is our plan for the day. Even if we don't write in Arabic, they write their piece of Arabic, but it's the way how you do it. But from a healthcare worker perspective, it's not clear. And now I know where this comes from. I'm sure it's from you. And somebody took it, and somebody just jumped on that wagon, and they don't even tell us why. Yeah, it's just give it to us, do whatever we say. That's why.
Yeah, that's what comes in 30 seconds. I have the same perception of almost all nurses in the hospital. And after this, the last phase and design was in the printing, they came and they asking me, they are the one who asking me, we need pen to write. Why? Because just imagine how many questions the patient and relative asking in one day, the same question. If you 5 o'clock, the visit is time 5 to 7 as an example, the 5:30 that they will come. They will ask the same question of the people who ask 6:30. So even if in the board, if you have a calculated, this one I calculate with them their time and effort. You know, it really minimizes their effort and time. In the beginning, it looks not, but about the financial issue, paying the cost, you know, the people should be say that in different perception. You know, if it is about the turnover bed, you see, if the patient he doesn't know anything about what is going on, he might review the discharge. You know, if refusing discharge in government hospital, it will take 3, 4 or more days. But if the patient getting the beginning and he knows the estimating discharge time, he might go. So it is even cost, vastly cost, financial cost, it really will increase.
Hi, Ms. Nassar. That was great. I just have one question. In the United States, they're obsessed with, the COVID. So using the pen and it being transferred to patient, to family, with, bacteria being transferred. Do you ever see this board going, not virtual, but digital, where a nurse could just input the information and it shows up in the patient's room?
Yeah, exact question. When it comes to digital, I have some colleague, I don't want to, I'm not here to have authority to talk about it, but I believe our colleague in King Fahd Hospital, they already implemented that in reality, implemented digital whiteboard. These have a lot of problems. The first is not a financial thing because it's very expensive. The second is there is the healthcare provider itself. They take time to write in the board. So instead, they will write in 10 minutes their diagnosis, everything. They will take 25 minutes. They are not prepared from the medical school to use this kind of tools. So how come they would ask him to bit long? So in the end, the decision from this my perception, I'm not talking about why how they did in Riyadh and King Fahd, but my perception when I go even further, we have two choices for digital, and the people they don't like to use it, or they would take long time. So that time will go to the patient care in the state to just write it in the digital thing. But that good choice, and hope in the future, I think in our vision 2030, my colleague has talked about it, and I believe this will be part of it. Thank you very much.
Okay, so thank you very much. And thank you. Certificate. Yeah. Right. Good. Thank you. Okay, thank you very much.
اي صحيح. صح.
Good afternoon, and welcome to the afternoon session for day 2 of the UCG Dubai conference. First speaker for the afternoon is going to be Dr. Rasma Al-Hunati from Qatar. She will speak about engaging patients in the development of national clinical practice. So Dr. Rasma, and I'm so sorry if I mispronounced your name. Can you go ahead and begin, please?
Thank you, thank you. You are absolutely right. You pronounce my name very well. My name is Rasma. Thank you, and I hope that you had a good break and a nice lunch for those who go to the lunch. Before I will start my presentation, I would like to thank the conference organizer for the invitation and for this opportunity to present our experience with the engaging patient in a clinical guideline to the esteemed audience. And that's in behalf of myself, Ms. Huda Al-Kathiri, Dr. Bushra Saeed, and Dr. Rasha, who are my colleagues in the National Clinical Guideline Program. I will share my screen with you. I hope that my screen is visible.
Yes, it is.
Thank you. Great, great. So in my presentation, I will brief you about the National Clinical Guideline Program in Qatar, and we'll share our experience in engaging patients in a clinical guideline process. We will talk about the criteria for recruiting the patient representatives, consideration that we took to engage patient or to include patient in the National Clinical Guideline development, the role that patient representative played in the guideline program, and how we prepare our patient, and the challenge that we have encountered and still encountering in recruiting patient, and to give you some example of successful experience that we found it good through while engaging patients in the clinical guideline program. As you all know that globally, the healthcare systems are challenged by increasing in the patient expectation and demands for better care. There is also complexity of diagnostic procedures. There are issues related to demographic changes like aging in dynamic population and in shortage in the health workforce, and of course unexpected pandemics or challenges like COVID. So both underuse and overuse of the investigation or treatment will compromise the healthcare resources. And the research landscape rapidly evolving. Health professionals are extremely busy to keep up to date or to stay updated on the recent research findings, and to assess or to ensure that to evaluate the research findings. Qatar in particular has culturally diverse population and health work professionals. This will of course add value to the healthcare system and the health services provided. However, it will result also in variation in care. So to bridge this gap in variation of care among the professionals who come from different parts of the globe, we have established the National Clinical Guideline Program that aims to standardize the management and the treatment received by patients across healthcare system, whether it's going to be provided at private or public sector, and to localize the best practice to the Qatar local culture, customs, practice, formularies, by developing this national clinical guideline for the most common health issues and diseases. As a background, the program started in 2015 under an integrated system of care that under the Health Quality Improvement Project at that time, and we continue in alignment with the current National Health Strategy 2022, where we have 6 population group in this strategy. We are aligning and working closely with the national lead of each population group and develop national clinical guideline as per the specific population needs. Who will benefit from the guideline? Of course, health practitioners, clinicians, healthcare organizations, insurers, policymaker, and of course, patient and public. This is our goal to improve the patient outcomes. Here is the list. So far, we have developed in 5 years 52 national clinical guidelines, and these guidelines are published at Ministry of Health website under the e-service section. And it's also published on Qatar National Library and Guideline International Network. Here, the process of engaging patient in guideline. This diagram shows the summary of the guideline, how we develop the guideline. We start by selection of the topic and approval of the topic as a priority for guideline development by National Clinical Guideline and Pathway Committee, a committee assigned, formulated by ministerial decree to oversee the program. Then we go for the scoping meeting in which we decide with the national lead or the clinician relevant to the topic being discussed to set the scope of the guideline, whether it's going to be what to include and what to exclude from the guideline and which population group the guideline will target. Then we will, once we agree on the scope, we go to the baseline document where we prepare the best practice recommendation and a template for the group of subject matter experts, which is the National Clinical Guideline Group, or subject matter experts from across the system, private, public, and semi-government sector. They sit in a workshop, either face-to-face or virtual, sorry, depends on the situation, and they discuss the recommendation and localize the recommendation to be appropriate for Qatar. As a guideline team, we will do the post-workshop editing to make sure that every recommendation is incorporating, and we keep exchanging the guideline, communicating with those subject matter experts to make sure that all recommendations are included and all are happy with the document before we take it to the National Clinical Guideline and Pathway Committee to approve it for publication at Ministry of Public Health website and other partner websites that I have mentioned earlier. The patient representative role is during the workshop, he or she attended the workshop, and post the workshop, he reviewed the patient information leaflet. From each guideline, once we agree and the subject matter expert approve the content of the guideline and the recommendation, we extract a patient information leaflets. Patient information leaflets considered to be extracted from the guideline, however, drafted in a simple language that patient can understand. That is clearly for normal people without medical background. Till this time, we are developing patient information leaflets in Arabic and English. In the future, we are targeting to aim other language to make sure that we fulfill the needs of our patients from different, who speak different language. This is the base sample of our patient information leaflets on the obesity in English, and we have the same in Arabic. We translate it in Arabic so that the people can read the way that they like. Why do we engage patients in the National Clinical Guideline Program? As you know, patient engagement is an action taken by people take to support their health and benefit from healthcare. So wherever you engage the patient to take a decision to support his health or to share in the decision relevant to his health, so this means you are engaging the patient. So we aim to provide a safe patient-centered care. We want to improve the quality of care by having input from the patient. We believe that engaged patient can make a better informed decisions about their care option and the treatment plan. And throughout the program, we have good input from the patient. And as a guideline team, we also aim to comply with the Agree-to instrument, which is an international document that assess the quality of clinical guideline, where patient engagement is an important aspect and item in this tool. How we recruit, what are the criteria of patients that we engage in our guideline? First of all, we make sure that the patient is willing to attend the workshop and he's available to dedicate 1 to 3 days to sit in the workshop when the workshop is going to be face-to-face, or 3 online meetings if not. This is the average. Some guidelines we can conclude in 1 day, some takes more than 1 day. So on average, it is 1 to 3 days. We inform them before that this is the time needed for the workshop. They should have better or good understanding of English, as the guideline document is in English, and we also need their own the language of the workshop almost in English. We have considered that he or she should have experience of receiving healthcare in Qatar. He's familiar and he has used the healthcare system in Qatar, and willing to reflect his or her experience to a wider group of people, either during the workshop or through the recommendation that he will put in the document itself, and ability to maintain confidentiality. So this is an important aspect. Before we include the patient in the guideline, and for their right and for the sake of the program, we confirm and ensure that patient representative should be willing to have his or her name listed in the guideline documents that will be published. We list their name in the guideline development group as guideline development group member, and we identified him as patient or partner. He is willing to review the patient preference section in the guideline. In each guideline, we have a generic patient information section that we prepare it, and we take input from the patient on that is related to privacy, confidentiality, communication, restriction, and all the main generic patient preference section. And he or she should sign a conflict of interest form that he has no conflict. This is the case for all GDGs, whether he's a subject matter expert, guideline developer, or a patient representative. Before the workshop, we try to go through the engagement process of the patient. We prepare the patient, we meet as a team, national clinical guideline team, myself and my colleague. We meet with the nominated patient. When I say nominated patient, usually we ask the support from the clinician who are in the healthcare system to identify a patient with the criteria that I have mentioned earlier. And we discuss with the contribution of the guideline process. This discussion includes the following, but not limited to: overview about the program. We give them idea about the program and the importance of their contribution, outline of the process, how does the process go, and what is required from them, how overview how the workshop will look like, because you may agree with me, patients need empowerment, and having the patient sitting with a group of very senior subject matter experts could be a scary or not comfortable experience for the patient. So we explain to them. On the other hand, we also inform the subject matter expert whenever we have a patient representative that we have the guest or the patient representative, so they mind and take care and know that we have to support and to consider his or her presence and existence. And we ask them through this preparatory meeting also as an opportunity to know more, to identify any deficiencies or anything that he or she might recommend during his or her receiving the healthcare. So if there is any deficiency that he identified, that needs to be highlighted, because on the other side we work on the implementation of the guideline, where we identify any consideration or barriers for the implementations so that we can take it. So we consider this meeting as opportunity to hear from the patient, and any suggestion on the improvement of the patient experience, anything that they can suggest to improve the patient experience. In this slide, I will summarize for you the role of the patient representative with some examples. And patient, they attend the workshop and provide input on the recommendation. Some patients are literate enough to reflect or to give input on the recommendation themselves. He reviewed the patient consideration or patient preference section that I mentioned. This section, the image shows that the section in each guideline, we have the section that include privacy, confidentiality, and all the generic patient considerations that should be followed and implemented when dealing with any patient. And if the patient for that specific guideline here's request for any consideration, we included. Some of them, for example, they support the delayed prescription. Some of them, they want to have a special clinic for autism, that they cannot go to the dental clinic with autistic child with any regular people, while the child is difficult to be controlled and active. But this consideration, we consider them so that the health professionals and the health system leaders can consider. They review the patient information leaflets, either in both language or as per the language that he or she is comfortable with. Here in this slide, the circle shows the lady. We took her permission to use her photo, and she was participating on 5th Qatar Patient Safety Week to speak up for patient safety. She has shared her experience. She's sitting next to the national lead for dementia and the Director of Strategic Planning Department. We have Professor Aziz Sheikh, I was moderating this session. This is an example of our successful story. And here I wanted to show you the voice from one of the patients. She literally says to treat the patient with respect, regardless the way she or he dress or look like. Some of these sample or the things that we point that we may ignore or we may not pay enough attention, so we can have it from the patient experience. We will be working on them, and we encourage our colleague wherever they deal with their patient to consider this. Here are some of the examples that of the challenge that we encountered. It's not easy to find a patient. To find the patient with the criteria and with the ability to commit and to dedicate the time to the guideline and to meet our criteria, it was not very easy. Cultural limitations. Some people, they are willing, but for cultural factors, they don't. To want to participate or to sit in the workshop with a group of physicians or to have their name. Some, they have their own experience, but they are reluctant to share their experience. They don't want to share their experience with the larger audience or to know. Language barrier. Due to diverse multilingual population in Qatar, we only take a patient who can speak English and who are comfortable with English or in Arabic. But if the patients from other, we did not have input from patients from other language. Urdu, for example, if we have colleagues that understand Urdu, sometimes we use them. But still it is a challenge, language barrier. And the other challenge is that we are not able to serve them with the patient information leaflets that are in their own language. Health literacy barriers. Some of the patient information representative who accept and who meet the criteria. We have the issue with health literacy. They have limited health literacy that they are not able to provide, or we expect more from them. Lack of human resources with the required skills to educate patients. As you know, patient cannot be brought to the workshop right away. They need empowerment, they need help, they need education, and this we lack the adequate resources to train them. But we have our plan to provide more staff with the adequate skills to provide. Here is one of our mission or outreach visits to speak up for patient safety. It's in one of a private organization where we go and encourage patients to participate in the guideline or in any other healthcare equality initiatives. Before I conclude, I would like to share with you my personal experience. This is a smiling lady. Actually, this is my mom. She's 84 years old. She had no chance or never go to any school or to have opportunity to suffer. She's illiterate. At the beginning of COVID pandemic, she experienced a panic episode, stomach ache, back pain, headaches, sleeping disturbances, poor appetite, and many other symptoms, which makes her moving every day from one clinic to another clinic, from one hospital to another hospital, end up with this list of medication that some of them are the same, some are cannot be used together, etc. One day, my family, they called me and they told me that they are in a difficult situation. She refused to take them the medication. She's diabetic, she's hypertensive, and throughout that time, she started developing some fits and convulsions. But they refused. When I talked to her, why didn't you want to take the medication? She said, because your sister is cheating me. It seems my sister tried to take some of the medication. She changed the envelope and she tried to put the medication in different box. So she just wants to convince her to take the medication. But at that time, I told her, okay, mom, you can decide on some of the medication, but not all of them. But diabetes is an old problem that you have it. Hypertension, we cannot stop. Anticoagulant, you can't stop. Anti-lipids, you can't stop. However, choose any other medication that you want to stop. She stopped them all, and she's doing very well since 2019 till this time. And she's very happy. And I personally asked her permission to share this with you. But I told her, Mama, can I share your experience with my colleague? But this is my personal experience with the patient engagement, in which I can say we cannot ignore the patient decision or the patient himself. We have to listen from the patient, and regardless how educated or how literate he or she, but it seems that they can take a decision related to their health, and communication is very important, and the trust. I don't think that cheating the patient or forcing the patient to take the medication will produce any problem, any benefit. That's all for me today, and this is where, if you want to know more about the guideline, please visit the Ministry of Public Health website. And if you have any query or would like to share with you any of our experience or our material, please feel free to email us at clinicalguideline@mobs.gov.qa. That's all, and thank you for your listening. Thank you.
Well, Rasma, thank you so much. I thoroughly enjoyed hearing your story and sharing that with us. Shukran, Habibti. And thank you for sharing your beautiful mother, mashallah, story with us. I really appreciate that a lot.
Thank you too. Thank you.
Thank you. Have a great afternoon.
Thank you. Same to you. Bye-bye.
Bye-bye. So our next speaker for the afternoon is going to be Marilyn Abdel Jawad. She is coming from, I'm not sure, Pakistan? Palestine, I apologize.
No, from Jordan. Hi.
Jordan. Yes, Jordan. All right, well, Dr. Marilyn, I'm
Jordan.
my apologies. Welcome aboard, and I hand it over to you, dear.
Okay, thank you. It's my pleasure to be for the second time with the UCG conference. And my apology regarding my voice because I'm sick. Today, I will be presenting one of my favorite topics, the just culture. As I have been trained by the father of just culture, David Marks. Let me share my slides. Share screen. Okay. Can you see my screen?
Yes.
Okay, here we go. So I'm a patient safety advocate with a background from pharmacy and master patient safety. So I'll be presenting understanding the just culture concept. I know since morning we're talking about the conference is about nursing and patient safety. So my focus here is about patient safety. The objectives for today, we'll learn what are the components of safety culture and understand the definitions of just culture and safety culture and what the difference between them. We'll describe the importance of just culture and develop a good understanding on the principles of just culture and learn the just culture framework, the 3 behaviors and the 3 duties, and develop understanding on just culture algorithm. I'll start my presentation with this testimony from Dr. Loshanib. He's the father of patient safety. We know that everybody is a human, and we are working in healthcare, which is complex. And staff sometimes doing some mistakes, but if we punish people for making mistakes, so it will not prevent the error. The error will keep happening. Let me share with you one of these sad story regarding Nurse Kim, who committed suicide in 2011, just 7 months after making a mathematical error that led to an overdose for an infant, for a baby, and he died. This nurse, despite she has 27 years of service, she was, the hospital leaders made a difficult decision to terminate her. To satisfy the state licensing, disciplinary action has been done to her and to pay a fine and accepted a 4-year probation, included medication administration supervision and any future nursing job and ACLS. But according to media reports, this and countless other efforts produced no job offer for that poor lady, which ended her up to suicide. Unfortunately, this is the case that's happened when you just focus on persons and you don't think about even the system and the behaviors. That's why there's a need to have a safety culture, to build a culture of safety. To understand what is it, we need to understand what a safety culture means. The definition as per the HRQ for the safety culture of an organization, it's a product of individual and group values, attitudes, perceptions, competencies, and patterns of behavior that determine the commitment to and the style and the proficiency of an organization's health and safety management. Any organization with positive safety culture, they are characterized by communications founded on mutual trust, by shared perceptions of the importance of safety, and by confidence in the efficacy of preventive measures. The culture of safety is originated actually outside the healthcare. It came from the higher-level organizations, and the higher-level organizations actually are also from the industries like aviation, nuclear medicine, and those are who applied it. And the acknowledgement that of high-risk nature of activity and the commitment to achieve safe operation despite how much is risk. And our healthcare is becoming more complex as well. So environment where individual can report errors without fear of reprimand or punishment. This is what we mean by culture of safety. It's encouragement of multidisciplinary collaboration to seek solutions to safety problems and organization commitment of resources to address safety concerns. So this is how it looks, the positive safety culture. The positive safety culture is a culture that staff are feeling free to report, they applying the just, and it's flexible and learning, and also it's informed what's happening. These are the key elements of any safety culture. Let's have this scenario together where patient was scheduled for a procedure and he was first on the list with a busy full schedule during preparation for the procedure. A staff who is low hierarchy, low grade, feels that something seems not quite right. Patient surgeon has a temper and clarification was required from him to proceed with procedure. However, staff stopped the process and said, I need clarity, which caused a delay for 45 minutes. And it turns out that everything was okay. So if you think about it now, in this case, with the delay of the procedure, what do you think that if we are in safety culture versus on non-safety culture, the reaction toward that stuff? I wish this is more interactive, but because it's online, in safety culture, she gets thanks by the physician and the manager thanks her and her action becomes a story told in the organization. However, in not a safety culture, people will whisper about her and she will get grief from charge nurse in the procedure area for messing up entire schedule. And physician demand that a person low in hierarchy, low grade cannot delay a case again. And she says to colleagues, I will never do that again. Culture of safety, how it came before 1990s, it was used to be a punitive culture where fear of retribution and decreased reporting and workarounds. So in mid-90s, they said, no, we should stop that and we should shift to blame-free culture. But this one even didn't work because here comes the lack of accountability. In 2000, they said, we need to apply something called just culture. So what does just culture? It's about transforming your safety culture from a culture of blame to a culture of safety. Instead of saying who did it, we will say what happened and why in case of incident. Instead of being punitive, we will be a fair and just. Instead of being pointing on people and say bad people, will say, no, we have a bad system and need to work on the system. Instead of penalizing the reporter, we thank the reporter for reporting. So instead of being confidential, we are now more transparent and learning. And instead of saying investigation, we are working toward root cause analysis. And instead of independent silos, we are inclusive and interdisciplinary team. So just culture, if I want to divide the word just from justice, it's acting or being in conformity to what is morally upright or good, fair, or fair, impartial. And culture, we already defined it. It's the sum of policies, procedure, conditions of employment, structures for decision-making, and types of behavior that are supported constitute a culture. The just culture is the balance between the blame and no blame. It's stressing more in system failures, improve patient safety, and encourage an open and fair culture. Its purpose mainly to create culture that truly support learning, justice, and accountability, develop common understanding about how to treat staff when errors happen depends on their behavior choice, not on the severity. Strive for culture that balance the need for non-punitive learning environment with the equally important need to hold person accountable and seek to judge the behavior, not the outcome. What's our problem as a human? We usually go toward outcome bias. What do you mean by outcome bias? Let's see this scenario and we'll elaborate more. This is a scenario for experienced surgeon who sees a new piece of equipment at a conference. Back at the hospital, sales representative persuade him to use the equipment for procedure. He has never used the equipment before and accidentally punctured the patient bowel. The hospital has a policy saying new equipment will be officially approved and training will be conducted prior to its use. They did a survey and to see what actions will be taken for physician if no harm resulted and what action will be taken for physician if harm resulted. And we'll see here how many says no action or warn not to make mistakes or encourage different behavior or disciplinary or punish. If no harmful outcome, they surveyed staff, manager, executive physician. As can you see from here, the slide, discipline or punish, the staff 19%, manager 0%, executive 11%, and physician 0%. So they show low percentage for disciplinary punishment. However, when they said, how about if case there was a harmful outcome, the patient was harmed, the disciplinary punish percentage increased. As you can see here, the staff become 29%, managers 50%, executives 14%, and physician 45%. So how do we judge and how we allocate responsibility between individual and the system in which they operate? We should have a mechanism to assess the individual versus system accountability and must be in place and should be through standardized process, not based on the severity. As again, for just culture, we need to act based on the behaviors. And we should use a standardized method to work across all value and all departments and not to be biased by the outcome. So we must avoid outcome or severity bias. These are the core beliefs of just culture. The 5 core beliefs are: to err is human, to drift is human, risk is everywhere, we must manage in support of our values, and we are all accountable. We must believe that not allow a severity of outcome or harm drive response or risk, and we must be just in our restoration of first and second victims. If I ask you who's the first victim, of course you know that is the patient. The second victim is the staff involved in the incident. And now they are talking about the third victim, which is the organization. So what we must believe: to err is human. No one is immune. Yes, we don't come here to harm patients, but however, it's our nature. To err is human. Human error is not a behavior choice. So this is where we focus on system and how we can prevent it. To drift is human. This is the drifting or the lapses or the workarounds. No one is immune. And many times we really drift as a choice. It's our behavior and unknowingly creating a risk. Why we drift? Because we wanted to expedite the work, or we think that this is justified, or no harm, or we are experienced. This is usually most of the time happen with the most experienced staff, the drifting or the lapses. And we must believe that risk also is everywhere. As I mentioned, that we are working in a very complex system. Medicine, it used to be simple, now it's becoming more complex. So risk is not inherently bad, and healthcare can be safe, but not risk-free. So which risks are worth taking? This is what we need to think about. We must manage around our values, safety, or freedom from unjustifiable risk. So the just culture pyramid, as you can see, it comes from the bottom to top. It's creating an open, fair, and just culture, and creating a learning culture with designing safe system and managerial and staff choices to prevent the human errors and adverse events. The 3 behaviors to expect in just culture. The first one, which is not a behavior choice, is human error. And we agreed it's an intentional behavior, inadvertently doing other than what we should have been done, mental slip, lapse, or mistakes such as miscalculating a dose, forgetting to dilute a medication, or transposing doses of 2 antibiotics while prescribing medication. However, behavior choices, we have the 2 things: the at-risk behavior and the reckless behavior. At-risk behavior, which is the drifting, which in behavior shows increased risk where risk is not recognized or is mistakenly believed to be justified. Reckless behavior, this should be the, I doubt that it should be the minimal, and we shouldn't find it, where behavior to consciously disregard substantial and unjustifiable risks. So human error is doing what should have been done. I will make mistakes. Risk behavior, increased risk where risk is not recognized or mistakenly believed justified, so I will drift. And reckless behavior, consciously you disregard a substantial and unjustifiable risk, which means I will knowingly gamble with others. So as per the just culture algorithm, these are the 3 behaviors and how we can manage. Human errors, which are product of our current system, design, and behavior choices. We manage it through choices, understand why he had the choice, processes, procedure, training, design, environment, so we consult. At-risk behavior, which is risk believed insignificant or justified. So we remove incentive for at-risk behavior and create incentive for healthy behaviors and increase situation awareness, so we need to coach. Here comes the red line when we are shifting to reckless behavior, which is conscious disregard of substantial and justifiable risk. and it should be managed through remedial action or punitive action. Exam of risk behavior, for example, I know this is an isolation room and I should wear the full PPE, and I decided to go without PPE. So this is pure reckless behavior. Not identifying patient correctly, one of the red rules. And I will come now, the coming slide about the red rules. So two things under control, the design of system and your behavior choices. And where accountability towards system or human, systems are accountable if error were driven by faulty system, which lead to human error. For example, there was a delay of medication administration because the system was down. So it's not staff failure, it's mainly the system failure. Human, when the staff know that this is the time to give the medication and he said, oh, no need to check the patient, or I didn't check his pain level and give him his pain medication. So if errors were driven by wrong human behavior choice, such as at-risk or reckless behavior, this is here human are accountable. Employees are accountable for their own performance consistent with their role and organization values, to act in ways to avoid harm to patients, for respectful behavior, report critical events and good catches and our own and others, stop any potentially unsafe acts by saying these safety phrases. I have a safety concern, let me ask clarifying question, stop the line, I need clarity, validate and verify. And what I teach the staff always, it's no problem to not to know, but it's a big problem to not to find out. Employees are accountable also to identify unsafe system or accidents waiting to happen. Know what resources we have, colleagues, leaders, policies, procedure. Use memory aids. Identify gaps in policies or procedure and speak up. Participate fully when critical event happen to learn what went wrong and how we can prevent in future, not to hide it. Contribute to the design and implementation of reliable system for care and service. Who can help you in really improving the system are the frontliners who are working. They are dealing with the patients. So those are the ones who can tell us what best system can be implemented. So accountability starts and no blame stop when practice is important and works, when systems have been fixed, when unintended consequences have been addressed, and providers understand the practice is value, the auditing strategy and the penalties, and single transaction has led to warning. I want to just to highlight something we really also introduced to draw the line for the accountability, the red rules. What do you mean by red rules? Red rules, from its name, red, it's like a warning. It's few numbers and easy to remember and associated only with processes that can cause serious harm to employee, customer, or product. It must be followed exactly as specified except in rare or urgent situation. It's the same from its name, designate the highest priority for exact compliance and stop the action if you cannot comply. Examples like timeout that should be performed prior to all procedure. The two forms of patient identification. Do you accept that you give medication to the wrong patient without proper identification? Reconciliation of sponge count. All specimens that should be labeled at the patient's bedside. Other exams include to not only organization, but sometimes departmental specific red rules, like standard lifts is a red rule in one of the hospitals rehabilitation. In some respiratory department, red rule that ventilators shall be plugged into red emergency outlet. So we shouldn't misuse the red rules and we shouldn't just make it so that we can get more compliance in the policy. As I mentioned, it should be limited and specific for something really that we really to be accountable on. So it must be possible and desirable for everyone to follow every time in a process under all circumstances, except if there's really something urgent. Anyone who noted that the red rule has been breached had the authority and responsibility to stop further progress of patient care associated with the red rule to protect from any harm. Managers and other leaders, including the Board of Trustees, support the work stoppage and immediately begin rectifying the problem and addressing the underlying reason of breaking the rule. And people who breach the red rule are given opportunity to support their behavior choices and then judged fairly based on the reason of breaking the rule. And should be few, well understood, and can be applied. So it's a move from common practice to best, from the best practice to common practice, set expectations, define safety behavior, educate the staff, and reinforce and build accountability. You might have some challenges. So staff review of correct processes, make sure that staff, they know what the correct process to ensure compliance, policy revision to ensure consistent language, and tied event reports to identify red rules violation with HR and focus on identify top opportunity with red rule. So what we can control as we are practicing, so it's for the system and our choices, our behavior choices. So if we have a reliable system that it's minimum risk, risk-free with the good choices and behavior, we'll get our good outcomes. So these are human choices. This is an example how the behaviors. So the 3 duties in the just culture, the duties don't do and how to and to do. Duty to avoid causing unjustifiable risk or harm, which is don't do. Duty to follow a procedure rule, which is how to, and duty to produce an outcome to do. This is the example of the just culture algorithm. You might see that it's complicated, but it's an easy. It defined the 3 duties. The duty to avoid causing unjustifiable risk or harm when risk and value-based quality choices, organization, management, or risk. The duty to follow or procedure rule, which is most of the time, process-based system-based compliance check, and duty to produce an outcome, which is task-based, outcome-based, rate-based. For each one, you have an algorithm. And I want to just remind, the use of just culture cannot be done without doing the root cause analysis. After you do your root cause analysis, you come to that algorithm and see what was the behavior or choice so that you can put an action. So you will ask yourself, was it employee's purpose to cause harm? If yes, so you consider punitive. If no, did the employee knowingly cause harm? If yes, was the harm justified? If yes, support employee. If no, consider punitive. If no, we will. So it's self-leading. And it's better to have it as a group, not so that to avoid any bias in their decisions. This is the duty to follow procedure the same, and duty to produce an outcome. If you're in doubt, sometimes you might get, okay, which one to use. Most of the time in our healthcare, the procedure, duty to follow procedure rule or produce outcome are the most common. But if either one, if you use, you will end up to the same results for the same incident. Also for repetitive human error and repetitive at-risk behavior, they have also an algorithm that you need to follow, because repetitive at-risk behavior is like a shift to a reckless behavior. This is another example of decision tree, also for just culture from another hospital. So it's either way, but at the end, all are they talking the same about the 3 behaviors. So the just culture is a journey. It's not something happened in one day with the safety culture. And those who did the safety culture survey in their hospitals, all of the blame-free culture, this question always getting the lowest scoring. We are still having some barriers in implementing the just culture, or understanding not the blame-free, the justice, which is the balance between blame-free and no blame, and the blame. What are the barriers to implement just culture? Leadership, if not clear about just culture. Managers, not sure how to incorporate concepts into practice. Staff suspicion, flavor for the week, human resources, quality and risk not on the same page. Unhealthy culture, small population staff or large population staff, either way, their beliefs of their culture and their work. The external pressure, the regulatory affairs, the unions, even in the States, when they apply the just culture, we are still challenged with the regulatory, when the incident goes to the court, you still, sometimes they are not really following the just culture. They will just apply what's in the court. A lack of support. So to have just culture journey implemented well, you need first of all to have executive and leadership commitment, and build champion teams in different healthcare providers. Champions that lead the change and update policies so that make it easy to follow. Update practices, design systems to reduce prejudice and prevent discrimination. Train all leaders and develop learning culture. Leaders and even the end users to understand so that they speak on the same page. Refine learning system. Train all employees and measure your progress and survey beliefs. You need to collaborate with HR, which each incident where staff got a punishment or warning. You need really to say, was the just culture was applied? Also assemble or investigate for patient safety information. Give time, attention, and passion to patient safety issues. Avoid being defensive or justifying errors. Create environment that welcomes suggestions. Do your workarounds, executive workarounds. Listen to your staff. Encourage employee frontline staff to speak up and share learning for patient safety. Facilitate your communication and teamwork, and take action when concerns are identified. Assure employee that full communication and reporting of safety focus on system vulnerabilities. Begin an investigation to identify type of behavior action that led to safety incident. Use the just culture algorithm after investigation is complete. Again, it's not at the beginning. After you do the full investigation, you apply the just culture algorithm, and both system and behavior have been identified. Apply appropriate just culture in determining the right course of action, and share with employee the outcome of the algorithm. Was it human error or at-risk behavior? And provide him or her with any guidance accordingly. Give employee to ask a chance to ask questions regarding just culture algorithm. Document the just culture outcome course of action. Share documents, consulting and coaching or notice disciplinary action forms and the selected algorithm with the HR. And HR should monitor and validate or receive investigation forms. And if there's any disciplinary action with the quality team. So what's the culture? Yes.
I'm so sorry to interrupt. I'm really enjoying this, but can we wrap it up quickly?
Yeah, sure. Yeah, sure. So this is it's a set of beliefs and set of duties. I will just skip here. So culture of safety looks like teamwork, open discussion, reporting, focus on system and ongoing learning. Its mistakes lead to learning. Systems are revised. Policies and procedures are reinforced, and response to error is non-punitive. So my take-home messages: human error and drifting, this should be expected. This just culture is really a value-driven. Severity of outcome must not dictate your responses. Red rules should be few in numbers, clear and obvious. Just culture algorithm is a valuable tool and should be the standardized approach to follow. Implement just culture requires stakeholders buy-in and the support from leadership, and essential to engage frontline staff to ensure continued success of both nascent and established just culture program. These are the four parameters of just culture. Competent professional make mistake in complex system. Even competent professional will develop unhealthy norm. Balance and non-punitive blame-free environment with accountability. Zero tolerance for reckless behavior. Before I end, just a quick question. I'm not sure how many are there in the on-site and online. So which of the following is not true about the management of risk in just culture? Can you answer? Carol? Do you have somebody there or online? They can type. Okay, the answer is risk is inherently bad, so healthcare should be risk-free. The other question, which of the following are core values in just culture? It's all of the above. The idea humans are fallible and systems can fail, increased error reporting, leader accountability. Thank you. By this, I end my presentation. These are the references. As I mentioned, this is cannot be just given in 25 minutes. It needs a workshop, but really I enjoyed presenting it, and I hope you liked it as well.
I did, and thank you very much. And I'm so sorry that I had to interrupt you, but I personally actually do want a copy of your presentation. It was very well done.
Thank you. Do you have any questions? Nothing? Okay.
All right. Thank you so much.
Thank you.
Our next speaker for the afternoon is Dr. Tara Prunoff, who was from India, and he will be talking about job satisfaction. I'm handing it over to you, Dr. Tara Prunoff. Sorry.
Manuela, thank you so much. It's been a wonderful conference. Are my slides visible?
Yes. It's there near minimize button, down, bottom. The first option, yes, this one.
Here. Thank you so much. I'm presenting the talk on job satisfaction of nurses. My guide, Dr. Surekha Kashyap, ma'am has taken retirement and she is a professor in hospital administration, and my co-guide, Dr. Bharat Kumar. Sir has been instrumental in helping me sorting out the problems. So the sequence of my presentation is I introduce the subject, give a few definitions of job satisfaction, professional commitment, organizational culture, give a sort of relation which I have found out from the literature, and then the methodology of what I did and inferences, what can be done. So to introduce, if we consider a person as an individual or an individual in the whole environment, what is he or what is she? How well the individual can be defined in relation to the environment. So if we consider individual as X and the environment which is infinitesimally large as Y, X and Y together will make the universe. Like it's a mathematical example just to explain a simple topic, a very simple topic. X is infinitesimally small. Like to exemplify, where am I or in the whole environment, in the whole universe? I'm hardly anything, but I exist. When I consider X relative to Y, X approaches to 0, while Y approaches close to infinity, or actually the infinity. Now, when the frame of reference goes on to the individual herself or himself, this individual becomes a capital X. That is, the individual assumes the size of the universe. So that means in the environment, in the work environment, when the individual workers become egoistic, become self-centered, they don't get attached to each other, the X becomes a capital X, almost equivalent to the universe. The universe thereafter, the environment, is as good as 0. A self-centered person will be like that, wherein the blue part fills up the whole universe. It is only the individual alone. But when we consider the environment important, the whole box becomes white and the blue becomes a small dot, a speck of dust. So why not take X as a function of Y? Y being the environment is much larger. Now this individual becomes a force to reckon with. This means in the environment, where are we? There's a lot of Manuela, did you are you getting it? Like, am I clear? So for job satisfaction, going into management studies of the healthcare environment, in defining the definition of the individual and the environment, this self-centered nature of the X and the wholesome figure of Y becomes a nurse who is working continuously in the environment of a matrix organization of the hospital. This white of the environment has doctors, administrators, patients, colleagues, super specialists, specialists, medical officers, nursing superintendent, healthcare workers, lab technicians, radiology technicians, security personnel, and whatnot. The nursing fraternity, when you consider each nurse, that blue dot becomes a small speck in the whole environment of white. If this X becomes a function of Y in a close-knit environment, the performance of this individual will be phenomenal. And if we just think the work will always be done this way or maybe that way. But what is the utility? The question mark here is for the driver. As Krugman said, economics isn't all about wealth, but a pursuit of happiness. If we go on to the theory of Maslow's, the behavioral theory, wherein we have a pyramid, right from the basic needs of safety, security, thereafter self-actualization. Or we go on to the management theories of X and Y. A worker never works satisfactorily. He only works when he gets a stimulus. And why? Wherein we say that every individual works. It is how we get the work done. So the question mark is the factor we are talking about. Job satisfaction. Job satisfaction is the measure of content or relatedness an individual who in the system is becoming an employee has to current position one is holding in that organization. This relatedness is defined as job satisfaction. We go on to another factor that is of professional commitment. You must have heard people saying, if a nurse is professionally committed, he'll never be or she'll never be wrong. A nurse is a patient's advocate. A nurse can go and question the doctor. Are you giving it right? The treatment given here is wrong. We can delay this drug, so on and so forth. In the quarrel, in the situations of conflict, fraternity often gets battered. You are not committed. You have to be professional. Then the healthcare goals will be achieved in the organization. It may be a public organization, it may be a private organization. Alike. The situation goes alike. Now, alignment of professional commitment with the commitment of the organization makes the situation win-win. It defines the level of dedication, the level of relatedness one has in the profession. As we see in the background has the photo of Florence Nightingale, none other than Florence Nightingale. The Crimean War saw her and made her famous. It was she who defined the care being given to the modern society of patients. Or into the Crimean War, it was mainly the soldiers who were wounded. The organizational culture. It's an anthropological concept of culture and related concepts that reveal the deep structure of organization, how good or how bad the organization is. Now, if we go on to the relation, where do these two factors go and where do they take us? The job. If it is aligned in the right path in the organization, the personnel, the nursing staff will definitely stay. If the professional commitment takes the U-turn, the turnover will be high. So if we see the gray part, the gray here is very scattered. The gray here is very dense. So it is this granularity which defines the value of job satisfaction. For a bird's eye view, job and work will continue to be the same, but they are not in silos. They are the same, but there's a big but. The work being done by the staff, and job, what the job was what was assigned for the staff, what was expected of her or of him to work in the hospital for the betterment of patients. Here, I like to mention the theory of completeness. One of the scriptures, Ishavasya Upanishad, says this theory of completeness. Purnamada Purnamidam Purnat Purnamudaccha means if we see the yellow and the blue, both are complete in their own ways. The job is complete and the blue is blue, work. That is also complete, but complete in their own ways. It is from the duty our rights arise, and it is from the rights we have. The duties take a cue. In entirety, the duties are complete and the rights are also complete. So complete is each and every staff. Never can I, as a doctor or as an administrator, say that you have not done your work. Making a statement is very easy. This theory of completeness defines that each and every aspect of the system is complete. If we take out a part of the complete, the remnant stays complete too. So going to the methodology, I did a cross-section study based on structured questionnaires taken from established studies. It was carried out in the tertiary care teaching hospital on the nurses and nursing assistants, done over a period of 2 years. For organizational commitment, this was the list of questions asked, and then the responses were taken on 5-point Likert scale. This list of questions is for professional commitment. So I took responses on 2 scales. That is for the organizational commitment, how committed a nurse is to the environment of the in this case, it's the government hospital wherein the nurse is working. And the other parameter was that of professional commitment, and then compared. From this, I went on to give a few cues. This was a poster on staffing. Wherein the resources are, as always, limited. Yes, they are. Health is always in priority. Time is always valuable. Time of doctors, time of nurses, time of the administration, time of the patients, time of the relatives who are coming there to ask for their relatives. Isn't it? So, a zoning of the hospital is by and large important. An outcome is health for all. Next, problem statement. It was the healthcare staff which becomes complacent. I'm not able to.
Just press it, Control Z.
Yeah. A healthcare worker who is working in the red zone. A red zone is a high pressure zone where a worker is prone to get infected. A worker who is in the red zone is prone to infect others once he is out of the hospital. So, deployment of the people who are once they are out of the red zone, we came to this conclusion that if that person is given rest, he goes there, takes rest. He thinks, he accumulates the stress which he has borne in that environment. Next, the person should be employed in the green zone. Green zone, what important? Main area of the green zone is crowd control. Not much of infection, but it is more of logistics. What happens here? That person will retain the memories of the extreme environment which he has faced in the red zone. He has seen the patients complicated. Empathy will help him work efficiently. Once his duties in the green zone over a period of 2 weeks or 4 weeks, the person goes on to the yellow zone to relieve a lot of people who will further go ahead to the red zone. Now this person in the yellow zone is aware of the repercussions the patient faces in the red zone, is not able to talk, is not able to speak, was not able to do his activities on his own, and the kind of situation that the next of kin faces, not able to contact him, not able to give him the logistics, not able to give him maybe a glass of water, maybe a glass of juice. The person in this yellow zone, or the amber zone, continues to be aware, is more empathetic. The logistic management will be much, much better. If the same person being in the green zone directly goes into the red zone, what will happen? It will be catastrophic. The person might go into a phase of PTSD, post-traumatic stress disorder. So this was my presentation on job satisfaction.
All right. I was just making sure that you were finished. Thank you so much. I appreciate your talk today.
Thank you.
Thank you.
Manula, the last slide is of the matrix journal.
All right.
If you see the last slide, the matrix.
The matrix, do you have it? Sorry, we cleared it. I don't have that slide to show at the moment.
Okay, I'll just show you.
Yeah, he can share it.
Is the slide seen?
No.
No, we can't see it.
Okay, just a minute.
How do you see it?
This slide, although, is the slide visible?
Shall we?
The slide, although it says 2 words, thank you. The backdrop shows the matrix. The matrix reloaded, the matrix innate, the matrix of future, complicated matrix of emotions, ideas, vulnerabilities, complications, uncertainties, adversities, a matrix of love, brotherhood, care, empathy. This matrix can go on and on for generations together, making the environment congenial, making each and every staff of the nursing fraternity feel wanted.
Thank you so much.
Thank you. It was great.
Yes. Our next speaker for the day is Sharmista Nai, and she will be speaking with us today on healthcare marketing. Sharmista, are you there?
Yeah, hi, good evening.
Hi, welcome aboard.
Hello. Hello.
Yes, Mr.
Yeah,
Yes, ma'am.
it's
Ma'am,
visible.
you're
Can I
audible.
start?
Yes, ma'am.
Yeah. Good evening, everyone. Thanks to UCG to giving this opportunity to present a lecture on the healthcare marketing. Healthcare marketing is the very big subject. I'll try to cover in this 35 minutes. I'll go with the definition. What is the marketing? The marketing is the management process that identifies, anticipated, and satisfy customer requirement profitability. Healthcare marketing objective, patient acquisition. How do I get more patients coming to my facilities? Patient retention. How do I get my patient continuing to use my facilities? Patient win back. How do I bring back patients who have not using my facilities for some period of time? New movers. How do I attract prospective patient in my facilities footprint? Now we'll see who are the connects with the healthcare marketing. So there are three components. One is the patients, second is the doctors, and third is the providers. If patient is not there, then there is no required marketing. If doctor is not there, then there is no required branding. If care provider is not there, then there is no meaning of the healthcare marketing. So these three are the, hello?
Can you please share your screen?
Is it okay?
No. No, yes, it's fine now.
It's okay now?
Yes.
Yeah. So marketing strategy, it's by Google source, we can define that 90% patient use online review to evaluate the doctors. 5% of all Google searches are to related to healthcare. 88% of healthcare appointment scheduled via phone. We know every healthcare industry now using the lot of technology, and most of all healthcare appointments is scheduled on the online. 66% of internet users searching about healthcare information for specific medical problem or disease. Healthcare marketing strategies continue with the 88% of those searching for healthcare information start with the search engines. 48% before booking, patients took over 2 weeks to research before booking an appointment. We know nowadays the social media is very active, so there are different tools where we can show the healthcare marketing, where we can check our status with our organization status. We can check which doctor is good, which hospital is good, which hospital technology is good. Prospective patients find this the most important areas where researching a doctor or medical practice. If you go with this again Google data, then the 94% reputation of the facility, whenever patient, they are choosing the hospital, yeah, they are selecting the hospital, they go with the reputation, which hospital is good, which hospital is bad, which hospital is average. So they are going with the Google review. 90% of insurance is accepted by the facility. So majority patient nowadays, they have insurance. So they will check the insurance facility, whether this hospital is having an insurance facility or not. 86% recommendation by another physician that we call as a referral doctor. 85% uses the latest technology, and 51% recommendation by friend or family. Now we see the 6 fundamental healthcare marketing elements. First is professional referral marketing, a reliable and continuing stream of inbound patient referrals from other medical, dental, or other professional sources is the lifeblood of many specialty providers. Internet marketing, from website and social media tools to patient portal and mobile app. Online marketing is a mainstream channel for marketing, advertisement, and public relation. Then continuation is a branding. This is all about standing out from the crowd in a positive way, and it is include virtually everything you do. A powerful differentiating brand for your healthcare business is a part of your reputation. Internal marketing, this is heading include all the way and means that you communicate with people who already know you, primarily present and previous patient, depending on the nature of your practice or situation. This influencing audience can be a rich resources for referral, additional service, testimonial, and word of mouth advertisement. Fifth is external marketing, how we can do the external marketing. These are the media that reach prospective patients that don't know you. Advertising is newspaper, radio, television, billboards, and the like target an audience that needs to know that you provide an answer for their healthcare need. Wherever we are doing the external marketing, we have to confirm that what message we are going to give to the patient so we can increase our patient portfolio. Public relations. This heading includes, among other things, planning and generating healthcare publicity and broadcast interview. The end result look easy and it can be a positive and powerful influence, but free praise typically result from careful planning, good timing, and clear message and deliberation effort. So there are different healthcare marketing plan. Whenever we are doing the marketing plan, we should know what message we want to give to the media. We should understand which product we are going to sell. For example, it is a medical patient marketing, is a surgical patient marketing, is a pediatric patient marketing. So that we have to understand first which kind of product we are going to sell to the media, to the patient, to the market. Based on that, we have to clear about our message. Because when we are doing the healthcare marketing, patient will come with the clear message. If you are just sending the message that we are coming with this scheme and we have a good scheme or we have a fancy hospital, patient will not come. So whenever you are doing marketing, you have to clear with your message and the media. So one more important thing, these are the different area how we can do the marketing. But thing is how to improve the marketing. So first is invest in content marketing. Content marketing has power to be one of the most effective ways of increasing brand visibility and attracting new customers. Patients nowadays are more proactive when it comes to their health and want to educate themselves on important medical matters before contacting healthcare providers. Digital strategy, we all know nowadays all are using the digital strategy. Digital marketing is one of the big subject, and every organization, every healthcare industry, they are using the digital marketing, which is the mobile, CRM, email, that SEO engine and everything. Take advantage of video. Whenever we are taking the testimonial, it should be to go with the clear message. The biggest appeal of video is it is entertaining and approachable nature. As a medical business, you might object that entertainment is not your aim, and we have to agree. But do keep in mind that people retain information much better when it is presented to them via video. It is much more effective to explain complex topic or introduce your business to an audience through video. Create a convenient website. Most will argue that digital marketing linked with a website and they want to be far from the truth. But if well-designed website that guide the user through their online journey is a prerequisite for any modern company. For example, whenever we are doing the marketing or whenever we are developing our website, on website, whenever we are giving the message, the first message should be the clear. There should be the detail if in case any patient searching that website, he or she should be the take proper information from this website. For example, if patient wants to do the online appointment, there should be facility on the website. If patient want to call on the any registration people or the concerned doctor, there should be the clear number of this website. If patient ask any question, there should be the clear chat opening message for this website. If we are giving this all solution, I think this website is one of the best solution for the healthcare marketing. Incorporate social media. Your business online presence also extend to social media, as it is a more convenient way to stay in touch with your audience on regular basis. Social media platforms are amazing medium to share short piece of information, update news and other content with your patient, and by doing so, keep the connection between you and your audience alive. Have an omni-channel approach. However, based marketing we are doing, whatever social media we are using, whatever good facility we are providing, but till our team if don't have an omni-channel approach, that is called we have to show our customer that we are there for you. In case of any problem, it may be related their diagnosis, it may be related their facility, it may be related to any other services. A team has to show that omni-channel approach, that whatever problem they are having, the team will resolve this problem. Till we are not having this omni-channel approach, the healthcare marketing is no value. Build a strong healthcare brand. A strong brand differentiates you from competitor, painting a clear picture of who you are, what you stand for, and how you can help customer in a way no other business can. Identify what makes you different from other medical brands, such as your logo, value, services, tone of voice, customer care, and you will have built a strong, recognizable brand identity. Know your patient. Apart from making sure your patient know you, it is also your responsibility to get to know your patient. It is not about remembering every single client by their personal information, but rather finding common characteristics among your customer based to form a clear understanding of who your audience. Monitor your online reputation. 94% of patients consider the reputation of the facility when they are searching for a doctor or medical practices. Online platforms have made brand reputation more transparent and accessible than ever before, magnifying the impact reputation level on a business. Thus, online reputation management should be an integral part of digital marketing. Implement innovative solutions. As we live in a world governed by technology, patients tend to put more trust in healthcare facilities that are equipped with modern technologies and offer innovative solutions to clients. If you have the budget for it, invest in medical technology and software to improve your service and stay up to date with current standards. Focus on patient experience. In today's broad market, patients have more options than ever to choose a business that will best serve their needs. And enhanced patient experience can help your company stand out and gain competitive advantage in the healthcare market. One most important thing is whatever marketing we are doing, but important thing is patient satisfaction. Whatever we are doing, we must have to take care of our patient. So whatever we have to do for the patient satisfaction, we have to train our team that how we can improve the patient satisfaction. With that, what is the important thing, like the wait, how we can reduce the waiting time, how we can help them for any of the problem, how we can go with the digital marketing, how we can help them for the admission process, how we can help them for the discharge process. So these are the very silly things. Sometimes happen that patient is all right till the end of the discharge, but because of the so many small issue, patient is getting dissatisfied. So this is a very important thing right from entry to exit. How we can make our patients satisfy more, that we have to train our team. Physician reputation matters. Your medical scientist reputation is directly linked to that your physicians. After all, they are the heart and soul of your business. So whenever any hospital is famous or any hospital is reputation, it is first important thing is based on the doctors. So whatever doctor you are selecting, whatever surgeon you are selecting, you should know they are thorough with the good experience, they are thorough with a good clinical practice. Helping a doctor will then maintain a respectable reputation, and effectively showing it online will boost your brand overall image. So these are the different strategy and the improvement plan of the marketing. But last but not least, I'll show the some point which is very much important for the every healthcare organization, and that is the role of internal team. So whenever we are talking with the healthcare marketing, out of the budget, how we can train our team so we can improve our organization or any hospital healthcare marketing. So first, everybody has to ensure that everyone understand that the customer is a king and they are ultimately provide the money for their salaries. If there is a no patient, then there is a no requirement of the staff, and there is a no patient, there is a no requirement of the any healthcare marketing. So first, we all have to understand the patient is the king. They are the almost on the first category and priority of the any healthcare organization. Multiple studies show that employee satisfaction leads to the customer satisfaction. Customer satisfaction leads to the increase the profit. So employee is our internal customer and our patient is our external customer. Till our internal customer is not satisfied, we cannot make this satisfied to our external customer. So organization have to take a lead how we can increase the satisfaction of our internal customer to lead the satisfaction of our external customer, that is our patient. Loyalty is increased as an employee become a stronger brand ambassador. Employee engagement is of high importance in a competitive employee landscape. Limiting turnover, reduce the cost of searching, hiring, and training new staff. Be open to and encourage employees' ideas for improvement and efficacy. Ensure that training and opportunities for advancement, promotion, and career development are available for the workforce of all levels. Sometimes what happens, we have a very good employer, but because of we are not regularly meet them, it may happen that employee, they have a good ideas to improve the organization marketing, to improve the image of the organization. But because of lack of training, lack of support, lack of engagement activity, many organizations, they are missing this criteria to improve the healthcare marketing. So every organization has to understand with all the prospective like the internal marketing, internet marketing or the digital marketing, your employee, which are this employee, they are the frontline worker, the PRO, the nurses, the technician, they are their frontline worker. Finally, they are going to take care of our patient. So till they are not getting satisfied, it is difficult with a lot of brand or the lot of advertisement, we may not get the patient satisfaction. If the patient satisfaction is not good, then it is really difficult to improve the healthcare marketing. Reduce state at workplace from confusion and care. Delegate responsibility to that individual understand and can take a pride in the contribution. Ensure people are properly paid for the level of their responsibility. Ensure that the company objectives are disseminated to all level and are understood. So this is the out of this all criteria, as I told you, the internal marketing is one of the most important thing where everyone can give their full efforts. if we are giving the full opposite that, then we may have to spend less money in the outside branding and the marketing. So every organization and every healthcare team, they have to understand how much important of the internal marketing. So this about the healthcare marketing is again no doubt very big subject, but I have covered in this slide. So I hope this is the good enough for this today's lecture. If anyone have any question, you can please raise your voice. Hello? 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 Hello?
We can hear you. Thank you so much for your presentation.
Okay.
Yes, so now we'll have a coffee break and we'll join again after some time.
Okay. Thank you
Okay,
very
it was
much.
a nice presentation. Thank you so much.
Thank you. Thanks to giving this opportunity. Thank you very much.
Thank you. Whom to invite now? Carl, right? So you can announce.
Tomorrow.
Is here. Hi, everyone. Welcome back from the coffee break. I would like to invite now Mr. Carl Dolling. He's from UK. He's a registered paramedic. Will tell us about existing frontline barriers that impact a clinician's delivery of advanced life support out in the pre-hospital setting. Welcome, Ms. Carl.
Thank you very much.
Welcome.
Hi, everybody. I hope all is well and you're enjoying the conference so far.
Yeah.
Now, I just need to bear with me on this. I'm just going to share my screen. It's been a while. Okay, here we go. I'm going to present a presentation that I've prepared. Screen. Start. Right. Okay. Can everyone see that? Here we go. Hello all and welcome. My name is Carl Dowling. I am a paramedic in the UK and I have recently just completed my BSc in paramedic science. I am going to be discussing a paper today that I recently wrote relating to advanced life support procedures out in the pre-hospital setting. The title of the paper is Existing Frontline Barriers that Impact a Clinician's Delivery of Advanced Life Support Out in the Pre-Hospital Setting. Okay, let's begin. Advanced life support, known as ALS, is a set of protocols used in cardiac arrest, which extend from basic life support in the aim to provide patients with further support in sustaining an effective airway with adequate ventilation and circulation. The Healthcare Professionals Council (HCPC) standards of proficiency state it is vital for clinicians to be able to modify and adapt their approaches to help meet the needs of the patients when presenting in the emergency care environment. Martin et al. Highlighted there are frontline barriers associated with paramedics that can impact their knowledge and skills when attending emergency patients in the pre-hospital setting. This article will explore the ALS protocols and further examine what impact frontline barriers can have on its effective delivery. Kondo et al. State the ALS algorithm is a protocol that involves invasive interventions such as endotracheal intubation for gold standard airway management and intravenous circulation for drug and fluid therapy. Saw et al. Further reiterates the drugs utilized after gaining vascular access in cardiac arrest is vasopressor drug adrenaline 1 mg intravenous IV or intraosseous IO, where it is given as soon as possible after identifying a non-shockable rhythm, such as a systole or pulseless electrical activity, PEA, or given after 3 shocks have been delivered for shockable rhythms, ventricular fibrillation, VF, or pulseless ventricular tachycardia, PVT. Another type of drug that is utilized in cardiac arrest is antiarrhythmic drug amiodarone. 300 mg after 3 shocks have been delivered, regardless of being consistent or inconsistent. And another half dose of 150 mg needs to be given after 5 shocks have been delivered, which also don't need to be continuous. Locke explained the first ALS guidelines were produced by the American Heart Association in 1974, whereby in 1992 the Resuscitation Council UK decided to develop the training for clinicians in hospital and the pre-hospital setting. In 2006, there was a new version adapted for clinical staff, which covered the recognition of the airway, breathing, circulation, disability and exposure, known as ABCDE approach. Berg state ALS protocols are updated on an ongoing basis. However, the additional major updates are made at 5-year intervals.
Welcome to a short video overview of the European Resuscitation Council's 2015 Guidelines on Advanced Life Support. I'm Dr. Jasmeet Saur, a consultant in intensive care and anaesthetics from Southmead Hospital, Bristol in the UK, and lead of the ALS Working Group. I'm going to focus on 4 things: the importance of high-quality chest compressions with minimal interruption, drugs and airway management during CPR, monitoring during CPR, and finally some technologies. ALS providers must still stick to the basics and give high-quality chest compressions and minimise interruptions. All interruptions and compressions must be planned with the team. Specifically, now this includes minimising interruptions in chest compressions to less than 5 seconds when assessing the rhythm or attempting defibrillation or tracheal intubation. The defibrillation strategy for the 2015 guidelines is unchanged, and chest compressions should continue while the defibrillator is charged. Regarding drugs, adrenaline and amiodarone may improve short-term survival from cardiac arrest, but their overall benefit or harms are unknown. Their use remains in the guidelines unchanged, although there is greater equipoise regarding their benefits and harms. The best airway option during CPR is unknown. Rescuers should use a technique or techniques that they are trained and competent to do. Most patients end up getting more than one airway intervention in a stepwise approach during CPR. For example, they may get bag mask ventilation, followed by a supraglottic airway device such as an iGel or LMA, or tracheal intubation during CPR, or if they remain comatose after return of spontaneous circulation. Only experts in tracheal Welcome to a short video overview of the European Resuscitation Council's 2015 Guidelines on Advanced Life Support. I'm Dr. Jasmeet Saur, a consultant in intensive care and anaesthetics from Southmead Hospital, Bristol in the UK, and lead of the ALS Working Group. I'm going to focus on 4 things: the importance of high-quality chest compressions with minimal interruption, drugs and airway management during CPR, monitoring during CPR, and finally some technologies. ALS providers must still stick to the basics and give high-quality chest compressions and minimise interruptions. All interruptions and compressions must be planned with the team. Specifically, now this includes minimising interruptions in chest compressions to less than 5 seconds when assessing the rhythm or attempting defibrillation or tracheal intubation. The defibrillation strategy for the 2015 guidelines is unchanged, and chest compressions should continue while the defibrillator is charged. Regarding drugs, adrenaline and amiodarone may improve short-term survival from cardiac arrest, but their overall benefit or harms are unknown. Their use remains in the guidelines unchanged, although there is greater equipoise regarding their benefits and harms. The best airway option during CPR is unknown. Rescuers should use a technique or techniques that they are trained and competent to do. Most patients end up getting more than one airway intervention in a stepwise approach during CPR. For example, they may get bag mask ventilation, followed by a supraglottic airway device such as an iGel or LMA, or tracheal intubation during CPR, or if they remain comatose after return of spontaneous circulation. Only experts in tracheal intubation should intubate and aim to do this with less than a 5-second pause in chest compressions. There is a new section on monitoring during ALS. Firstly, waveform capnography must be used to confirm and continue monitoring correct tracheal tube placement during CPR. It can also be used to monitor the ventilation rate, the quality of CPR. Higher quality chest compressions lead to an increase in measured end-tidal carbon dioxide value, and to provide an early indication of return of spontaneous circulation. A sudden rise in the end-tidal carbon dioxide can indicate a return of spontaneous circulation. This may lead to rescuers withholding adrenaline during CPR until after the rhythm is checked. Finally, a persistently low end-tidal carbon dioxide value during CPR may suggest a poor prognosis. The role of several technologies is included in the 2015 ALS guidelines. Mechanical chest compression devices may be useful in situations where sustained high-quality manual chest compressions are impractical or compromise provider safety, for example, during prolonged CPR or transport. Focused ultrasound done by trained rescuers with minimal interruption to chest compressions may be used to identify reversible causes of cardiac arrest, such as cardiac tamponade or tension pneumothorax. In patients who have a treatable cause of cardiac arrest, extracorporeal life support techniques may provide an artificial circulation while the reversible cause is treated and a spontaneous circulation restored. This is currently only available in specialist settings and not commonly used. All these technologies require training and monitoring of their use to ensure patients benefit. In summary, the main changes are: there is a continued emphasis on maintaining high-quality chest compressions with planned interruptions for interventions, such as defibrillation and airway interventions. We suggest a stepwise approach to airway management based on the skills of the rescuer. Waveform capnography must be used with tracheal intubation, and end-tidal CO2 values can be used to help guide interventions during CPR. And finally, technologies such as mechanical chest compression devices, ultrasound, and extracorporeal life support techniques have a role in specific circumstances.
Williams state ALS training is a mandatory requirement for doctors, nurses or paramedics who work in an emergency setting. Resuscitation Council UK state the importance for healthcare workers to recertify their ALS protocols within 1 year of completing their previous course to maintain an adequate level of skills and knowledge. Perkins et al. Explain more than 1.5 million healthcare professionals receive training in ALS protocols every year, which is achieved via instructor-led and e-learning training.
Hey, Carl, your
Abdullah et al. Highlight the
Carl.
positives of integrating an e-learning format in the delivery of ALS protocols onto healthcare.
Yeah,
Your video is stuck. Can you please check your internet?
yeah, sure. I'll try and do that now. Bear with me. Wi-Fi. Technology these days. It's great when it works. I've got
No,
Wi-Fi.
it's working fine. Can you please try now?
Yeah, sure.
As it allows for easier accessibility of
I'm trying to do that. Right.
Williams state ALS training is a mandatory requirement for doctors, nurses or paramedics who work in an emergency setting. Resuscitation Council UK state the importance for healthcare workers to recertify their ALS protocols within 1 year of completing their previous course to maintain an adequate level of skills and knowledge. Perkins et al. Explain more than 1.5 million healthcare professionals receive training in ALS protocols every year, which is achieved via instructor-led and e-learning training. Abdullah et al. Highlight the positives of integrating an e-learning format in the delivery of ALS protocols onto healthcare staff, as it allows for easier accessibility of learning materials, lower cost, and a more personalized learning schedule. However, Davis et al. Explain instructor-led training remains more beneficial, as it allows for the healthcare staff to utilize the simulation setting in a safe environment where trained instructors can provide immediate debriefing, whereas Reed et al. Emphasize the best way to maximize resuscitation education for healthcare workers is for the training to follow the Resuscitation Council guidelines, include pre-course reading, case studies, and practical simulations. Newton and Meir state that each learner can be categorized into one or more of Fleming and Mill's 1992 VAC learning styles, which include visual, auditory, or kinesthetic, whereby utilizing their learning style can improve the learning process. However, Busen state there is no evidence to suggest that utilizing a learner's individual style can provide a better outcome, whereby 73% prefer one learning style, 22% prefer to learn using two learning styles, and 5% prefer using all three learning styles. Furthermore, Bakari and Zafar reiterate that previous studies have shown that each individual learner adapts their learning preferences to their learning environment, thereby indicating an individual's learning style can be vital, as it forms part of the learner's intellectual ability, and ignoring this can put their learning process into jeopardy. Locke et al. Explain in recent years that ALS course structure has moved away from the predominantly lecture-based approach and adopted to a more participative focus, which includes group work, active participation, and formative assessment. However, Busen mentioned it is an educator's responsibility to create, facilitate, access to organize experiences, whereby enabling the learning process. Sheng et al. State ALS training is fundamentally delivered through a script based on current guidelines, whereby instructions are given during a 10 to 15 minute scenario in a step-by-step process. Palakia et al. Highlight that pattern recognition strategies utilized from scripted training can most often lead to decisions which are obtained analytically, which can cause an individual to not see the whole picture, and holistic assessment could be more relevant. Kovacs et al. State skill retention usually takes place between 3 to 6 months after initial training has been completed, whereby recent studies have shown positive results in preventing skill retention by retesting skills every 3 months rather than 12 months, as it can improve ALS efficacy and provide Gent highlight how paramedics are responsible for maintaining their own clinical competency by keeping up to date with their current practice and taking part in continual professional development activities. Busen states self-directed learning is an opportunity where adults can plan, evaluate, and conduct their own learning. Kindi et al. Explains self-directed learning has been utilized for many years, whereby it can help improve the quality of understanding in the subject matter and is noticeably more cost-effective. However, certain criteria must be met to optimize the benefits of the learning process, where it could impact the individual's understanding and strategy of learning about the subject criteria. Furthermore, Long expressed their opinion that it is essential for the practical use of self-directed learning for the individual to clarify all aspects of the concept, to prevent limitations in their overall understanding of the subject matter. Priyanthia et al. State that In previous studies, self-directed learning has been led to improve study retention for up to approximately 6 months when approached in a practical concept. Priyanthia et al. Conducted a study on the knowledge of attitudes in ALS among medical students and medical officers in Sri Lanka. The results of the study showed out of 411 participants, only 10% demonstrated inadequate ALS knowledge scores. Overall, only 8% were confident when selected and giving emergency drugs during ALS, which highlighted there are potential gaps in their knowledge. Cormack et al. Highlights a correlation between a lack of attending out-of-hospital cardiac arrests and clinical skill fade. Pasali et al. Suggested the healthcare workers who attended more than 5 cardiac arrests within a year showed greater knowledge and skills in ALS procedures, compared to healthcare workers who attended ALS training as part of their curriculum, but had not attended any arrests within a year. Dyson et al. Collected data from the Victorian Ambulance Cardiac Arrest Registry between the years 2003 and 2012 to examine the exposure of out-of-hospital cardiac arrest resuscitation and patient survival. The study highlighted the patient survival rate was lower when paramedics had not attended a cardiac arrest during the preceding 6 months. Ahmed et al. Defines medical errors as a preventable event, primarily resulting from healthcare interaction between healthcare worker and patient. Duarte et al. Explain human error can be related to the approach in the system through latent conditions such as barriers to communication, lack of standards due to patient exposure, skill training or absence of resources. Whereas Parker and Davis reiterate the importance of healthcare systems needing to continuously consider how to prevent medical errors and consistently develop in responding to medical errors when they occur. Graves explained through history medical errors were thought to be caused by individual. However, by examining errors through a systems approach, highlights human failings within a poorly designated system. Whereas a systems approach to error focuses more on identifying situations or factors that can lead to human error, whereby working to improve them and
So what's the last bit? Let's hope the video works. Just put it on now for you.
That's a Chromebook with the everything button. One button.
The patient care technician came to me and she told me, I need to let you see this screen. And she showed me the glucometer.
She saw the word high flash on the screen, and that's what she assumed was the result that she had.
She's like, I just feel like my blood sugar is really high. She's like, I don't feel good. I know my body.
And so there wasn't really any suspicion that it would be low. And so when this error message comes, it kind of confirmed that.
So we rechecked her blood sugar and the same thing popped up. So I covered her with some insulin and I called the physician. And by the time I got her back in bed, she became like non-responsive.
Ended up being a rapid response and requiring a transfer of the patient to the intensive care unit.
Nurse had misread the glucometer and called the physician, asked for insulin on multiple occasions, and the patient had a severe hypoglycemic event and had to go to the ICU before it was caught.
During the rapid response, we checked the glucose twice, I believe, and the same thing kept popping up, the screen that said glucose greater than 600. The next day is when I received the call that the whole time her blood sugar was actually critically low.
Shortly after this particular incident, another nurse made the same error where the machine it was an actual low value, but the machine read off this alert saying for a high, do X, Y, and Z.
It never came to mind that the glucometer was incorrect. It was probably the worst experience I've ever had in my professional career.
The nurse manager called our human resources department, explained the error, this is what happened. We didn't fully understand the ramifications of this piece of equipment and the message that it displayed. And they said, well, I think you need to suspend her until an investigation is completed.
I felt like I was talked to like a 5-year-old. I wasn't talked to like an adult. I mean, I'm a nurse because I come to take care of people, I come to do my job, I'm very passionate about what I do. And for a long time, it really shook me. Like when I came to work, I was scared to like take care of patients, and I was really apprehensive about everything I was doing. I wasn't really confident anymore. It really shook me to the core.
I questioned it with my boss, and she had the suggestion to invite some of the staff from the Human Factors Engineering Department in MI2 to come over and help us at least evaluate the process.
I got a call from the chief nursing officer at one of our hospitals saying that they had had a case. There was a design issue that might have contributed to the case, and they wanted us to take a closer look at it from a human factors engineering, safety engineering standpoint.
It quickly became apparent that there was more to the story than just that she had made a mistake, and that there was a lot more, that it wasn't just her, it was the actions of lots of people that led to this hazard, and it certainly could happen again.
You can't fault any one individual. That's a process problem that needed to be addressed, and the more we thought about it, the more we decided that we needed to fix the process.
The concept of high reliability, the concept of systems problems versus people problems, the concepts involved in human factors engineering, they become very familiar to us, those of us who are talking about them all the time. They're not as familiar to the people on the front lines. Our job is to be able to share that in an effective way, one in which they can actually use the tools and change outcomes.
The leadership, when they saw our analysis of the case, they supported the fact that Annie should not have been disciplined, and they reversed the discipline. And that was doing the right thing. And I think that sent a very important message to the staff at this hospital, that the leadership supports them and takes the systems approach to managing error.
There was a team there, and they were all like nodding, and they were all like validating. They were like, okay, so you know, you're not incompetent. Everything you're saying makes complete sense. And it was just like, it's like I could take a breath and be like, okay, I'm not crazy. And then when I was told by my manager, she pulled me in her office after it, and she was like, we're gonna take away the discipline. She was like, they actually said that we didn't treat you so fairly, and that made me feel better, and that was like a positive aspect of the experience.
We need everybody in our system, actually everybody in the healthcare industry nationally, to understand the systems approach and understand just culture, so that when we have near misses and when we have small little noticed hazards and unsafe conditions that we encounter day to day in our job, that we report it and that we look for trends, and where we can, we fix the system so that the next time that same error or near miss happens, we won't injure a patient.
The implementation of advanced life support protocols is vital in cardiac arrest, with improving patient outcomes. However, there are various factors that can impact the high quality delivery, such as medical errors and lack of exposure or training. By adopting a systems approach in healthcare, certain elements of concern can be detected and adapted to further strengthen the existing healthcare system. A good example of this could be providing more ALS training at more regular intervals, whereby healthcare workers complete their annual training and in between have online quarterly training sessions, which could help them to maintain their skills and knowledge. Another possible example could be the paramedics work on a shift rotation, as other healthcare professionals do in hospitals, which allow them to attend various sorts of jobs, as this will provide them with more hands-on experience in attending cardiac arrests, which will further strengthen the healthcare system, service delivery and patient care.
And that's it.
And thank you for this. Okay.
No, thank you for having me. And I wish everyone well and a better year for 2022. And be safe.
You too, sir.
Thank you.
We just want to say welcome to Miss Amal Ibrahim. Amal.
Hi, Miss Anis. How are you? Nice to meet you.
Yella, how can you not be here?
Actually, the borders are closed here in Palestine. That's why I'm presenting online today.
All what you need to do is get on the plane. Yalla.
Inshallah, at our next conference, we will meet physically.
Yes, and we will have coffee someplace, huh?
For sure.
Of course. Okay, Amal is going to speak about improvement in the address of chronic non-communicable diseases in Palestine through research, application of innovative protocols, capacity building, and community prevention. The floor is yours, Amal.
Thank you very much, Ms. Anit. Hi, everyone. Thanks for having me for today. Actually, I was planning to attend physically, but unfortunately, the borders are closed in Palestine. That's why I'm presenting today online. Let's introduce myself. I am Amal Ibrahim from Jordan. I am working as the project coordinator at Health Work Committee Association in Palestine and also the Middle East Organizing Secretariat in UCG. I am a certified professional in healthcare quality from National Association in the USA, also a certified in healthcare project management from American University in Washington, D.C. Have done a master's degree in health management and policy at Al-Quds University here in Palestine. Today, I will speak about improvement in the address of chronic non-communicable diseases in Palestine through research, the application of innovative protocols, capacity building, and community prevention in collaboration with the University of Jaén in Spain. And I will be leading this project. Before I start my speech, I just want to say one word, that you are the elite, because only very best people in healthcare field can have take time and come to attend this amazing conference. So thank you very much for participating with us today and hope to meet physically soon. Can you see my screen?
Hey, Amal. This is Priya.
Hi, Priya. How are you?
Yeah, I'm fine. So can you please enlarge it?
Where should I press?
Yeah, it's this one only. Yes.
Okay.
It's not
now?
okay. So can you click on minimize? Sorry. Yes, this one, right? It's not working. Okay, you can continue.
Okay, one moment, please.
You can continue like this. No problem.
Okay. As we all know, one of the greatest challenges facing health systems in the 20th century is the need to develop effective approach to address the improvement of chronic non-communicable diseases. Chronic diseases are complex and require a long-term, multi-phase response that coordinates input from a wide range of health professionals, essential medicines, and where appropriate monitoring equipment, all of which is optimally embedded within a system. Our project aim is to adapt intervention protocols on chronic non-communicable diseases to the current global pandemic situation caused by COVID-19, and the training of health personnel to contribute to improving healthcare for people with chronic non-communicable diseases. Can you see my slides carefully?
We can, but you need to move on to second one.
Yeah, I'm already in the second one.
Sorry?
I'm already in the second slide.
No, it is showing first slide. So just click on second. Can you move your mouse? Click on second.
From where should I click?
We can't see it still. Please click on second slide, double click.
One moment, please. Okay, I will say my presentation briefly. So the second aim for this project is to reduce the community impact, raising public awareness, and making the protocols available to the counterpart health centers more effective. The University of Hain, through the teaching and health professionals of which the work team will be part, will help transfer knowledge to implement the advantage of protocols used in health system in Spain, creating a space for generating knowledge on chronic non-communicable diseases of use to the public. The participation team will be the main one, University of Hain, the second one, Health Work Committee Association, and the third team is Al-Quds Association of Solidarity with the people of Arab world. The big blocks to be worked on are observatory, intersectoral table, protocols, review, and creation. At the end of our project, we must work on 8 protocols: health training and digital platform, public awareness, COVID-19 prevention workshops, prevention protocols, gender violence perspective incorporation workshop protocols. The general goal for our project is to contribute to the improvement of healthcare for people with chronic non-communicable diseases under the pandemic condition in Palestinian population of the West Bank. And the specific goal is strengthening capacities to respond to chronic non-communicable diseases through alternative and innovative solutions adapted to the current epidemiological, social, cultural, and political context in the West Bank in Palestine. The indicators that we are working on are that number of protocols generated in the framework of the project adapted to the new normality COVID-19 with a gender approach, implementation of the new protocols at the end of the project. For outcome result 1, which is about research, analysis, and knowledge on non-communicable diseases, the indicators are strategic documents for the constitution of the observatory, number cross-sectoral meetings held for the creation of the observatory, number of protocols analyzed. Outcome result 2, improved professional skills of healthcare. It will be percentage of the Health Work Committee health professionals participated in planned training, and also percentage of training attendance demonstrate knowledge equation. Outcome 3 and result 3, it will be about preventive practices. The indicators are number of people participating in awareness raising workshops, percentage of workshop attendees demonstrate equation of preventive practices, percentage of incorporation of preventive practices in the targeted audience of advertising campaigns. And outcome for results for it will be the milestone of gender approach. The indicators are percentage of the protocols analyzed and adapted incorporate the gender perspective, protocol for detection, information, and assistance to women and children who are victims of gender-based violence. Working groups, we are 4 working groups. The first one is observatory. The second working group is for protocols. The third one is for capacity building. And the fourth one is for awareness raising. For the first group, observatory, we will work in establishing the Observatory of the Chronic Non-Communicable Diseases in the West Bank as a space for data analysis, research, and knowledge generation in the subject, providing it with resources and strategy, analyzing the chronic diseases by using many of health determinants such as age, gender, occupational level, educational level, marital status, income status, and etc. Convince an intersectoral prevention roundtable with health authorities here in Palestine and the media to facilitate networking and its impacts on the population. Working group number 2, protocols will identify and analyze of the existing protocols in relation to non-communicable diseases as well as strategies for approach by Health Work Committee Association, development of a new updated protocols for the care of patients with chronic diseases adapted to the global pandemic situation. Actually, we are working for hypertension, diabetes, cardiac diseases, and asthma. Design and incorporation of the specific protocols for the detection, information, and assistance to women and the children victims of gender violence. Translating the gender approach by incorporating the gender perspective in the revised and implemented protocols to be applied in healthcare system in the association. Holding of a specific workshop for health personnel with the aim of teaching applicability of the gender approach in the updated protocols. Group 3, the capacity building, will identify the training needs of healthcare personnel, also identifying specific training proposal. Actually, we worked on focus the group to identify the healthcare training needing assessment and the outcomes we are working on to be measured in this part, such as awareness and concern of the healthcare professional level regarding the chronic non-communicable diseases, capacity of the facility of the manager to manage the chronic diseases, the capacity of the facility for surveillance, information management, and referral system, community characteristics and context within the chronic diseases, identification for the gap and opportunities along with proposal of future directions, gender awareness, disabled patients, rural area, quality improvement, emotional barriers, and performed measures. In group 3 also, we are drawing up an annual training plan for the health staff of the programs and centers managed by the Health Work Committee Association in collaboration with the academic professors in the University of Jaén in Spain. Development and implementation of a digital distance learning platform as health training tool. Carrying out workshops and theoretical and practical training for health staff of the program and centers managed by Health Work Committee, given by the University of Jaén lecturers and Spanish teaching staff, adapted to the epidemiological situation, cultural, social, and political context. The final group is awareness raising. They are working on design and implement a population awareness campaign for the prevention of chronic diseases through the publication of audio-visual and offline material, conducting 25 awareness-raising workshops of non-communicable diseases prevention and protective measures against COVID-19. Briefly, let's talk about the calendar and the timing for our activities. For outcome 1, the activity is establish the Observatory of Chronic Non-Communicable Disease in Palestine as a space for data analysis, and 2 or 3 more points. How we can act these or do these activities by conducting a feasibility study of available resource together with the management of the association, and actually we did this study, analyzing the information of interest for the design of strategic action documents, creation of an accessible web space for the observatory, and next week we will start working in creation this website with the IT department in the University of Hayin, meeting with the professionals involved to review existing protocol. Actually, we made a lot of meetings with the healthcare organizations here in Palestine, evaluation of the adoption of the new protocols by a panel of local experts and researchers from the University of Hayin, elaboration of a checklist to see the relevance of the existing protocols, and we will convince 3 meetings with the healthcare authorities with the media to address the prevention practices in the chronic non-communicable diseases, facilitating collaboration and networking between different actors. For outcome 2, identification of the training needs and drawing up the annual training and developing the digital distance platform. How we can do this by drawing up the training proposal for between professionals from the University of Hayin and all collaborating entity NGOs here in Palestine, joint elaboration of an annual theoretical and practical training program, creation of a virtual teaching web space where health work committee, association professionals can be trained, overcoming the mobility access barriers imposed by the Israeli occupation and the variable situation of the COVID-19, and implementation of the workshop and the practical and theoretical clinical sessions scheduled in the training plan. For outcome 3, that creating a workshop and design and implement the population awareness and the 25 awareness raising workshop, we can do that by coordinate a campaign with the Observatory Intersectoral Board, a communication that will include a short video to be distributed through social networks, 5 billboards, and the publication of 2,000 brochures with the practical recommendations to be disseminated among the Palestinian population in the West Bank. Also, the head of the Health Education and the Promotion Committee will be in charge of organizing and delivering 25 practical workshops on non-communicable diseases awareness and the prevention, as well as on protective measures against COVID-19 to the 3 different groups: women, elderly, and young people. And finally, outcome 4, regarding gender approach and holding a specific workshop for the health personnel. How we can do this activity by collaboration with the cluster of NGOs, Forum Against Women Violence, and the Palestinian Education Solution. We will design a protocol to be followed in all our clinics and awareness and education programs for detection, information, and assistance in case of gender-based violence. The University of Hayin, together with the Health Work Committee Association, will review the updated and completed protocols, detecting and correcting any bases, and which will be applied in the clinics and the programs of the Healthcare Committee Association. Finally, the University of Caen will design in coordination with us a specific workshop for health professionals with the aim of showing the change applied to the protocol in terms of gender approach and their applicability in daily working. Before I'm leaving, I would like to say thank you for my colleagues in UCG team, Mr. Max, Ms. Freya, and Ms. Priyanka for coordination and organizing this amazing conference. Hope to see you physically, inshallah, in soon, shortly. And if you have any questions, I'm ready to answer.
Thank you for your presentation.
Thank you, dear. You're more than welcome.
We will see you soon. Please talk to COVID that we can have coffee together, sir.
I will do my best. Thank you very much, dear.
See you.
See you.
No, anybody with questions? Okay. Thank you. Have a
You're more
great
than welcome.
Have a great day further. The next speaker is Dr. Najla Al-Nasser. She's going to speak about importance of nursing staff in patient nutrition. Najla? Najla? Hello? Hello!
Yes.
Okay.
It's working now.
Welcome.
Thank you. All right.
Okay, the floor is yours, okay?
All right, thank you. Do you guys have access to my slides or do I have to share them from my side?
Can you please share it for us?
Yeah, I've been trying to share. Let me see.
Dr. Nasla, please click on share screen, the green button.
Yes, because I've been trying to access it from, I'm using a different laptop now. Let me see. It's not allowing me for some reason. Is there any way you guys can share it from your laptop or your side? I sent the slides.
So to whom you have sent your presentation?
I've sent it because we got an email about the presentations and.
So can you please try once again? Please click on share screen, green button option is there at the bottom.
Yeah, I'm choosing, but it's not allowing me. That's the problem. Let's see if it would work now.
I am checking. Meanwhile, you can introduce yourself.
All right. So hello, everyone. Good evening or good morning from my time. Good afternoon. I'm Dr. Najla Al-Nasser. I'm a registered dietitian. I'm Saudi and living and practicing in the US. I am a clinical dietitian. Again, as I mentioned, I worked in 16 hospitals in the West Florida division as a clinical dietitian and as a leader as well for the division, and I do teach nutrition for undergraduate and graduate students. At the meantime, we are doing a study on COVID effects on children's intake. I believe everyone now is doing their studies on COVID due to the the pandemic and what it's doing. So my topic is about, my presentation is about a very dear topic to my heart. It's about the importance of nursing staff on nutrition. So I'm going to go ahead and start my presentation, but until we get, let's see, let me do that. Okay. So I'm going to go ahead and start the presentation until we can get the slides up and available.
Give me a moment, please. I am doing it from here.
Okay, so you got it?
Yes, just give me a
Okay.
moment. I will play it. But you need to guide me by saying next.
Okay, no problem. Sorry about that.
That's
And thank you for having me in this conference. It's been a pleasure. There is diverse topics from different backgrounds, and it's very interesting to hear everyone talking, you know, in this conference. And all the topic, honestly, are very interesting, especially having speakers from all over the world. All right, so I'm just going to go ahead and start with the objectives until we get the slides up.
yeah, we got it.
Okay, perfect.
I hope you can see it.
I do. Yes, I can.
Great.
Okay. So the objectives for these slides, if you can go to number 2, please. The objectives would be of the presentation would be number 2, please.
Yes, it's there.
The second slide. Okay. We would be defining malnutrition and identifying the malnutrition triggers and list signs and symptoms of patients suffering actually from malnutrition. Because when we say malnutrition, what is malnutrition? Discuss the importance of providing education and support patient nutritional needs. If you can go to the next slides, please. Okay, so if we look at malnutrition, when we say malnutrition, what comes to your mind, you guys? When we say malnutrition, it's always undernutrition, and this is what comes to everyone's, immediately. But malnutrition can actually happen also with overweight and obese individuals. The term itself is very broad term, and that can be defined in disproportion in nutrition. So we have either overnutrition or undernutrition, and overnutrition is seen in developed countries, and undernutrition is seen in developing countries and also in hospitalized patients, and this is our focus. So malnutrition is most simply defined as any nutrition imbalance that affects both overweight and underweight, as I mentioned. And it's not only overweight, because even in the hospital, sometimes we would have overweight patients or obese, even morbidly obese patients. And some of the medical team members would argue, oh, they're fine, they can survive 2 weeks without getting nutrition, which is absolutely wrong, because malnutrition is very common among even overweight and obese patients. So it's regardless of their BMI, which is body mass index. It's a measure of their weight and height. It measures, and their weight status. They typically suffer from undernutrition due to the surgical patients or patients who are on an MPO, which means nothing in my mouth, due to swallowing issues or any other problems. In addition, they may have an increased energy and protein and essential macronutrients needs for recovery, such as patients with inflammation, infection, and other catabolic conditions. So the statement by AND, and AND stands for the American Nutrition and Dietetics, and ASPEN is the American Society of Parenteral and Enteral Nutrition, and it's published in May of 2012, and this is the most recent one. It defines malnutrition as the presence of two or more of the following characteristics, which is insufficient energy intake, weight loss, loss of muscle mass, loss of subcutaneous fat, localized or generalized fluid accumulation, or decreased functional status. So when you have two factors of those or more, then you have malnutrition. And from those, you can see it's very common in obese patients to have, loss of muscle mass and, let's say, decrease in functional status. So it's not necessarily just weight related. Next, please. Unfortunately, I don't see the pictures here, but I don't know, but it's okay. So malnutrition started to be appreciated 4 decades ago, and malnutrition and its side effects continue to be a problem among hospitalized patients, and it continues until this day. We still have the malnutrition problem. And it continues to be unrecognized. So when we focus now on hospital malnutrition, it is a complex interaction between underlying disease, disease-related metabolic alterations, and reduced availability of nutrients. Next, please. So factors leading to reduced availability of nutrients include reduced intake. When you are in the hospital, you're not feeling well. That's why you are in the hospital. And when you are not feeling well, you usually eat less. Your appetite is lower. You maybe don't like the foods. It's a hospital food. It's outside of your comfort zone. Other reason can be impaired absorption, increased losses, and or combination of all of those factors. And our problem is the reduced intake, and this is what we will be focusing on, because the other problems are we can't fix immediately, but the reduced intake this is what we would be working on or focus on. Next, please. So again, malnutrition can result from dietary intake deficiency, increased requirement related to health status. Let's say cancer patients, they have higher needs, calorie needs, higher energy and protein needs. The same as well with skin problems or burned patients. Those are having higher needs for calories to build those new cells and need higher protein to replace those damaged cells. It can be a complication of the underlying illness or the combination of the above mentioned factors again. Next, please. Okay, so here we come, and is it really a problem? Is malnutrition a problem? The easy answer is yes, of course it is a problem. The prevalence of malnutrition ranges up to 50% among patients in the hospital. So it's very common among the hospitalized patient. Malnutrition is also common in the long-term and other health care settings. Here in the state, it's common in nursing homes. I know in the Middle Eastern countries, we don't have lots of nursing homes, but malnutrition is very common here in nursing homes. Okay, next, please. Other importance of focusing on malnutrition is that malnutrition is a major contributor to decreased function and quality of life, and it increases the readmission and length of stay in the hospital due to those serious bloodstream infection, pneumonia, congestive heart failure. It reduces the wound healing and increases the complications, increases morbidity and mortality of the patients. So again, looking at numbers, which always makes more sense for some people, thinking that 1 in 4 patients admitted to the hospital is malnourished. And this is a really high percentage if you think about it, 1 in 4. 1/3 of all patients are at risk of becoming malnutrition during hospitalization. And this is why we want to focus on it and try to prevent the malnutrition from happening before it occurs. Next, please. Yeah, let's see. Let me see from my side what slide is this, number 15. Okay, you can go next until we see. This is an image.
I'm trying, but it is not working here.
It's okay, we can jump to the other ones.
Yes.
It's just showing the percentage and prevalence of malnutrition in hospitalized patient. Sometimes, you know, I like the visuals and showing the problem and issue. So malnutrition remains a significant and highly prevalent public health problem, and early identification and appropriate nutrition intervention can help to reverse the malnutrition and prevent all those outcomes that can happen from having a poor nutritional status. Next, please. Next. All right. So when we think about nutrition, how do we deliver nutrition to the patients? Looking at the nutrition delivery, there are different methods of delivering the nutrition, and we're thinking what happens when the patient becomes malnutrition. So we have effects on patients and effects on the facilities itself. Next, please. So the nutrition delivery methods, either by mouth, which is food and drinks, drinking and eating, providing nutritional supplements. I'm sure you guys are familiar with the different nutrition supplements that are available, the commercial ones available there. Depends on the provider, either Abbott or Nestle or however your company is. There is a wide range of supplements that can be used to add additional calories and protein for those patients. Tube feedings is one major also method of delivering nutrition. And we have the parenteral nutrition, either TPN, which is total parenteral nutrition, or the PPN. Next. And this is a figure that's showing the delivery methods of the nutrition, where usually TPN is through a PICC line. Tube feeds is usually either through the nose or through the stomach, or wherever the placement in the GI, based on the patient's nutritional status and overall status, actually. Next. So what happens when the patient is not receiving adequate nutrition or not even receiving nutrition at all? Next. So this is when the malnutrition happens due to the inadequate intake. So malnutrition affects overall health status, and it would increase the hospital stay, infection, morbidity, and mortality. Next, please. So when we focus now on the effects on the patients, it causes a depleted body mass, poor wound healing, impaired immune function, weakened ventilator drive and respiratory muscles, and more support needed after the discharge. Of course, when they are discharged malnourished, you know, we would need someone to take care of their tube feeds if they're on tube feeds, or even if they are eating orally, they would still need the support because they reach that point of malnutrition. Next, please. And those are figures that I know you can see them, but it shows the effects of malnutrition in patients and the prevalence of the increased length of stay, which is the hospital stay, and the increased infection with patients. Next, please. All those slides discuss the same factors that we talked about. We're going to talk also about the effect on the facility. So malnutrition affects the patient itself and also affects the facility. And we are mentioning this, the effect on facilities, and this is usually a very good drive to discuss with the administration team, because it's spending is one major factor and drive for the team to change and to accept more changes in the system. So when we mention this, usually either the nutrition team are asking for specific extra help in terms of documentation or additional staff or more support for the clinical nutrition team. So when we treat, can you go back, please? Yes. So when we treat the malnutrition, it will not only improve the patient status, but it would save money by decreasing the length of stay. So with the malnourished patient, when we look at them as effect on the hospitals, they are 3 days longer staying in the hospital, which means increase in spendings. They have higher rates of medical prescriptions, higher rates of infection, higher rates of readmission rate, and you guys it depends on the country as well on the readmission status, but the focus here not to have the patient at least readmitted within 1 month of discharge. Otherwise, the insurance won't cover that admission. And then increased spending of $1,600 per patient per stay due to the malnutrition problem. Next. So this is just a question. Do you think that patient's nutritional status is important? The next slide. Next slide, please. All right. So how did malnutrition happen and why? So these are some of the factors. The major one is the failure to recognize malnutrition from the beginning when it happened, and lack of nutritional screening and assessment, and the confusion regarding the nutrition responsibility. So when we look at the lack of nutrition screening and assessment, we need to screen patients once they get admitted to the hospital, and this is where the importance of nursing is. If we, as a dietitian professionals, if we don't get the proper information about the patient, proper information on upon admission, we won't be able to recognize the nutrition problem, because we do screen for patients, but if the information is not there to tell us, we will not know that this patient have a problem. Yes, we might go and see him by consult like 3 days later, but it would be too late. It's not too late to interfere, but it delays the benefit. But with the nursing staff being on top of it from the beginning, asking all the nutrition questions that are available upon admission, if which especially very common with elderly population, a simple one. Do you have a poor appetite? So sometimes they would skip those questions, and it won't trigger for the dietitians. Therefore, we will not know, are they, do they have a poor appetite? Do they have they lost weight without trying? And all of those questions. Other reasons for malnutrition is the confusion regarding nutrition responsibility. Yes, the dietitian will go and assist the patient, but we need the trigger and we need the consultation. Otherwise, we will not know that the malnutrition exists. I would have always a new nursing staff that we would think that the dietitian would go and see each single patient in the facility, but this can be possible and certain facilities, and therefore there is special techniques to go and see the patients, but by clarifying, to the all staff and the communication by whose responsibility is to trigger the malnutrition, and by improving the communication. Failure to record height and weight, and this is a very common problem. I would have many patients with the wrong height and wrong weight. I would go there expecting them to look obese, while at the same time they look exactly the opposite, which is underweight. And this is very important, and it's actually dangerous, because even with the weight and height, the weight that the nurses put in the computer is the one that used for pharmacy as well. So there is also the communication between the clinical nutrition staff and the pharmacy about the weight issue. And the moment that I see an under-recorded weight or a problem with that, I would contact the pharmacy, because the medication dosage also depends on the weight. And failure to record the patient intake. How much is the patient eating? How much are they ingesting? Are they eating food from outside? We have a special place, where to record the intake, because again, this is another parameters for us dietitian to look at, and what would trigger nutrition intervention. Next. Again, lack of staff and that can assist in feeding is a big problem. Most of the times we don't have sufficient staff here on nutrition as a nursing assistant that can provide feeding for the patients. And some patients will total feed. They would need to be fed, otherwise they won't be eating. But the lack of staff is a problem here in the US, and the importance of nutrition is actually under-recognized. Next, please. This is why the nurses are a very important part of the patient nutrition. I mean, nutrition and nurses are a very important part in the patient's health overall, right? The nurses are always there by the patients. So nurses play a major role in patients overall and health and outcomes, and nutrition is one of those. They have the most interaction and face-to-face with those patients from the admission to the discharge. Next. So the sooner the intervention with malnutrition, the better outcome. Next. So nurses are a key player in patient nutrition because they observe nutrition intake and tolerance. Nurses are there around the patient 24/7. As a dietitian, we would go and visit the patient, and we can spend maximum half an hour a day with the patients to take the information and get this information and use it for our assessment and analysis. However, the patients are actually there next to the patients, and I can tell you, I've had wonderful nurses who would come to me and say, hey, we have this patient, he hasn't been eating. He states that his appetite is well, but he's actually not eating anything. And I am very grateful for those nurses because without the help of nurses, we won't be able to detect and get the intervention that we need for those patients. Nurses interact with family and caregivers. As we mentioned, this is another figure, that's showing the effect of malnutrition and complication of the health status and spending of the hospital. And this is another figure, and this is what the figure is here about. Next. All right, so the next following slides, we would be discussing the 3 W's, which is who's responsible, what, and where to find more information. Next. So the factors used to identify malnutrition, as I mentioned earlier, they are a mixture of different factors, which is intake, anthropometric, which means, weight and height, BMIs, we screen and we trigger for the low BMI, but not the high BMIs. We look for the fluid status and of course the functional measures. Next. So what's the difference between screening and assessment? Screening is done by the nurses, and this is the screening is the tool that we look for the patients, while assessment is the detailed digging and studying of that patient. So the nutritional screening is the first line practice, which identifies the malnutrition. And the investigation is actually done by the registered dietitian. Next. As I mentioned earlier, the screening is done by the nurses upon admission. And this screening would enable us to identify those patients on and risk of malnutrition. Next. So the malnutrition triggers, those are some of the malnutrition triggers that we talked about earlier. Unlimited, unintentional weight loss, poor appetite, the BMI, the intake, swallowing and chewing issues. This is a big thing because if they have chewing or swallowing problems, it means that they're not getting adequate nutrition, and we might need to interfere either by adjusting the consistency of their diet, or at some point, if they are unable to swallow, we might need to use the nutrition support. And of course, this is is assessed usually by the help of a speech therapist who complete, complete a swallow eval. And impaired skin integrity, different type of wounds and surgeries that need, additional calories and protein. Next. Tube feedings, TPN, nausea and vomiting are among the other triggers that we need to be interfering and assessing the patient, because we would do our own calculation and own recommendation on what type of formulas that the patient should use and what is the rate of that formula. Next. Of course, with the nutrition, you can fix it with one visit. So we would have to follow up. Is weight and height accurate? Is PO intake recorded correctly? And what is the policy of that specific facility? And you would notice as healthcare providers, each hospital have their own electronic medical record system. They have their own policy on recording, the PO intake. I've had some hospitals that the nurses are the ones who have to record the PO intake, the nutrition intake for the patients, and some hospitals are the nursing assistants. We had, before it was one facility, it was the food service personnel who delivers the tray, but then this was inaccurate recording due to the mixture of the tickets of each patient. Next. Okay, so again, to end it, when in doubt, always ask the dietitian, offer supplements if you can. Is the patient able to feed themselves, and can the patient swallow? Those are important questions to highlight, the nutritional status of the patient. Next. Okay, and I can take any, let's see, we have a few slides left. Next, please. So this summarize, the slides that we went over. Nutrition is very important for patient overall health, and nurses are the frontline personnel that can provide the important factors that improve overall nutritional status for that patient. Okay, I can take questions by now because the others are summary, and I see that we don't have the rest of the slides are references. So if you want to see the references, and that's it for today.
Thank you so much, Dr. Najla. I hope I pronounced your name correctly.
Yes, you did. That's okay.
Yes, thank you so much. It was a very nice and informative presentation.
You're welcome.
Yes.
Thank you, Ms. Najla, for this, Dr. Najla, for this informative topics, and it's a pleasure for us to have you with us here today, and hope to see you again in our next conference.
Definitely.
Thank you very much. Welcome back, everyone. And let's move to the final speaker for today. It's Ms. Ashley Brooks from the USA. Let me take a brief introducing for her. She's a nursing student at Berry University in Miami, Florida. She will be graduated in May. Prior to school, she was traveling for clinical educator for over 3 to 5 years. Mostly, she's responsible for preparing hospitals for Joint Commission surveys. Her first major was biology from the University of Roosevelt University in Chicago. Today, she will speak about surveying trail processing and how regularity bodies have shaped trail processing. Welcome. The stage is for you, Ms. Ashley.
Hi, can you guys hear me?
Yes, I can hear your voice.
Okay. All right, I'm gonna go ahead and share my screen.
Okay.
All right.
Make share screen, please.
Okay. Can you guys see it?
Yes, perfect.
Okay. All right, so my presentation is about surveying sterile processing, how regulatory bodies have shaped the sterile processing community. As she mentioned before, my name is Ashley Brooks. I'm a Berry University nursing student. I'm in school right now, Miami, Florida, and I'm also scheduled to graduate in May of 2022. But prior to going to nursing school, I had a career where I traveled throughout the United States. And I prepared hospitals for surveys such as Joint Commission and Centers of Medicare and Medicaid. All right, so sterile processing is a department that is responsible for cleaning, inspecting, disinfecting, and sterilizing medical instruments during a surgical procedure. The professionals in the hospital are responsible for these tasks, and they play a critical role into the healthcare facility's ability to provide safe patient care. Can you guys see my slides? Okay. All right, so the areas that we're working in, so sterile processing consists of pretty much 4 major areas. The first area is decontamination. So this is where soiled instruments are sorted, inspected, and if necessary, disassembled. And then the instruments are also manually cleaned. So if you look at the pictures here on the left side, instruments usually they come down into a case cart, and they're supposed to be cleaned and washed according to a 3-sink system. So the first step is normally you rinse the instruments off, and then you soak them, disassemble them, clean them, brush them, whatever you have to do. And then the final step is that you rinse them before they go into the mechanical washer. The picture here at the bottom is kind of what the instruments look like when they come into decontam. They're contained with a lot of bioburden. And so the techs in decontam, they have to have full PPE on with gloves and shoes and whatnot so that they don't get hurt. Okay, so these are some additional decontamination photos. So the first photo that you see here, you have a technician who's actually loading the mechanical washer. The mechanical washer is pretty much a dishwasher on steroids. So it's gonna put the instruments into the washer, and then it's gonna use all these different types of enzymatics and hot water in order to get the instruments clean so that they're safe to handle on the other side. And then here on the right side, you can see that these are the instruments that are used after surgery. Usually, depending on the hospital that you work on, they're supposed to have a policy in which the instruments are supposed to be sprayed or cleaned and kept moist so that when they arrive in decontam, that they're not so hard and they're not dry and they're not difficult to clean, so that the instruments can be reprocessed quickly and go back to the operating room. All right, so the next department area in sterile processing is assembly. So after the instruments come out of the washer, they're actually safe to handle. So they're supposed to be clean, and you're trying to set up the instruments in a way that would prepare them for sterilization. So the instruments are sorted, they're inspected. You're looking at them in magnification to make sure they're working properly, making sure that there's no bioburden on them, make sure that the instruments are stick together. And then usually towards the end of the process of assembly, you either wrap the instrument. So that's what you see here in the picture on the right. You see that they're actually wrapping the tray and the instruments. All right, these are some other pictures from assembly. So you can see here on the left, so this is a peel pack. Peel packs are usually used for instruments that may be like special, or they're pretty much one of a kind. And so you don't want them to get lost. So you kind of put them into separate from an instrument tray set. The middle picture displays what an instrument set looks like. So you can see there's 2 indicators on here. There's instruments here that are open, so that when they are into the sterilizer, that the steam actually penetrates all parts of the instrument. And then the last picture is just another lady who's actually assembling the instruments and looking at them to see whether or not they're good to use. Okay. The next area of sterile processing is called sterilization. So sterilization is where the instruments go and they're actually supposed to be sterile, right? So it's the process of when you're eliminating all forms of microbial life, and it's carried out in healthcare facilities by physical or chemical methods. So this picture here, you can see that these are actually instruments that have come out of the sterilizer. I can know that because the indicator on the outside of the trays, the wrapped instrument, that actually changed colors. There's several different types of sterilization methods. There's high temperature, there's low temperature for instruments who cannot undergo a high temperature. So anything that's like flexible endoscopes, some instruments that are maybe made out of a certain type of material or whatnot, they can't undergo sterilization. There's also high level disinfection. It all depends on the manufacturer's recommendation of how the instrument should be manufactured and how it should be cleaned. And there's some more pictures. So like I mentioned before, this picture here on the top is another example of low temperature sterilization. She's wrapping the tray, she's getting ready to put it into the sterilizer, hit the button, and then the machine's gonna let her know when it's sterile. And then the bottom picture here is on a lady who's actually loading the sterilizer. She's gonna load it, into the sterilizer, and then after it's done, the machine's going to give you an alert and a printout and let you know if the instruments have been sterile or not. The sterilizer is pretty much a fancy word for like a pressurized oven that's extremely large. It usually has like high pressure steam that goes in there, and that's how the instruments get sterile. Okay. Another part of sterile processing that may either be in the department or ancillary is flexible endoscope reprocessing. So it's the same process that you would use for medical instruments, but for flexible scopes, because the lumens inside of them are so large, they have particular machines that particularly for flexible endoscopes. So pretty much when these arrive in decontam or in this department, they're already pre-soaked. All you have to do is manually clean them, inspect them to make sure that they're clean. And then the instrument, the flexible endoscope goes into what's called an automatic endoscopic reprocessor. And as you can see here, the technician she's actually loading it into the machine. And this is also used for a lot of other instruments like ultrasound probes as well. All right, and then here's some other pictures of some flexible endoscopes. So like I said, the first step in decontam, you're always going to make sure they're rinsed, they're cleaned, their instruments are flushed. So the technician on the left here, he's actually flushing the flexible endoscope, make sure that it's potent and that the water come out is clean. And then on the right side here, I have a picture of what a flexible endoscope looks like. You have the distal tip, the bending section, the biopsy valve, the biopsy port. I would say in my experience, the biopsy valve and the biopsy ports have been the most difficult things to clean. You have to make sure that when you clean this instrument that you have the right size brush, that it doesn't damage the scope, or if it's not too thin so that it can be able to remove any bioburden that's on there. Also too, sometimes depending on the manufacturer, they'll bring down the suction valves as well. And then the technician also cleans those as well. All right, so this is an example of the sterile processing workflow. It's supposed to be in one direction, and it's also supposed to be a separation of clean and dirty. So usually instruments arrive, they are already soiled, they're dirty, they have to be clean, they have PPE on, and then they go into an area of assembly where they're not actually clean, it's just a clean area. They are inspected, any other prep needs to be done, indicators are put in the tray, and then they are prepared for sterilization. After the instruments are sterile, they actually go to a section that is storage where the instruments are cooled, and anybody from the OR or any other ancillary departments in the hospital, they can come and pick up their instruments. Some departments do have an endo suite, some do not. I've seen some places where the endo suite is actually in the OR, where they have a little bit of a decontam and a clean area for the scope. It all kind of depends on how every department, what it looks like and how it's formatted. Okay. Does anybody have any questions? Okay. So I have a little bit of a quiz for you guys. What area of sterile processing is where dirty instruments go after a surgical procedure? Okay, so the answer for that would be
Hi, Miss Ashley. If anyone wants to answer, he can raise his hand or write in the chat box.
Okay, I don't know. Can I access the chat? Oh, wait, I can. Okay, no one put anything in the chat. Okay, now that I know, thank you.
You're welcome.
Okay, so yeah, so the answer to that question was decontam. So after the instruments are used during surgical procedure, they go to the decontamination area, and that's where they're cleaned and they're properly inspected and whatnot. All right. So the next thing that I'm going to get into is the agencies that I work with when I had this position. All right, so Joint Commission. So Joint Commission is an independent nonprofit organization in the United States that has no legal authority over hospital organizations, but they further set the standard for the hospital. So Joint Commission is huge in the United States. They pretty much go around and they, hospitals, you wanna have this gold stamp of approval, because this means that if a patient goes into this hospital, that their patient safety is not gonna be compromised. All right, so Joint Commission is the abbreviation for it is going to be TJC. And what it is it's a governing body which provides hospitals for their certification. TJC mimics the standards by two organizations in sterile processing. The first one is going to be called AMI, which is the Association of Advancement of Medical Instrumentation. The second one is AORN, which is the Association for Perioperative Registered Nurses for Practices in Sterile Processing Area. So Joint Commission, to try to explain it, they could not shut a hospital down. So if a surveyor goes into a department, the staff cannot answer any questions. There's dirty instruments that are not being cleaned in time. The staff cannot speak to policies and procedures. The management has no idea of tracking information. They cannot actually shut it down. What they can do is they can report their instances to the Centers of Medicaid and Medicare, or they can report it to the state. And the state is the one who authorizes whether or not a hospital loses funding, whether there's a follow-up action plan, whether or not there's this hospital's gonna close. It all depends on a root cause analysis. In sterile processing, there's two main organizations that we actually pay attention to when it comes to standards. And the first one is AMI, which is the Association of Advancement of Medical Instrumentation. So AMI, they basically set the standard of what should be done in each department: decontam, assembly, sterilization, what to be looked for, anything between what needs to be done, etc. The next organization that actually sets the standard that we don't typically deal with in sterile processing, but the nurses deal with, and that they should be aware of their standards, is AORN. And AORN is the Association for Perioperative Registered Nurses for Practices in Sterile Processing Areas. Stop. Okay, so Joint Commission is based on compliance. They're basically, if you're not compliant, there's standards, there's laws, there's regulation, there's rules, there's policies, and everything that are required in order for you to be compliant. So there's four main things that Joint Commission is going to look for when they come into a sterile processing department. They want to know first, can the staff demonstrate or speak to their work processes according to AMI and AR standards? They want to know, and that can be anything from safety. I've had surveyors come in and ask about, what do you do when there's a fire? Like, what does PASS stand for? What does RACE stand for? They also are looking to see if the staff knows what they're doing. So sometimes they may watch them, sometimes they may observe them, sometimes they may ask just for one person to come around during the survey. Sometimes they may ask for the manager. So they have departmental policies and procedures, and what they're looking for from the manager is to see whether or not those are actually being tracked and managed in a way that's appropriate for the department. There's also competencies that need to be done. So training and development is very, very, very stringent in the medical industry, especially sterile processing. So you always are going to be learning, you're always going to be training, because things change, instruments change, policies change all the time. So you have to make sure that you have education for your staff. You want to make sure that there's competencies being done, and you also want to make sure that there's in-services being done. Another thing that they're going to be looking for, they want to make sure that the products or equipment being used by the staff are being used safely and according to the manufacturer's instructions for use, which is the IFUs. So failure to meet Joint Commission standards during the survey will most likely result into several different things. Sometimes when a hospital doesn't do well with Joint Commission and they may they may miss a few things, it's actually a good thing because it kind of exposes what they missed in a couple of years. And so you can use that failure to be part of the process of success. So usually there's a follow-up action plan being made. Also, there's a possibility of losing a certification. It depends on how many times they've been dinged on it or how many times that it's been failed. And they also are at risk of possibly having a survey from the Centers of Medicaid and Medicare. Now, the Centers of Medicaid and Medicare is a regulatory agency that is going to be, has more stringent rules to it if you do fail one of their surveys. Does anybody have any questions so far? And I'll check the chat. Okay, no. All right, and my question for you guys are, what two professional organizations set the standard for Joint Commission? Does anybody remember what two organizations I said for sterile processing set the standard?
Kindly, if you want to answer the question, just raise your hand or write in the chat box.
Okay, so the answer is Association for the Advancement of Medical Instrumentation, which is AMI, and AORN, which is the Association for Perioperative Operating Room Nurses. Okay, so now we're getting into the Centers of Medicaid, or Centers of Medicare and Medicaid Services. So in the United States, the Centers of Medicaid and Medicare Services is the law and it is managed by the government. I can tell you now, if it gets to a point where the state is coming to the hospital, it's not good. Because you're at the point where you're at risk of losing a certification, you're at the point of either closing or either losing funding. All right, so the Centers of Medicaid and Medicare, when they perform a hospital survey, their main thing is patient safety. They want to make sure patient safety is not being compromised and that basic healthcare standards are being upheld. So the CMS will often utilize local health departments to perform their surveys in certain states. I've been to a couple hospitals in the United States where it has gotten so far where where the state comes in and they passed Joint Commission, but the problem was that there was a huge staffing concern because the technicians were intentionally sending dirty instruments up into the OR, and it was a children's hospital. So when they were doing the investigation, there was so much public scrutiny and there was a lot of lawsuits being gone. So when I came in, I was a clinical educator. I had to pretty much wean out the staff members to see which ones were capable of learning, which ones actually listened, and which ones were not unintentionally sending dirty instruments to the OR because obviously patient care is being compromised. In this situation, I believe it was a girl, a little girl who I think contaminated instruments were being used on, and it was actually during a spinal surgery. And it was probably like in the beginning steps of the lawsuit. So they were actually, the hospital was at the point where it was like, okay, if the staff is not going to get on board and they're not going to do what they're supposed to do, and they're not willing to learn, then we're going to go ahead and get rid of them and then just restaff the department. Because at that point, that's when safety, patient safety is actually being compromised. When the state does come in, oftentimes they do use the local health department. So in my particular example, when I was in Michigan, they're gonna the Detroit Public Health Department is gonna come in and they're gonna be the ones that actually do the surveys. That can look anywhere between coming in and observing the department, just falling back on what they missed on their Joint Commission survey, et cetera. All right, so again, your Centers of Medicaid and Medicare Services are going to be looking for 5 main things, right? They're going to be looking at documentation from a management perspective. So usually when the staff is not educated, not trained properly, the manager is not trained properly. So they're going to be looking from the management to see not only education being done, but also what are the consequences for disciplinary actions? What are their policies? How that's been documented? How is it being tracked? Is it being tracked electronically? Can we pull up these records, et cetera? They're also looking for departmental quality data, audit, metrics, policies, and procedures. The policies and procedures are more in pertain of the staff and education development, but it also pertains to the department's metrics. How many dirty instruments have been sent upstairs? How many did not have indicators? How many times was a tray called up to the OR and it was dirty? They're looking to see, you're gonna be under more public scrutiny based on what your metrics and your audits are actually stating. A couple other things that they're looking for, the individual employee files. So they want to see these employee files, everything from behavior issues to education and services, et cetera. Education and competencies, again, is a big thing. Like I said before, the medical industry is something that's always changing. It's always advancing. So you want to make sure that your staff is educated and trained properly. And they also want to make sure there's an onboarding practice and program for new hires. I will say in my experience, a lot of hospitals, some of them do, some of them don't. They have onboarding training practices for nurses, but they don't have it for sterile processing or CNAs or things across that line. And just because they're not in patient care, like direct patient care, doesn't mean that they're, that they should not receive the adequate training that they need. All right, so when the Centers of Medicare and Medicaid Services come, they're being compromised and they observe that patient safety is not being met, you're at the risk of losing Medicare and Medicaid funding. So in my experience in the OR, sometimes Medicare and Medicaid will pay for some services, some operating room services. So if you're losing funding from operating room services, because the operating room is something that generates revenue, then what that may look like is surgeries may be reduced. And then the surgeries are being reduced and you're gonna have to reduce staff because you're not producing as many instrument sets. So that can just be a trickling effect once the hospital loses funding. Also, the agency also will revoke funding from any hospital that's failing to meet any type of standards and requirements. All right, so I have another quiz for you. If the Centers of Medicaid and Medicare see patient safety is not being met, what will most likely happen? Again, you can either raise your hand or you can type it in the chat box. I'll give you guys a couple more minutes. Okay. So what most likely will happen is hospitals will risk losing Medicare and Medicare funding. All right. Okay, so in my experience, working for this department, this is usually what happens in the department that usually leads to it. The biggest problem that I have seen trickles from the executives and the stakeholders. So hospital leadership, that can be your CEO, your CFO, the stakeholders, the stakeholders of a hospital have a lack of knowledge of sterile processing. Sterile processing is important because if your instruments aren't clean, you're going to be at risk for infection. But a lot of stakeholders, a lot of executives don't even know the difference between a sterilizer and a washer. And capital equipment in this department is expensive. You know, the sterilizers they're not cheap, and to keep them maintained is not cheap either. You have to have someone that's always working on them. The steam has to be right. They have to be efficient so that the instruments are sterile. The same things with washer disinfectors. Like I cannot count for so many times where I go into a board meeting and they don't have the funding for a sterilizer. They don't have the funding for a washer disinfector. So, you know, you're hand washing these instruments, they're not going through the washer. If it's an older department in a rural area, sometimes the hospital doesn't get as much funding because there's not that much, there's not a lot of population for that hospital to treat their patients. But I cannot stress enough how much capital equipment is important. And the main reason why stakeholders and executives do not invest in this department is because it is a non-revenue generating department. In other words, it does not make money. So you have people in this department who typically, they're in the basement of the department, you know, they're supporting ancillary service, but it doesn't bring value to the hospital because it doesn't produce money. Revenue generating departments receive the most attention from hospital executives because that's where their money is. So the operating room, like I cannot tell you countless of time where I go into an operating room and they have the most elegant hospital room beds, tracking system, cameras, technology, and then you go down to the sterile processing department and there's not even a functional equipment because, like I said, this department does not generate revenue. So if stakeholders and executives and stakeholders know more about this department and how important it is, then it kind of eliminates the lack of knowledge that they have. Also, a lot of people do not know about this department. It's still relatively unfamiliar to the public. So because it's relatively new, there's a lack of understanding and scrutiny of the practices, you know, because no one like, oh, sterile processing, well, what's that? Is that some type of surgical procedure that's done when you can't have kids? No, that's not what it is. It's a department that helps with cleaning and disinfecting of instruments. Another thing I've also noticed in my role too is like, even from an educator standpoint, sometimes like the managers and the educators, like we don't get invited to those meetings. You know, we get invited to the infection control meetings. They're like, oh yeah, because you guys are important for infection control practices. But we don't get invited to those stakeholder meetings. We don't get a buy-in and say, hey, I need a new sterilizer. My sterilizer's outdated. Hey, I need this. So because of the public doesn't know about us and because the department doesn't make revenue, it's hard to fight for something that's not actually available. Another thing is what hospital leadership is, they don't recognize the importance of how crucial the department is. And because they don't understand it, they don't recognize it until it's too late. I cannot tell you how many times where I've been into a department where the whole staff calls off because they're on strike or they don't feel like they're getting paid enough. And then the OR is gonna go on regardless. They're gonna do whatever they have to do regardless, whether or not they have enough instruments such or not. And I'm sitting there, you know, trying to pump out these instruments such so that people can have what they need. But we normally don't get those phone calls until it's, you know, at late notice, you know? We don't get the phone calls for the hospitals that are doing well and that are certified. We get the calls for the hospitals that are at risk of losing their certification or the state is getting ready to come in. So some of these consequences include infections that jeopardize patient safety. Another thing I've seen is surgeons are threatening to leave because, like I said before, you know, the operating room is a generating revenue department. So if surgeons are leaving, that means that they're not going to be generating revenue, especially if it's like a world-renowned surgeon. Also, there's lack of instrumentation availability. There's also lawsuits that happen, public scrutiny, because if there's a lawsuit, then you know there's going to be in the media, it's going to be in the paper. There's also can happen a loss of Joint Commission certification and the government funding being revoked and eventually resulting in a hospital to close. Okay, so sterile processing is the most important department because it prevents infections in the hospital setting. So hand washing and sterilization and disinfection of instruments and tools are equipment that are necessary to protect the patient safety. Okay. And then the solution to all of this would be collaboration. So the more people that know about this department, the more people who are educated about this department and the importance of it and the repercussions that are not executed to the standards, the more key stakeholders will start noticing the change and the strategies towards it. So I've had success in some accounts where I do get invited to those meetings, and I collaborate with infection control, I collaborate with the material management department, I collaborate with the CFO, the CEO, because they realize that it's a problem and they don't want the problem to keep going. So the solution to this is always going to be collaborating with the people who can be your allies, and they can start making change and different strategies towards it. Okay. And that's the end of my presentation. Does anybody have any questions?
Thanks, Ms. Ashley, for this informative presentation and important points. If anyone have any questions or comments, you can raise your hand or you can write on your the chat box. It seems there is no questions. Actually, I have two small questions for you. Okay. The first one I would like to ask, what's the most challenges that you have faced during the preparation of the Joint Commission survey? And the second question is, what's your recommendation for hospital leadership, department heads, and the healthcare professional about sterilization process?
Okay, so my most crucial Joint Commission survey. Okay, let me think. Okay, so I will give you my hardest assignment I had. It was at a hospital in Chicago. Basically, they had failed the Joint Commission survey. And when they looked back at it, they said, well, it was the education that was being done. So I had to go in there and I had to educate. But prior to that, the hospital leadership, they recognized that the staff was a problem, and they only gave them 18 months to get certified. And so when they gave them 18 months to get certified, they didn't give them the resources. And so I had to overnight textbooks. I had to start classes when I wasn't in the department, because I was in the department Monday through Friday. So I was like, hey, you have to wake up at 9 o'clock on a Saturday to learn this stuff. You have to learn it. But also their director of surgery at the time also taught classes on sterile processing at a local community college. So it wasn't the fact that they didn't have the resources, it was the fact that they just weren't putting in the effort and they didn't care about the job. It was kind of like one of those things where it was like, oh, they just did not care. And they felt like because the hospital was one of those government funded hospitals for the community of people who were like the lower impoverished, like socioeconomically. So like for people who like some of the programs the hospital had was like a needle exchange program for drug users. So that people felt like because the community needed the hospital, they were never going to shut the hospital down and they were never going to lose their job. But in the essence of it was they were just lazy. it wasn't that we were collaborating with, like, we collaborated with the director of surgery, we collaborated with the CMO, CEO. It was like, no, the problem of this particular thing is the staff. And so they basically, half of the staff did not get certified, and they did exactly what they did. They gave them a job in another department in the hospital because it was union. So a lot of them went to the kitchen, and then they got agency in there. So my company at the time, they had hired all these different technicians to come in and from an agency. Hold on one second. My dog is about to drive me nuts. Come here. Come on. So this is Champ, everybody, like in the picture. So basically he was, they pretty much had, it comes to a point where, like, sometimes people just don't want to do right. And they don't see the value in their job. And so because they don't see the value in it, they try to do things to intentionally sabotage people, because, you know, human behavior is very unpredictable. So even though I was coming in doing classes and giving them textbooks and stuff before, it was just was the fact that it wasn't until it was like, oh, I'm getting ready to lose my job, that they actually thought it was important. So that I would say that was probably my hardest account, because Joint Commission came in twice, not in our department, but in other parts of the hospital. So we had to be ready when they came. And then there was a couple of times that the state had came in as well. And so I was in the middle of restaffing the department and training them. And it was difficult because it was like, it wasn't like one person left in 1 week. It was like 6 or 7. So if you have a staff of 12 people and half of them leave in 1 week, you're like, who's gonna come in here and do the work? Okay, well, get some of these nurses down here. Like, you guys are complaining about these instruments, like, get them down here. You guys know how to count, and you know what these instruments are, so you guys can come down here and do it. So that would be my answer to my first question.
For the second question, what's your recommendation?
My recommendation for like stakeholders to prepare for Joint Commission would be some of the things that I mentioned in the slide, was like, make sure that your staff knows the policies and procedures. Make sure that you have tracking information and things available for across that line. Make sure that you have education and in-services, and make sure that's tracked and that your staff can speak to that. Make sure that you have your manufacturer's IFUs available. Also, too, like, I think a lot of times, like, I feel like hospitals, when that time comes, they get extremely stressed out. Like, I think they need to like have like a breather. Like, I think at one hospital, like, they had like yoga sessions at lunch or something, just to get everyone's mind off of those questions, because sometimes the staff, like, they get stressed out. Or I've also seen too that some of the staff know more information than the managers do. Right? So the staff is more trained to do everything, because most of the managers in the department, they're managing other things. You know, they're fighting for capital equipment, they're in infection control meetings or whatever. So they haven't done the work in a while. So I would just say that education, competencies, departmental policies, procedures, make sure there's tracking information for your IFUs, and make sure that your staff can be able to speak and they're adhering to the policies. Not only can they speak to it, but they have to be following it as well.
Absolutely. Thank you, Zee, for your informative topics, and thanks everyone for joining us. See you tomorrow. I would like to thank everyone for joining us for the second day, and hope to see you tomorrow for the third day and the end date of the conference. I would like to make sure that everyone will be available at 8:40 a.m. UAE time. Thank you very much, and see you tomorrow.
I'll see you guys tomorrow.
See you
You're
tomorrow.
welcome.